So hi everyone, a very good evening and good afternoon after the exam to all of you. So first of all, let me know how was your exam and how did you do? How was the experience of the INICET paper? So let me hear from all of you first before we start talking about the exam and the radiology questions. I just want to know from you, those of you who've already joined in, how was the paper? So when I asked the students on the DAMS Telegram channel, so on the DAMS Telegram channel, we see most of the people are saying it was moderate to tough. So it is not like that everybody is saying easy. It's like very few people are saying easy. It is moderate to tough paper. And when we look at the percentage of PYQs and PYTs in the paper, most people are saying maybe around 40 to 50 questions were from previous year questions or previous year topics. Some people are going up to 60 also. So 60 to 70 we might actually believe. And we are very happy to see because it was a conceptual paper. Again, we can see that most of the students felt that regular class, DVT, Mission INICET, AIIMS Capsule were giving the direct hit rates in the paper. As usual, in every INICET paper, basic sciences are, have more questions as compared to clinical questions. Most people could just finish the paper. So that also tells us that it was all about the time management was not tough. And when we look at the other questions, most people have attempted between 180 above, 180 and above, 30, and some people have actually, a good number of people have attempted 190 and plus. First block was considered tough by most of the people. First block was considered tough by most of the people. So that was the, idea so far. So if I look at the paper from my perspective, it seems that anybody who had done the DAMS regular class or the DVT or the AIIMS capsule had an edge, had an edge. I'll tell you why I'm saying so. So one of the questions that you see in the paper was like this, and it was a patient with retrovirus positive, low grade fever, one episode of hemoptysis, and the question was saying most likely diagnosis. Now I want all of you now to look at the question and see, and if you remember, if you've attended my TND this year, it's almost like what we predicted. Trachea is central. Trachea is central. There is a opacity in the right upper zone. Can you let me know in the comments if you were agreeing here? Almost similar. Now, there's a opacity. Pneumothorax would have lucency. Pneumothorax ज़्यादा black हो गए तो opacity थी. So pneumothorax is not the answer. And abscess, if you remember from my class, I told you patient would have foul smelling sputum. ऐसा कुछ भी नहीं लिखा हुआ था. Foul smelling sputum नहीं था. Metastasis is unlikely to present with hemoptysis, and even if it does, you should see multiple round cannonball like nodules through both these sides. Remember, we discussed this in the class already. Metastasis होगा दोनों तरफ होगा ना, दोनों तरफ होगा. So this is immunocompromised patient and upper lobe problem with volume loss because the horizontal fissure is pulled up. That volume loss is because of fibrosis. Because of tuberculosis, you have fibrosis, that is secretizial collapse that has happened, and that is what is you see in the image. So answer was tuberculosis most likely. It is not hemoptysis. We can't go with metastasis as a single lesion. Remember, cannonball appearance was one of the discussions that we did at length in my classes. And this is the exact same image that we discussed in the TND this year. And I'm sure, this gives you the confidence that, we have a good strike rate in the paper. Second question that I'm very happy about is that we always predict is that either they will show you myasthenia gravis and thymoma, or they will say arm pain, tingling, and the vision problem that they will mention will be Horner syndrome, ptosis. Do you remember that? Do you remember? And I told you that if they show you in the upper lobe or in the apex, that will be Pankos tumor. Each one of my test and discussion session, we had a maybe 15-minute discussion on it. And we also discussed the role of MRI in this patient, and that we have to see the involvement of the neurovascular bundle, and then MRI would have been the answer to, go for the extent. But they changed the question, and this time they said, what is the definitive investigation for diagnosis? And obviously, and I'm sure, all the pathology teachers already have told you that जब भी definitive diagnosis करना होता है तो biopsy ही करनी पड़ेगी. Biopsy would be the best answer here because we are looking at a malignancy. We are not looking at tuberculosis, so you not do sputum microscopy. Ultrasound will not help you to diagnose, and nerve conduction velocities will not make a definitive diagnosis in this case. The answer will be CT guided biopsy in this particular question. And if you look at the discussion from my class this year, this is the class image, almost similar to what we got in the INICET. And I look at the history that I've written, ptosis, arm pain. So I'm very happy that we could predict the question exactly how it was supposed to be done, and exactly you got the question in the exam. And now what I'll do is we'll look at another question from the radiology indirectly. Here the baby had a term baby respiratory distress resolved spontaneously in the now if you can just let me know in the comments also. So the it resolved spontaneously, if you remember, in 2 hours, or it was within 48 hours that most people were able to answer in the recall that I did. So if you can now tell me what was the answer, transient tachypnea of the newborn, because if you remember in my class, in my lecture, I told you that the fissure will be thickened, and in the question also they said horizontal fissure is thickened, there will be sun ray like appearance. All of those is fitting into the answer that we are looking at in this particular question. Yes. Okay. And I think, yes, most of the people are agreeing that this was the question, and answer was transient tachypnea of the newborn. This is not respiratory distress, because if hyaline membrane disease there, the lungs will be collapsed, preterm baby, white out lung, air bronchogram, all those words would be there in the question. So the answer was transient tachypnea of the newborn. And this particular question, although I have taught in every one of my class, I'm very proud of it. A patient with trauma, 2 episodes of vomiting, unconscious. So the choices that students are getting confused between are, first choice is saying craniectomy. क्रेनिएक्टमी मतलब आप डिकम्प्रेशन करने के लिए स्कल का टुकड़ा काट के यू आर डिकम्प्रेसिंग द स्कल. So in extradural hemorrhage you do craniotomy. You do craniotomy. ठीक है, हम craniotomy करेंगे ना कि craniectomy. समझ पा रहे हैं? So then the better answer is burr hole and evacuation. So if you remember in the class also I told you, if craniotomy facilities are not available, you're in a rural setup or a peripheral setup, in EDH you will go with a burr hole with evacuation of hematoma. Burr hole with evacuation of hematoma. And if you go back to the AIIMS capsule this year, this is the image from the AIIMS capsule where directly I have mentioned that EDH will be asked, they will ask you the management, and the answer will be burr hole with evacuation of hematoma. The patient had a extradural. Patient had a extradural. So in EDH, why would you do a craniectomy? It is not the answer in the question as of the choices and the image that I have gotten from my recall so far. Another question that I see is okay. Another question that I see is 13-year-old patient, child with arm swelling, diaphyseal lesion, ESR is high, pain is there, neutrophils are mildly elevated. Now, when I see this question, and I am sure most of you would agree that there is some evidence of inflammation going on, there is some periosteal reaction visible in the shaft of the humerus. Many of you have marked biopsy as the answer, but I do not agree. Why would you do a biopsy straight away? Why not do a MRI first? अगर भाई आपको लग भी रहा है कि ट्यूमर है, मुझे लग रहा है ऑस्टियोमाइलिटिस हो सकता है कि इविंग्स इसको मैस्करेड कर रहा हो, बट देन व्हाई वुड यू डू? ओके, पहले मुझे बताओ व्हाई वुड यू डू अ बायोप्सी विदाउट डूइंग एमआरआई, है ना? तो लॉजिक कम है उसके अंदर. यू बिकॉज यू फर्स्ट वुड डू वांट टू इमेज इट फर्स्ट. अ बायोप्सी वुड डिस्टॉर्ट द इमेजिंग फाइंडिंग्स एज वेल. बायोप्सी के कारण आपका इमेजिंग कभी कभी डिस्टॉर्ट भी हो जाएगा, तो पहले एमआरआई करना पड़ेगा. And if you look back at the class, we have also discussed, whenever you have a patient with soft tissue swelling, osteomyelitis is suspected, do a MRI, look for bone marrow edema. This is straight from your back to basics. So do you agree or not? मतलब अगर चलो जो भी है यार, मतलब तो कोई बच्चा कह रहा है लाइटिक लीजन थे ह्यूमरस में, मैं मानता हूँ, लेकिन फिर भी क्या अभी इस न्यूट्रोफिल एलिवेशन है, ईएसआर बढ़ा हुआ है, स्वेलिंग, एमआरआई कर लेते हैं पहले, देन विल थिंक ऑफ बायोप्सी. हो सकता है उसके बाद करें, but the question is saying what will you do next? I would put the answer as MRI, and I want to tell you here, this is a question inspired by a previous question which has already been asked in the INICET in the past, and I know the answer is MRI. Okay, and this is the question that I am most proud of. This patient had a chronic abdominal pain, amylase lipase elevated with normal exocrine function of the pancreas. So lipase amylase increased is always in pancreatitis. So we know the enzyme pain and enzyme elevation, pancreatitis is the one that you're looking at. MRCP, you could see in the image, if I show you the image, on this MRCP, you can see that the pancreatic duct appears to open where you see the arrow mark. It appears to open above the opening of the CBD. It is opening in the minor papilla. The reason why it is opening in the minor papilla is because the patient has a pancreatic divisum. And if I now take you back to the image that we discussed in the class in the T&D session, I told you that if you see a pancreatic duct opening uh, above what the CBD is opening, so that is in the minor papilla, and you can then see a smaller pancreatic duct also, that is the ventral duct. The pancreatic divisum predisposes to pancreatitis was also. So the the image might be slightly different. By मरीज हर मरीज की image अलग हुई, but the logic and the topic and the language, everything I had predicted. सब कुछ मैंने सेम कहा था. मैंने बोला था अगली बार कोलेडोकल सिस्ट आ चुका है, अब कुछ नया पूछना पड़ेगा. दे लाइक आस्किंग एम्ब्रियोलॉजिकल थिंग्स. So choledochal cyst, you would have a dilated, maybe a bile duct seen in the image. If it is Carolis, you will see the intrahepatic choledochal cyst. This was pancreatic divisum in the image. The image, some people are saying image was not exactly the same. Images, you know, we may never be able to get the same image from the exam because, many times in INICET paper, the examiners use the images from their own clinical knowledge. They don't use it from internet. So sometimes here, we will not be able to. Annular pancreas, you should see a pancreatic duct encircling the second part of duodenum. So आपको क्या एक सर्कल में दिख रही थी डक्ट ड्यूडनम के आसपास? नहीं दिख रही थी. And that is why the answer is not annular pancreas. So the choices were choledochal cyst, pancreatic divisum, annular pancreas, chronic pancreatitis. I feel most likely answer was pancreatic divisum based on what I have seen in the images recalled by the students so far. And so this kind of tells you, and gallbladder is normal here is also telling you कि उसको pancreatitis है, लेकिन gallbladder normal है, इसका मतलब gallstone नहीं है. They are also trying to tell you कि the routine causes of pancreatitis like gallstones are not there. So that is the logic in the question, and image was almost same. I have seen with many students. This is the similar question in the paper. Okay, and this is the similar image that we discussed. I discussed a much better image in my class, but I would say I'm the only person who has predicted pancreatic divisum this year in the TND, and I'm very proud of it. I'm very proud of it, and I'm very happy. These are the 6 questions that we had. We talked about all of them in our regular classes, TND, and in the AIIMS capsule. And also, I feel that the paper is more of a moderate difficulty level. Okay. And then same beta, I told you right now, I think some बच्चा is asking about EDH. देखो EDH के अंदर मैंने बोला अगर craniotomy नहीं लिखा तो burr hole and evacuation mark करना है. This is there in your class notes. I've directly told you if it is extradural hemorrhage and the patient, you don't see craniotomy in the paper, then you need to mark a burr hole and evacuation, because in rural setting where craniotomy facilities are not there, you do a burr hole and evacuation. Okay. So craniectomy is done when you are doing decompression. So maybe you can read about craniectomy more. So these are the total 6 questions. For diaphyseal lesion, we'll do a MRI first before we biopsy. In pancreatitis predisposition, MRCP, think of pancreatic divisum. We discussed this in the class. So these were the 6 questions that we discussed. So I'm happy, and that once again, 25 years, never once we have missed on any question so far. So God bless all of you. And I'll ask now Dr. Deepti to come on board, and we'll discuss in 2 minutes. I'll ask her to come and discuss the gynae question.
Okay, so hi everyone and welcome everyone. Very good afternoon. I hope obs and gynae questions were good for everybody. So happy to say that yes, I've been able to collect all the questions and I'm going to show you the slides as well. Okay, so let's look at the first question. The first question said that your patient is having postpartum hemorrhage. Yes, and she is bleeding despite uterotonics. What is the next step? Okay, yes, is that correct? Is this the correct recall? So then, as per the protocol shown here and taught to you, if she is not responding to uterotonics and initial massage, then yes, the next best step is going to be balloon tamponade, right? So the answer for this question is going to be balloon tamponade. Okay, great. Okay, let's look at the next one. There was a question on placenta previa. The woman was 30 weeks. Slides nahi aa rahi. Okay. Is it okay now? Can you all hear me? Yes, I am back. So I said this was a question on placenta previa, right? 30 weeks, no fetal distress. She has come with mild bleeding. The blood pressure is normal. Yes, and next step is asked. So what is the answer? The answer is going to be admit and conservative management or expectant management. Yes, I hope it is audible now. I've just corrected the sound. Okay. Yes. So there is no indication for immediate termination. The patient is stable, the baby is stable, the bleeding is mild, the POG is less than 37 weeks, and therefore the answer here is going to be conservative management. Okay. Yes, this is only the second slide that I've done. The first one, the answer was, as I said, it is balloon tamponade. Okay. So these are the two questions that I have covered. So the first one is balloon tamponade. The second answer is yes, admit with expectant management or conservative management. Are we ready for the next one? Okay. So the next question was, what all are included in criteria for impending eclampsia? This is a question that I have always said, as it is a very predictable MCQ for this year for your exam. Whether it is about AIIMS capsule or your routine class or your TND, we have talked about this. Okay. So impending eclampsia, what all do you include? It was a multiple completion type question. So yes, you will include new onset headache. Okay. You will also include new onset visual disturbances. And you will also include epigastric pain, nausea, and vomiting. Persistent pedal edema is not a marker of impending eclampsia at all. No. Okay. Pedal edema can be physiological, and persistent pedal edema is not a criteria at all. Okay. Okay, if the question was accept, the answer is persistent pedal edema. It is not included. What I know was it was a question of multiple completion. So if it is multiple completion, we will include headache, epigastric pain, as well as visual disturbances. We will not include pedal edema. If it was all except, then the single answer is pedal edema. Okay, are you with me, everyone? Yes? Okay, so I'm going on to the next slide now. Yes? No, persistent leg edema is not a sign or symptom of impending eclampsia. Okay? We will not include it. It is not a inclusion criteria. Okay. Yes. So multiple completion. So 3 will be right. New onset headache, new onset visual disturbances, and epigastric pain. Okay. Let's go on to the next question. So the next question was on uterine inversion, and there were 4 statements about shock, and you were asked to pick one of them. Yes, or was it multiple completion? So even if it was multiple completion, then let's see what are the options I get. But yes, the answer is neurogenic shock. Yes, so it is a neurogenic shock initially. Only later it will convert into a hemorrhagic shock. Yes? Okay. Please remember it is not a septic shock or not with severe blood loss initially. In fact, initially the blood loss is out of proportion to shock. The patient is in shock, but initial blood loss is not much. Yes, so single best is going to be neurogenic shock. Okay, neurogenic shock. Perfect. Okay, so we will go on to the next one. That's what I have shown here as well. So yes, single best answer, neurogenic shock. Okay, next. This is where I would say there is a little controversy depending on how the question was framed. Definitely, yes, when we say postpartum IUD, as you can see in the slide where I have taught, it is within 48 hours of delivery. Yes, so then you call it as postpartum. But I think in the question, it also said the ideal time. Yes, so when you talk about the best or the ideal time, as early as possible becomes best. But so within 10 minutes may be a better answer. But what is the problem? The problem is that Government of India guidelines use different terms. So they say within 10 minutes, the GOI uses, yes, the GOI uses it as post-placental. Okay. Whereas within 48 hours is what is postpartum. So yes, 24 to 48 hours is in that time frame. It is still within 48 hours. But because they are asking ideal, yes, then sometimes with the ideal, we actually say the best is the immediate one that we use. So that's why I said it's controversy because they're using 2 different terms. One, they said ideal, and based on that, the earlier the better. So then it is post placental, yes, as it is within 10 minutes. Okay. But as I said, GOI uses different terms. So when they say within 10 minutes, the term they use is post placental. Typically speaking, postpartum they use when it is within 48 hours. So 24 to 48 hours is in that time frame. So as of now, because you people are saying the question had the word ideal, I will go with, within 10 minutes. The earlier you put it, the better it is. Okay. Yes, is that okay? All right. Yes, I understand. It did say postpartum, but it also said ideal. So both, that's why I'm saying this is the one which I feel will depend on what the examiner is going to ask, right? But ideal, as I said, is the earliest one that you will put when you talk about postpartum. Okay. And yes, anywhere between first 48 hours. Okay. Chalo, let's look at this one. So there was a 45-year-old woman who had an endometrial thickness of 15 mm, right, and abnormal bleeding. So please remember, I have always taught this in the guidelines. If the patient is more than or equal to 45 years and she has abnormal bleeding, irrespective of endometrial thickness, the answer has to be endometrial sampling, which means we will have to go ahead and do an endometrial biopsy. Okay, so the answer here would be endometrial biopsy. Yes. Okay. Yes. After placental expulsion, I am not sure because that nobody has told me that the word after placental expulsion is said or not. But then, as I said, within 10 minutes is again after placental expulsion. So within 10 minutes of placental expulsion, that would be the ideal because it is earliest. Okay. Next, you got a question on AGUS, again directly from your class notes, atypical glandular cells. So when the patient is 35 years or older, which was the case in your exams. So yes, you have to do a colpo biopsy and you also have to do a endometrial biopsy. Okay. So colpo biopsy along with endometrial biopsy both have to be done. Okay. Okay. Which word is not there? Okay. So anytime if we talk about beyond 45 years and this thick in endometrium, yes, you have to do an endometrial biopsy. Okay. Next question was a question on white plaques. Yes, itching and thinning of epithelium, classically taught to you in class as lichen sclerosis, and also taught to you that it is a risk factor for vulval cancer. So this is from the topic on vulval cancer. Yes, so it is a chronic inflammatory condition which leads to thinning of the epidermis, whitish colored plaques, and yes, there is itching. So the answer is lichen sclerosis. It is not lichen planus and it is not VIN. Okay, vulval intraepithelial neoplasia. It will be lichen sclerosis. Yes. The classic histopath finding being absent rete ridges. Yes, yes, that's right. Yes, yes, yes. I specially use this word that if you take a biopsy, you will see absent rete ridges. So I am glad if those keywords have stuck to you. Yes, there is a reason why we speak those things in class because we want you to connect the dots. Yes, that's why, I would concise but always talk to you about the keyword. So everything fits in and the diagnosis is lichen sclerosis. Okay, next one was very easy for everybody. So the image was given and the answer is strawberry cervix related to Trichomonas vaginalis. Yes, so this we all know. It is Trichomonas vaginalis, and I think the diagnosis was asked, not treatment, nothing, no kit related things. Usually they ask kit related things, but here it was diagnosis. Okay. Next, please remember again directly from your class notes, every single line that I write, even if it is like half a line like you see here, has been asked in exam. So you got a question on ovarian reserve and you were asked which is not a test of ovarian reserve. Okay, so I've clearly written serum E2 by itself is not a test of ovarian reserve. It is sometimes combined with FSH, but by itself, it is not a test. This is a question I always give in my TNDs as well. So please remember, serum E2 levels is not directly a test of ovarian reserve. It was a single best answer, and that is the answer. The other options were antral follicle count, FSH, and AMH levels. Okay, right? So FSH levels, AMH levels, as well as antral follicle count, they were all in the options. Okay. So early cycle E2, it doesn't matter what they write. E2 by itself is not a test of ovarian reserve. It is just done to analyze the FSH levels. Yes. Okay. Direct question from DQB from your PYQ section. Yes. So again, I had this time specially given targets for solving my OBG PYQs from DQB, and I gave them in slots of 50-50, and I ensured everyone was doing these questions close to exam. Okay, so please remember, it is exactly the same question. Instruments used for cesarean section, and it is a multiple completion type question, right? These were the options. The options are also same, and as you can see, the answer is A, which means green armitage. So in option A, we have included A, B, D, and G. So green armitage used, Ali's forceps used. Okay, so A, B, Doyen's retractor, ABD used, and G is scalpel. It is also used. Yes, yes, it's a direct question from DQB PYQ sections, and I made you solve them close to the exam. Okay, Shirodkar's retractor is not used for cesarean sections. It is used for deep vaginal surgeries. Okay, Carmen's you all know are not used, right? Okay, perfect. So I think those were the questions that we have. Okay. Any other recalls that you, I think this time we have only around 10 or 11 questions in Obs and Gynae, and that's sad, but, but it's okay. As long you get all of these correct, I am happy for you, right? Do you have any other recalls which you feel have not been covered? Please let me know. I've already shared all the screenshots as well. But anything, if you feel there is more, do let us know, okay? No, bache, no question was different. I understand sometimes we're in a defense mode, okay? And sometimes the recall is a problem, okay? No, Shirodkar's retractor is not used in cesarean sections routinely, okay? It was a multiple completion. I have shown the image as well. So A, B, D, G, green Armitage, Alice forceps, Doyen retractor, and the scalpel. Okay, no Casco's speculum, no Shirodkar's retractor, no Carmen's cannula. Okay, is that clear? Okay, they're saying there was a question on endometrial histology. Can you tell me what that question is? Because I haven't got it in the recalls from what I have done. Alice and green Armitage both are used, baby. Okay. So yes, anybody can recall the question on endometrial histology? Yes? All right, which is not included in STD kits. Again, I do not have that recall. Maybe you people have given it to the derma faculty because it is actually a derma recall. So yes, do let me know the question on STD kits. Let's see. Otherwise, the derma faculty will definitely clear it. Okay. Perfect. So wishing you all the best, everybody, and we will be doing a yes quick recall. Yes, not 15 centimeters. It was 15 mm. Okay, and that is also even if it is 15 centimeters, it doesn't make a difference. The answer will remain as endometrial sampling. Okay, so बहुत ज़्यादा ओके क्वेश्चन इज कौन से सिम्टम के लिए एसटीडी किट नहीं देते राइट सो डू लेट अस नो द ऑप्शंस बट आई एम श्योर द डर्मा फैकल्टी विल clear it okay so here is wishing you all the best everybody I wish you really come out with flying colors I hope the exam gives you new opportunities and we are waiting for you on the other side lots of good wishes to everybody out there may it be the best one for everyone okay so the next teacher would be here very soon in the same session. Okay, I am really, really grateful as long as you people are happy with what we are doing for you. Thank you so much. It means a lot. Yes, the notes are very, very high yielding and usually I just hope nothing comes out even in NEETPG exams. Right? Chalo, let's do the next question now. Okay, next subject now. Okay.
Okay, so okay, can all of you give me a quick thumbs up if my audio video is clear? Am I audible and visible? Can you all give me a quick thumbs up? Okay, so good evening, all of you. Good evening, and let's very quickly complete our dermatology recalls. So, how was your paper? Can you tell me, like, in brief? Although I have got around 6 questions from dermatology, if you have any more questions, please do let me know in between. And I have not actually found all the options of all the questions. Chalo ji, chalo. Correct, correct. So let's go and discuss the first question, Bacho. The first question which I got was this question. that match the disease with the sign. I've got the three options here. The first option was psoriasis, and you have to match it with the sign, and that is the OSPIT sign. I think it's very easy and clear. We have discussed in the class that in psoriasis patient, we take a scaly plaque and we rub it with a glass light. It is a step-by-step procedure where in step 1 we rub these scales and the scale becomes more prominent. In step 2 we remove these scales and we see Bulkeley's membrane, and in step 3 we remove the membrane and we get a pinpoint bleeding spot. Okay, the next option which I was told by the students is about the flag sign. If you remember, in our nutrition I told you that the kwashiorkor has some skin lesions as well as hair conditions. On skin you get the parchment like skin, or there is a peeling of skin which is known as scaly pain dermatosis, while on the hair you see alternate discoloration of the hair, and that is known as flag sign. That was also told to you in your pediatric classes. Now, what is this carpet sign? I hope you know this, bacho. In DLE, what you have is this is the skin. The part from where these scales are coming out or the hairs are coming out, from that area, the scale actually enter inside the skin like this. Okay, so this invagination or this lower extension of the scales into the hair follicle, that is known as carpet tuck sign. So if I remove this scale, what I will notice that there are some perpendicular projections which are coming out from the undersurface of the scale. This is known as carpet tuck sign, and students are telling me that option number 4 was the mastocytosis and the Derriere sign. So what is the Derriere sign of mastocytosis, bacho? First of all, what is mastocytosis? It is the collection of mast cell into the skin. So normally also we have mast cell in our dermis, but sometimes the number of mast cell increases a lot, and that collection of mast cell is known as mastocytosis. Now what is this Derriere sign, bacho? Whenever you stroke the lesion of the mastocytosis, you have hyperpigmented patches. Whenever you stroke those areas, that particular area, the mast cell will degranulate and that will form a wheal. We have covered this in our back to basic classes. You can just go and see the mastocytosis and the Derriere sign. I hope this is clear to all of you, bacho. Okay, so psoriasis, OSPIT sign, also Derriere's and mastocytosis. I don't know what was the exact option given, whether you have to match all of them or whether they are asking you which is the correct option. So please check this, bacho. Derriere sign is for mastocytosis. DLE, carpet sign. Carpet tuck sign is also another name. Kwashiorkor, it is flag sign, and for psoriasis it is the OSPIT sign. So these are the options which you have to match. Okay, chalo. So psoriasis and OSPIT sign was not given. So can you tell me what was the fourth option, bacho? Okay, okay. No option matching psoriasis and OSPIT was given. Okay, correct, correct. Now, this is the second option, the syndromic approach. Which of the following is not used? Now, bacho, the syndromic management of STD, you remember that we have recently added total 8 kit in STD. Previously, we were having 7 kits. Kit number 1 is for urethral discharge and endocervicitis. Kit number 2 is vaginal discharge. 3, 4 and 5, they are all for genital ulcers, where 3 and 4 is for non-herpetic genital ulcer, while 5 is for herpetic genital ulcer. 6 is for pelvic inflammatory disease. 7 is for bubo, and 8 is for anorectal discharge syndrome. Bacho, there are 2 STDs which are not, there are 2 kit which make no sense in a men. One is the vaginal discharge kit, but that is obviously not given in the question. Second is, please remember, it is the lower abdominal pain, which is the PID. So answer of this question should be option number 3, lower abdominal pain or PID, pelvic inflammatory disease. That syndromic approach has no role in a men. Urethritis, yes, definitely urethritis. Anorectal discharge, I was told that anorectal discharge was the second option. That definitely makes sense, especially in male having sex with male. Inguinal swelling, that is bubo, that is a characteristic presentation of LGV, chancroid. So other than lower abdominal pain, please remember, bacho, it should not, the lower abdominal pain and vaginal discharge, that does not make any sense in a men. Okay, so please remember that was the second question which we got. Now the next option is most common site of melanoma in skin. Now, Bacho, I told in the class that melanoma or in general, all the skin cancers, they are more common. In general, the skin cancers are more common in sun exposed areas. But there is an exception, and that is melanoma, the lower limb or the acral part, I would say. So, if there is an option which says acral, that would be the best option. So, according to me, the palm sole or the acral part, if it is given, that should be the correct. Seshna, you can tell me what is the option for psoriasis and what was the option for Auspitz in that particular question, okay? So please remember that it should be according to me. See, if you see in Indians, acral, that is the lower limb, followed by trunk. It should be the best option. Face is common in white skin individuals, so I will put it third. So that should be the sequence of the most common site of melanoma in Indians. So according to me, hands and feet or limb should be the correct option. The lower limb or the sole is actually the most common site compared to even the palm, but not that option was given. So it should be option number 2 for the most common site of melanoma in Indians. Coming to next, I think this must be discussed by Deepthi ma'am also, because it's a gynae question. They have given an image, a very classical image of strawberry cervix, and they've asked you which organism causes this. I think this is a very easy question. Trichomonas vaginalis should be the answer. It is trichomoniasis, very classical greenish frothy discharge. Along with that, there is inflammation of the cervix, and that is how we make the diagnosis. This image, I don't know whether this was the correct image given in the question or not. Now, this is another question. Again, I'm not sure of the image, but the question which was told to me was that there is a rash on the thigh. Okay, there is a rash on the thigh which appears on the same site and it is recurrent. So there is one rash which is coming again and again, and the site is same. What history will you take? Now, I don't know whether they have given you the diagnosis, but it should be a very classical fixed drug eruption, which is a drug reaction. And if you remember in the class, I told you that whether the patient take that drug immediately or whether the patient take that drug again after few months or few years, the site of rash is exactly the same. So please remember, the fixed drug eruption, it is the site which occurs always, it is same in that particular patient. So you have to take the history of drug. So that was the question, I think. Number 3, it was given HSV, herpes simplex virus. Again, on the thigh, HSV, it doesn't make much sense. But yes, if they have given some vesicular eruptions, then it could be a HSV reaction. But again, the same site, I would not say that will go more in favor of herpes simplex virus. It do occurs on the mucocutaneous junction, but not always on the same site. So if there is no drug reaction given, if there is nothing related to drug reaction given, then HSV becomes the best option. But I was told that drug history was given in the question. Some students told me that a diagnosis of FDE was given in the question. So I don't know what was given in that particular question, bacho. Ek option, small vessel vasculitis. So option number 4, small vessel vasculitis. Again, I would say that if it is small vessel vasculitis, it should not occur always on the same site. It can occur on any site where you have small vessels. So if they have given drug, then the drug reaction would be the first option. If the drug is not given, bacho, then herpes simplex virus can again be a good question because, or good option, because the recurrence is common in herpes. And if it is herpes genitalis, it always occurs on the mucocutaneous junction. For that, we need an image. For herpes, it should be vesicle, grouped vesicles which are present at the mucocutaneous junction. Okay, so some students are saying that drug option was given. If the drug is given, that should be the best answer. Okay, chalo. This is again another question, more of a gynae question. There is a white patch in a 60-year-old female which is associated with thinning and itching, and there is absence of rete ridges. Please remember, bacho, this is a very classical description of lichen sclerosis. In lichen sclerosis, which is actually a pre-malignant condition which can convert into the malignancy, there is thinning or atrophy of the skin. The skin becomes very white or very fine, very thin, and the classical complaint with which the patient come to us is itching. When you examine the patient, you see that the skin is very thin, like a cigarette paper. Sometimes you can even see presence of secondary scarring, or you can even see that there is blood because of frequent itching of that area. When you do the biopsy, there is atrophy, and that is by the absence of rete ridges. I think that was also given in the question, bacho. So for this question, the answer becomes lichen sclerosis. Lichen planus, it should be bluish purple. There should be white lacy line, which is known as Wickham's triad. Nothing like that was given in the question. And what is VIN? That is the vaginal intraepithelium neoplasm. Again, that should not be the option here. The best answer should be lichen sclerosus. Bacho, is there any option 4? I have no idea what was option number 4 given in this. Okay. Okay. So lichen sclerosus was the correct answer for this question. So these were the only questions which I got from the students. Bacho, can you tell me any more questions? Anything from hair disorder or anything from psoriasis, nutritional deficiencies? Anything was given? Okay, candidiasis was given in which of the following question, Bacho? Okay. So I think they are saying that candidiasis, but there was a question. Prithvi, can you tell me what was the question on candida? Acha, in this question, you are saying that candida was 4th option. Okay. See, again in candidiasis, what will be the clinical feature? In candidiasis, the clinical feature is there should be curdy white discharge. Itching will be present, but there should be discharge, which is curdy white discharge. But nothing like that is given in the question or mentioned in the question. Plus, this absence of reteriges, atrophy and thinning of the skin or that mucosal area will not be a feature of candidiasis. So that should not be the answer. Okay. Chalo. So, acha, here option number 4 is mastocytosis. That's what students are saying. Anyways, bacho, so these were some of the questions which we got from the dermatology. If you get any more questions, please try to write it on the chat section. You can share it on the Telegram so that I can add the questions and make a final presentation. Thank you all of you, bacho. Bye-bye.
Hi everyone. Alright, hi everyone. Dr. Saurabh here. Hi, so I hope you have been able to solve the questions. Some subjects I've been told are very tricky, but I don't think so. I've got 7 questions. Usually 8 questions come from ophthalmology. That's a standard 8 to 10. I've got 7 questions. I hope you're able to solve. Saurabh here. Hi, so it's very noisy because it's Sunday and there was an exam. That's why it's very noisy. Sorry about that. Let's see the first and let me know. This is a recall. I'm able to recall from my group and other students, and just know that whether the questions are correct or not. Then I'll give you the answer, and the correct then question I'll compile and give you tomorrow. The first question was this: any patient came with sudden onset of severe eye pain, headache, blurred vision, colored halos, and mid-dilated pupil. This was a clinching point that there was a mid-dilated pupil. There was no doubt in that. And hazy cornea, high intraocular pressure. This was the question, and was these the options? Let me know. Phacomorphic glaucoma was in the option. Okay, I will check for that. So which one was not there? I hope you can tell the answer, because this is a repeat question asked many times, even in FMGE exam, NEET exam. Answer is acute primary angle closure. IOP was 60 millimeters. Okay, fine. So which option was not there? This option was there, I think. Entry uveitis, secondary glaucoma was there, but that is not the answer, because it should be small constricted pupil in entry uveitis. Phacomorphic glaucoma was in the option. IOP 60. Okay, fine. What else? Same question. Cellulitis was not there. Okay, fine, good. Thank you very much. So this was there. Phacomorphic glaucoma was there. Endophthalmitis was there. Secondary glaucoma due to हो गया ना? Secondary glaucoma due to entry uveitis was there. ठीक है. और कुछ? C was हो गया ना? C or cellulitis was not there. ठीक है. D is the answer. I don't think so. There is any doubt in this. Acute angle closure is a very hot topic. Acute red eye, acute hot topic. Noisy topic like today. So there was no doubt in this. I hope you should know that this is I should not tell that it has been asked multiple times in any exam, and opthal exam, whether it's a grand test or a INICET, FMGE or a NEET exam, acute red eye question is mandatory. And an acute red eye, there are very few examples of acute emergency in ophthalmology. Acute angle closure is one of them. Open angle glaucoma was an option. No, nobody have told you this. Nobody told open angle glaucoma was in the option, because open angle glaucoma, acute red eye बनता नहीं है बात. Manish Reddy, I know that यार, it's okay. I hope you are able to. मैं देखा अपने आप को, सुना मैंने. Acute angle closure is still okay. I am audible. So first question, I don't think so there is any doubt. Okay. Taken multiple times in many classes. Now I hope, let us see the second question, because second question was, there are two images which I was told, and one was this image with some ring-like opacity in the cornea, and patient was having painful blurred vision, photophobia, and contact lens was given. Yeah, dirty water washing was not given, but slit lamp picture was given. Steamy cornea, why not uveitis? Steamy cornea means hazy cornea that can be in any intraocular pressure high, and why not uveitis? AK007 आपका नाम है, तो small constricted people should be there in anteruveitis, not mid dilated people. So this is a correct image. Very good, thank you very much. And you people have also, you people have given me this image. मैंने exam नहीं दिया इस बारी, मैं भूल गया देना. So what is the stain used? What is the question? The question is ring infiltrates, and this is a acanth amoeba keratitis. And I hope these were the four options. There was a stain. What stain is used for this acanth amoeba? That was the question. And I don't think so there is any doubt in this. The answer has to be calcifer. See, in my class also I have given a similar picture, ring infiltrates. Ring infiltrates was a FMG question of July. So same FMG, NEET, INICET, they are repeating. Two questions are given, two were repeat in last exam. Non-nutrient E. coli is a very important culture, but two stains, acridine orange and calcifer white, are the two stains. अब वो आएगा myopic astigmatism, not zinc, it was Zeal Nelson. Okay, fine, it was Zeal Nelson. क्योंकि बाकी ऑप्शन भी जानने जरूरी है ना, इसलिए रिकॉल सेशन होता है. हिस्टोपैथ फॉर ऑल्सो गिवन. अरे नहीं, वो पैथो क्वेश्चन आप करो. यूज था, मिसयूज नहीं था. मिसयूज कहाँ लिखा मैंने? कहीं लिखा मिसयूज मैंने? या फाइन. Alright, so second question also. ठीक है, ऑडियो क्वालिटी बैड है मुझे पता है, क्योंकि है कुछ, आई एम नॉट एबल टू टेक द क्लास फ्रॉम द प्लेस वेयर आई यूज्ड टू टेक, बट ठीक है, इट्स ओके. उससे आंसर नहीं बदल जाएगा. आंसर कैल्क्यूफर वाइट. हाँ, सूडोम. वाई सूडोमोनास? राइट, बिकॉज कैसे सर इसमें लिखा नहीं था कि टैप गंदे पानी से वॉश किया है, टैप वाटर और डर्टी वाटर. ऑलवेज इट इज नॉट नेसेसरी दैट डर्टी वाटर से वॉश करें तभी कैंथामीबा. This picture was very important. The picture is showing ring infiltrates, and ring infiltrates means it's a acanthamoeba, and that is a similar picture which is given in the workbook as well. If you have attended the class or any TNDs or anything, ring infiltrates means acanthamoeba, and for that calcifer should be the answer. Okay, chalo. Third question. Third is a straightforward. Just let me know the options. The question was, Krukenberg spindles are seen in which condition? I hope this was the question, third one. हाँ, मैं रोड पे ही हूँ, रोड पे ही सोता हूँ एक्चुअली. Krukenberg spindles are seen in which condition? The answer is straightforward, that is pigmentary glaucoma. I want to know the other options are okay or not. Pigmentary glaucoma is a very important question. I tell in the class also. Young male की कहानी है. Young myopic male comes after exercise. Exercise करके high pressure हो जाता है. Pigments are spread all over the eyeball. Reverse glaucoma. What are Krukenberg spindles? Are pigments on the posterior surface of the cornea. That is seen in pigmentary glaucoma. A child with visual acuity आएगा भाई. Child moody Mandy. Child आ जाएगा अभी. वो भी मुझे पता है. आप लोगों ने दिए. तो I don't think so any other malignant glaucoma was in the option. Acute angle closure, neovascular glaucoma, इसमें किसी में Krukenberg spindles नहीं मिलता. या एक ने juvenile glaucoma बोला था. One said juvenile glaucoma, but other said that juvenile was not the option. It was malignant glaucoma was in the options. हाँ, तो इट वाज अ कीर्थना डायरेक्ट क्वेश्चन, बट अगर आपने पढ़ा हो तभी डायरेक्ट होता है, तभी इट्स डायरेक्ट, बिकॉज इफ यू हैव रेड देन इट इज डायरेक्ट। देखो मैं तो आराम से बैठा था यहाँ पे, देखो आराम से मैंने समझाया था कि पूछा था, एक्चुअली क्लास में हमेशा पूछता हूँ कि क्यों यंग माइक्रो ने क्या किया होगा ऐसा कि उसका एक्सरसाइज करने के बाद प्रेशर बढ़ गया। इसमें तो काफी टाइम है, 5 मिनट देता हूँ सोचने के लिए। कोई मुझे डायरेक्ट, कोई कहता है उल्टा खड़ा हो गया, कोई कहता है स्टेरॉइड खा लिए, तो बाद में उनको समझ आता है कि आयरिस पिगमेंट्स ब्लॉक होते हैं, आयरिस पिगमेंट्स पीछे कॉर्निया पे चिपक भी तो सकते हैं, एंड दैट इज द क्रूगेनबर्ग स्पिंडल्स, एंड दैट इज अ ट्रायड आल्सो इन पिगमेंटरी ग्लाकोमा। Open angle was one option. Okay, I will open angle glaucoma was a non option. I will check with the students in my group whether किसको निकालें कि open angle glaucoma को घुसड़े। Juvenile glaucoma भी ऑप्शन में था, बट आंसर तो पिगमेंटरी है, उसमें तो कोई डाउट नहीं है, बट आई विल सी which options is not there. ठीक है, ओके, आंसर इज पिगमेंटरी ग्लाकोमा, इसमें कोई डाउट नहीं है। ठीक है, आ गया चाइल्ड, आ गया, लो आपका चाइल्ड आ गया, मूडी जी। ध्रुव राठी भी है यहाँ पे, ध्रुव राठी। ऑल आर यूज्ड इन विजुअल एक्टिंग इन अ प्री वर्बल। प्री वर्बल का मतलब क्या है? एज नहीं दी। प्री वर्बल कैन बी एनीथिंग वी इज नॉट एबल टू स्पीक। तो एक तो आपको पता होना चाहिए कि विजुअल टेस्टिंग इन ए चाइल्ड में हम टेलर्स चार्ट यूज करते हैं, इट्स अ प्रेफरेंशियल एक्यूरेट। एक ऑप्टोकिनेटिक डिस्टैग्मस ड्रम यूज करते हैं, ड्रम घुमाओ, देयर इज एन डिस्टैग्मस। इसमें पेशेंट को पूछने, बच्चे को पूछने का जरूरत नहीं है, वी डोंट हैव टू आस्क द चाइल्ड। सो दीज टू ऑप्शंस आर देयर, टेलर्स एंड ओके एंड ड्रम। नाउ द थिंग इज ETDRS एंड लैंडोल्ड्स। अब इसमें से क्या चूज करें? अब देखो ना ध्यान से, अब लैंडोल्ड्स एंड ETDRS में इस किसको बोलना, पेशेंट को बोलना पड़ेगा ना कि H है, V है, Z है। इसमें तो ही कैन टेल द डायरेक्शन ऑफ द C, डायरेक्शन ऑफ द E ऑल्सो। तो लैंडोल्ड E चार्ट, C चार्ट कैन बी डन इन प्री वर्बल अमंग द ऑप्शंस, बिकॉज ही कैन टेल द डायरेक्शन ना, डायरेक्शन यहाँ पे है, वहां पे है, डायरेक्शन तो कर सकते हैं ना बच्चा। प्री वर्बल है, एज नहीं दी, डायरेक्शन तो कर सकते हैं, बट इसके लिए तो प्री वर्बल ही हैज टू टेल इन इट, यू शुड नो व्हाट इज ETDRS। कैसे, क्यों पता होना चाहिए? बिकॉज ETDRS इज अ रिपीट क्वेश्चन ऑफ INICET, फुल फॉर्म आया था। और हम क्लास में कितनी बार बताता हूँ, एम्ब्लोपिक लिए स्नेलन चार्ट इज ओवर एस्टिमेटिंग, सो आंसर हैज टू बी ETDRS इन द क्वेश्चन। हाँ, तो एक्सेप्ट ही तो है जो मैडम पर्पल लव का नाम है आपका, तो उसमें ETDRS ही ऑप्शन आएगा। अच्छा, ये कह रहे हैं मल्टीपल चॉइस क्वेश्चन था, तो मल्टीपल आंसर थे। ओके ओके, बट आंसर तो लैंडोल्ड्स कर सकते हैं यार, ठीक है। ओके एंड ड्रम इज नॉट यूज्ड, टेलर्स इज नॉट यूज्ड, मतलब टेलर्स इज यूज्ड, टेलर्स इज यूज्ड, ए इज यूज्ड, एंड लैंडोल्ड C चार्ट भी यूज कर सकते हैं ना प्री वर्बल में, ही कैन टेल द डायरेक्शन। एज नहीं दिए, एज दिया था क्या मुझे बताओ? अगर एज दिया था तो फिर मैं चेंज कर देता हूं आंसर अपना। इट वाज अ मल्टीपल, ओके, इट वाज अ मल्टीपल आंसर क्वेश्चन, सो ये भी मुझे अब देखना पड़ेगा कि और एज क्या था, और उसमें ए बी ऐसा क्या था। मल्टीपल करेक्ट ऑप्शन विद कॉम्बिनेशन ऑफ 2 चॉइसेस, ओके फाइन। तो अब कॉम्बिनेशन ऑफ 2 चॉइस हैं, तो ये तो मुझे ऑप्शन आप बताओगे तभी तो पता लगेगा, अभी तक तो किसी ने बताया नहीं। जैसे मैंने कहा ना, मैंने एग्जाम नहीं दिया इस बारी, मैं भूल गया, मैं फॉर्म फिल करना भूल गया था, सॉरी। एक्सेप्ट वाज नॉट देयर, तो ये कह रहे एक्सेप्ट नहीं था, सिर्फ पूछा था ऑल आर यूज्ड इन विजुअल एक्टिंग प्री वर्बल। अच्छा, ए ऑल आर यूज्ड, तो फिर तो हो जाएगा ना आंसर, ए यूज हो जाएगा, सी यूज हो जाएगा, और अगर ऐसा ऑप्शन था ACD तो वो यूज हो जाएगा। और अगर सिर्फ 2 ही ऑप्शन का था तो फिर तो बेस्ट आंसर A और C है, फिर तो कोई डाउट ही नहीं है, फिर तो ये लो डायरेक्ट, फिर तो ए टेलर्स एंड ओके एंड ड्रम हो जाएगा। अगर 2 ऑप्शंस का सवाल था, हाँ मोहिंदर प्रीत सही कह रहे हैं, ACD सही हो जाएगा। अगर ऑप्शन ACD थे तो वही, अगर वो 3 ऑप्शंस वाज नॉट देयर देन द आंसर, बेस्ट आंसर विल बी A and C। अब ये आप देख लेना आपका कैसा एग्जाम में सवाल आया था, बट लैंडोल्ड्स कैन बी यूज्ड इन सेम क्वेश्चन था, तो लैंडोल्ड्स कैन बी यूज्ड, ठीक है। Okay, fine. Okay, Shan Single, fine. Okay, now a very good question. Which was there. A patient of myopic astigmatism was there, present with acute red eye, and same question था मेरे ख्याल से. History significant or eye rubbing and frequent change of glasses. Now everything is pointing towards keratoconus. Age नहीं दिया था. Everything is pointing, but answer is not keratoconus. Answer is it. Direct question is, this is the question which I gave in my workbook this time. Because it is in my nephrology book also. Same question जिसमें लिखा है कि पेशेंट को वही लुकिंग डाउन पे मंसन साइन है, बल्जिंग इन द लोअर आईलिड, रेटिनोस्कोपी, रिसीजिंग रिफ्लेक्स, But answer is not keratoconus. It is acute, because the only reason of pain and hazy acute red eye in keratoconus is acute eye drops. So answer is acute eye drops in keratoconus. And acute eye drops का मतलब है डेस्पेंट मेम्ब्रेन रप्चर हो जाती है. तो पहले तो डायग्नोस करना है कि केराटोकोनस है. फिर एक पोस्ट ऑफ पिक्चर दी थी जिसमें गैस बबल था, सिमिलर, नॉट सेम बट सिमिलर पिक्चर वाज देयर. बट दिस इज नॉट क्रॉस लिंकिंग. वो तो एक्यूट हाइड्रो में नहीं करते. एक्यूट हाइड्रो में डीएल के डीएसई का मतलब ही नहीं है. अगर आप देखो डीएसई का फुल फॉर्म अगर आपको पता हो, क्लास में बताया हुआ है, एंडोथेलियम डैमेज में करते हैं. एंड डीएल के व्हेन ओनली द स्ट्रोमा, इसमें तो डेस्पेंट रप्चर हो गया. इसमें तो डीएल के डीएसई के का मतलब ही नहीं है. और C3R का पिक्चर नहीं है. C3R तो प्रोसीजर है. तो इसमें गैस डाला हुआ है, C3F8 इंजेक्शन, दैट इज डन इन एक्यूट हाई ड्रॉप्स. इसमें कोई डाउट है तो मुझे बताओ. अच्छा, उसमें इन्फेंट मेंशन था, ठीक है, मैं इन्फेंट कर दूंगा. ओके फाइन, थैंक यू फॉर दैट. ठीक है. सो एनी डाउट इन दिस? Was it the similar question or the options were different? अच्छा, I want to know this कि have they given the full form of DACK or short form DACK? I don't expect them to give a short form DACK DLK like this. Please let me know this. With riboflavin was okay fine. एक ही मतलब हो गया, riboflavin से करते हैं. Please let me know. नहीं, ऑप्शंस वर देयर, बट डीएसई के शॉर्ट फॉर्म डिड दे यूज और दे यूज द फुल शॉर्ट फॉर्म? बहुत ही गलत बात है. आईएनआईसीटी वालों को लेटर चिट्ठी लिखूंगा उनको मैं. हाउ कैन दे एक्सपेक्ट अ शॉर्ट फॉर्म लाइक दिस? शॉर्ट फॉर्म नहीं लिखना चाहिए कभी भी एग्जाम में. दे शुड नॉट गिव यू शॉर्ट फॉर्म, दे विल गिव यू फुल फॉर्म. गलत बात है. चिट्ठी लिखेंगे सब मिलके उनको. ये क्या तरीका है? शॉर्ट फॉर्म नहीं लिखना चाहिए. ठीक है. तो इसका आंसर तो इंट्राकैमरल मतलब क्या होता है? एंट्री चेंबर में वो बबल दिख रहा था आपको, वो बबल दिख रहा था, तो वहीं से भी आंसर हो सकता था यार, गैस इंजेक्शन डाला हुआ है. बट एक्यूट हाई ड्रॉप्स, केराटोकोनस नहीं था, एक्यूट हाई ड्रॉप्स आए. अच्छा चलो. एंड आई वांट यू टू नो दिस बिकॉज आई हैव नॉट गॉट दिस क्वेश्चन फ्रॉम एनीवन. इवन इन माय ग्रुप दे हैव जस्ट मेंशन्ड हॉर्नर सिंड्रोम, दे हैव नॉट मेंशन्ड एनीथिंग एल्स. तो हॉर्नर सिंड्रोम क्वेश्चन वाज देयर एंड देयर वाज अ लॉस ऑफ स्वेटिंग. Which structure was it? ऐसे ही क्वेश्चन था या कुछ और था? Let me know please. Because अगर ऐसे ही था, Horner syndrome question, decrease in sympathetic activity, and there was loss of sweating. Loss of sweating means the lesion has to be before the ganglion, because after the ganglion, sweating is normal. Sweating is not present in post ganglion. तो एक तो सिंपैथेटिक चेन, ओके ठीक है, सिंपैथेटिक चेन ऑप्शन में था, वो आंसर हो सकता है ना. सिंपैथेटिक चेन, व्हाट एल्स द ऑप्शन? वन ऑप्शन इज सिंपैथेटिक चेन. जॉगरेन सिंड्रोम कहां से आ गया? सर्वाइकल सिंपैथेटिक चेन, आईसीए सिंपैथेटिक प्लेक्सस. द आईसीए प्लेक्सस आंसर नहीं हो सकता बिकॉज दैट इज इन द पोस्ट गैंग्लियन. ठीक है, वेरी गुड. यस सर, जॉगरेन सिंड्रोम. अरे हॉर्नर सिंड्रोम क्वेश्चन था, जॉगरेन सिंड्रोम था. क्या पूछ रहे हो यार? शर्मा टेस्ट पूछा था. ये अलग अलग एग्जाम देकर आए हैं. ये हो क्या रहा है? एक शर्मा टेस्ट बोल रहा है, एक मुझे बोल रहा है कि पैनकोस ट्यूमर था, कि एक वैगस बोल रहा है. वैगस भी लिखा था क्या? जॉगरेन का भी क्वेश्चन था. ओके ओके, द अदर क्वेश्चन वाज इन जॉगरेन सिंड्रोम. ओह ओके, फाइन फाइन फाइन. तो बताओ, ये क्वेश्चन भी बता दो. वेरी गुड, थैंक यू वेरी मच यार. तो क्योंकि आई वाज लुकिंग फॉर द 8th क्वेश्चन. आई हैड 7 क्वेश्चंस, आई वाज लुकिंग फॉर द 8th क्वेश्चन. कैरोटिड था ऑप्शन. ओके, कैरोटिड भी था. तो आंसर तो सिंपैथेटिक चेन हो सकता है ना, बिकॉज बाकी पोस्ट गैंग्लियोनिक में आ गए. हाँ ठीक है. अब मुझे बताओ जॉगरेन के ऊपर. अब मैं समझ गया, अलग अलग क्वेश्चन मैंने एग्जाम नहीं दिया इस बारी. तो जॉगरेन सिंड्रोम का क्वेश्चन क्या था, प्लीज बताइए. इमेज और विदाउट इमेज? पंजाब मील गिवन सर, ये क्या है? अरे पीएसएम थोड़ा पढ़ा रहा हूं यार. जॉगरेन सिंड्रोम का बताओ. दैट्स द लास्ट क्वेश्चन फ्रॉम माय साइड. जॉगरेन आंसर फॉर शर्मा टेस्ट. मतलब एक ऑप्शन में क्या पूछा था, क्या टेस्ट करते हैं जॉगरेन सिंड्रोम में? शर्मा टेस्ट तो करते हैं ऑफ कोर्स, बिकॉज जॉगरेन सिंड्रोम हैज ड्राई आईज. जस्ट ब्लर्टिंग आउट द ऑप्शन ऑफ डिफरेंट क्वेश्चन कंफ्यूजिंग। नो नो नो, कोई बात नहीं, मैं मेरे कंफ्यूज होने से क्या हो जाएगा। बताओ बताओ, नेक्स्ट क्वेश्चन बताओ और ऑप्शंस दो। नेक्स्ट फैकल्टी इज वेटिंग। Jogren वाले क्वेश्चन में they only gave clinical history, okay, that there is decreased secretion, decrease oral and tears, I think decrease tears, decrease oral secretion, मतलब Jogren बताया नहीं था, history wise Jogren था, okay fine. Shermer and autoimmune antibody, okay fine, autoimmune नहीं नहीं, तो क्वेश्चन क्या था कि आई में क्या टेस्ट करेंगे या मतलब क्या नेक्स्ट टेस्ट क्या करेंगे, ओके नेक्स्ट टेस्ट क्या करेंगे आई में या बॉडी में। Jogren's how to diagnose Shermer without antibiotic testing prednisolone for 1 month, ये तो मुझे देखना पड़ेगा। सलाइवरी सिंटीग्राफी, अच्छा सलाइवरी सिंटीग्राफी नहीं तो इट वाज ऑप्थेल में पूछा था क्या, आई में टेस्ट तो शर्मर करेंगे। एक टिंगलिंग सेंसेशन लेकर आया था, डेसी गॉसिप्स बता रही हैं, गॉसिप कर रही हैं यहाँ पे, उनको रेस्पिरेटरी सिम्टम था, आई ड्राई होता है, माउथ ड्राई होता है, विच टेस्ट इज लीड टू डायग्नोसिस, ओके फाइन, अच्छा ये था। तो ये तो यार वो भी हो सकता है ना, एक मेडिसिन का सवाल भी हो सकता है कि क्या पता जॉगरन के लिए वो उन्होंने एंटीबायोटिक टेस्टिंग, ओके तो ये आई हैव टू चेक। ऑटो एंटीबॉडीज भी तो हो सकता है, ग्रिटिनेस इन द माउथ, ग्रिटिनेस माउथ में नहीं होता, आंख में होता है, माउथ में ग्रिट है, तंबाकू थोड़ा खा रहे हो यार, पीकाबू, ये क्या होता है ग्रिटिनेस इन माउथ। हाँ ठीक है, ऑप्थल नहीं है, मेडिसिन क्वेश्चन होगा, मे बी इट्स अ मेडिसिन क्वेश्चन, बट ऑप्थल के साथ साथ आ गया इसलिए आपने हो गया। आई डोंट थिंक सो इसमें कुछ लोग विल टॉक टू द मेडिसिन डिपार्टमेंट एंड सी विच हु विल टेक दिस क्वेश्चन, आई विल गिव इट टू देम इफ दे वांट। इसमें आई थिंक आई विल हैव अ लुक ऑफ हॉर्नर सिंड्रोम। सो आई हैव गॉट 7 क्वेश्चंस, 7 क्वेश्चंस में एक बारी मैं अगर रिकैप्चुलेट फटाफट कर दूं, सो द फर्स्ट क्वेश्चन में कोई डाउट नहीं है, एक्यूट प्राइमरी एंगल क्लोजर, नो डाउट, शुड बी करेक्ट। सेकंड क्वेश्चन में कैल्क्यूवर वाइट, इट वाज अकैंथामीबा नॉट सुडोमोनास, should be correct. Third में pigmentary glaucoma, if you know, you should know because it was in the class. Third, fourth is option थे वही ACD या AB, मतलब ओके एंड ड्रम और टेलर से करते हैं, लैंडोल्स भी करते हैं। Then it's the acute high drops, gas injection is given, there should be no doubt in that. A Horner syndrome question, sympathetic chain answer होना चाहिए because that is a central sympathetic pathway. Alright, okay fine, चलो, alright, चलो, thank you very much and I'll get the real questions. अभी तो unreal था, I'll try to get the real questions tomorrow and we'll post with the answers as well. ठीक है, thank you very much and we'll wait for the next faculty to take over. Best wishes. I hope you have done well. Let's relax now and wait for the result. All right. हाँ, मुझसे बात करनी है, मुझसे बात कर सकते हो आप। 5 तो क्वेश्चन सही होने चाहिए थे 7 में से। All right, bye bye.
Very good afternoon, all my students. Can we start with the ENT segment? everyone? So let's start with our first of all. Tell me, how was the paper? Paper was easy, moderate, difficult? Very good afternoon, everyone. Every student should help me in getting all the choices, getting all the expected, all the important points. Can we start? Very good afternoon, beta. Is audio video fine? Can you update in the chat box? Is audio video fine? So beta, let's use next couple of minutes for getting all the ENT MCQs. Paper was moderate. Yes, the same feedback I'm getting from the students. Paper, some questions were direct hit, direct one-liners, and some questions were twisted, difficult MCQs. So let's crack all the ENT questions which were there in today's session, beta. So I tried my best to compile all the questions with all the choices. So just help me in this session to complete this all the ENT recall MCQs, recall choices, beta. We'll be conducting the complete session tomorrow morning. We will be discussing all the choices in detail. At this point, I'm just trying to recall the choices. First question was dedicated to CA larynx. आना ही आना था बेटा, ये question तो आना ही आना था, and I'm confident everybody must have attempted. क्या question attempt किया बेटा? पहले let's crack. Now don't write all the questions in a single go. Just one by one. One MCQ from larynx. CA larynx. They have asked you on the TNM staging. Very good, Dr. Vinayak. Excellent. Answer was T3. अगर आपको याद होगा मैंने लेक्चर में एक बात भी बोली थी कि if you can't digest, always gamble on T3. Why? Because क्या basic motive था behind this question? The most common presentation in ENT OPD is patient commonly land up in T3. But you have revised the notes completely. You have revised the notes multiple times. Fixed vocal cord was mentioned. याद है बेटा? Fixed vocal cord mentioned. Paralysis of the vocal cord. Immobile vocal cord. ऐसा कोई question होगा. हमने DQB में भी किया. Answer will be T3. So MCQ was on CA larynx and the answer was T3. Yes. The thyroid cartilage was involved. Agreed, beta. Thyroid cartilage, two vocal cord were fixed, inner cortex of the thyroid involved. Now I am adding this point, beta. If inner cortex of thyroid is involved, if thyroid cartilage is involved, even then it will be, answer will be T3. Now, just give me important, I will crack this concept. Just give me a few minutes, beta. If thyroid cartilage is involved, it is a part of, kiska part hai beta? It is a part of larynx, na? So we will be taking it as T3. If they have mentioned the word muscles attached on the thyroid, which one? Sternothyroid, thyrohyoid, inferior constrictor. Agar aise options the, then we will go for T4 now. The students who are writing the answer should be T4. Why T4 beta? T4 is there when your tongue, base of tongue is involved. If your trachea is involved or the muscle attached with the thyroid cartilage are involved. If the tumor is involving the thyroid cartilage and even paraglottic space was mentioned, so beta better choice will be T3. I am repeating again. Tumor starting from the larynx. If it have involved complete larynx, supraglottic, glottic, subglottic, we go in the favor of T2. But now the vocal cord are fixed, means all the muscle of the vocal cord, thyroid node is gone. So it will be T3. Paraglottic space involved, T3. Thyroid cartilage involved does not mean it is T4A. Yes, beta. Dr. Adya, it is not T4A. T4A will be when the muscles attached with the thyroid cartilage should be involved. If it have involved base of tongue or it have involved your trachea. So till now what I got from all the students, the answer should go in the favor of T3. But if they have mentioned the tumor involving the cartilage of thyroid along with the muscle, neck muscle, it should be T4. Is it clear, beta? Is it clear? If muscles attached are involved, then we'll be going in the favor of T4. Anyone? Please kindly update in the chat box. Was the muscles attached with the thyroid cartilage was there? Muscle attached with the thyroid cartilage was involved. ये बताएंगे बेटा, was that involved? No. If it was not involved, we'll be going in the favor of T3. Is it clear? No. Thanks beta for writing in the chat box. If muscles were not there, so it will be T4. Question number 2, block. I will take you to my INI marathon session, which I have taken 2 days back. I have given you one important point that they will ask you something on the block beta. ENT with anesthesia, this is the most important topic. They always ask you in the exam, that is your block. So what image they have given? I hope they have given the same image. There was some block was given on the palate, and if this word was there on the palate, so which block? It is your greater palatine block. So in this MCQ, the answer should be in the favor of greater palatine. It should be greater palatine. Clear? Thanks, Dr. Vinay, Dr. Deep for writing in the chat box. The muscles were not involved. We'll be taking it as T3. Is it clear? Any change in the upcoming hours, beta, I will interact with all these students again. If any change in the answer, we'll update you in the main session, which will be running. Clear? Done. Now block. Now I want to ask you one thing. See, larynx. From larynx, did they ask you anything on the vocal cord paralysis, nerve supply, or any MCQ on epiglottitis group infection part? Any voice abnormalities? Or from the larynx, there was only one MCQ, that is carcinoma larynx PNM classification. What was the right answer, beta? That is T3, yes. Only one question from larynx or any other point? Kindly help me in recalling the questions, recalling the choices. No, it was only one CA larynx. So second MCQ, we are going for blocks. Question number 3, they have asked you something on the endoscopy steps, beta. Endoscopy steps. But I didn't get choices of this MCQ. Can you help me? Yes, Dr. Devesh. Dr. Ayush, what was the option in the steps of endoscopy? Functional endoscopic, they have asked you something on the one MCQ on the larynx, anat picture and the function have asked. Very good. I will add in the MCQ. They have shown you a image of larynx and the function. This question repeated more than I think 5 times in the last 10 years. Protection, protection, protection. So the first statement of my lecture in larynx, it is we always, why God has given you larynx to protect the trachea, steps. Yes. Identify the sinus, uncinectomy. Very good. Okay, that's great. I got the choices. Okay, they have started from the nasal cavity. They have asked you removing the uncinate bone, and if I hope this image must have helped you, which we have drawn in the classroom. This is uncinate bone, and you are going from outside. The most common step done in endoscopy, I repeat multiple times, that is your uncinectomy. That's great. Once we remove the uncinate, we will be able to identify. Dr. Manish, thanks for the writing choices. Identification of uncinate, I will help you to. Very good. That's great. MCQ. First, we will be removing this uncinate bone. Then we will be identifying the ostium, because all the ostiums are here behind uncinate bone in hiatus semilunaris. Yaad hai beta? I hope. Okay, that's great. Uncinectomy, identification, then bullectomy, then posterior air cell. This should be the order. Very good, very good. I will just take the screenshot of this. Very good. All the 4 choices. The first, uncinectomy. Then the posterior air cell will be the last one. Agreed. Identification will be the second step. And if any change in the choices, Dr. Dhruv, beta, thanks. Uncinectomy, removal of the ethmoidal sinus. First, the uncinectomy will be the first choice. I hope this must have helped you to rule out the option. Clear? Order should be dissection of ground lamella was there. Okay, that's ground lamella is a bony partition between anterior group of ethmoidal air cell, posterior group of ethmoidal cell. Okay, 5 steps were given. I will add 5 steps with that. Clear? Thanks for writing all the ground lamella is the partition. Basal lamella is the partition between ethmoidal air cell and posterior ethmoidal air cell. Is it clear? Dissection will be the later step. Dissection of the ground lamella is inside. 2 options in which uncinectomy was the first step. Yes, the choices were uncinectomy. Once you remove the uncinate, then only you will be able to do the other steps. Na beta? So out of those 2 options, you have to choose like the ground lamella or posterior word. Now, listen carefully. All the students listening to me, listen carefully. Now, with the word posterior ethmoidal air cell or ground lamella, they should be in the last option. A posterior ethmoidal choice should be the last option. Yes, Dr. Pramod, excellent. So how can we reconstruct all the choices, reconstruct the MCQ? The uncinectomy, the choice having uncinectomy should be the first step. And the choice having the posterior ethmoidal air cell should be the last one. So it should be this, clear? That's clear. So I will be compiling all the choices. I will be coming with a complete discussion tomorrow. Clear? So the first MCQ on CA larynx, second was on the block, third was on functional endoscopic sinus surgery. Any other MCQ from the nasal cavity? Thanks for compliment with our ENT. Thanks if you were able to crack all the MCQs. That's great. Thanks for that. Now tell me, every student should apply any MCQ from the nasal cavity. Did they ask you on fracture part, Chevalet, Jarjovic fracture or Leafoot fracture, or they ask you some on granulomatous condition, or from the nasal cavity? There was only one MCQ. Yes. From larynx till now we got two questions. One was TNM classification, one MCQ was on your function of the larynx, that is protection. From nose nasal cavity beta, only one MCQ, that is functional endoscopic sinus surgery. That's great. Now coming on otology, not done in an infant. Which investigation is not done in an infant? Options were, can you help me in the options? Autoacoustic emission to karte hain beta. This is the screening procedure of choice in all the newborn. Cadaveric picture with a labeled muscle. Okay. That from Dr. Pramod, can you tell me one? I will add here the nose image. What did they ask in cadaveric image of nasal cavity? Can you help me here? Yes, what did they ask on? Very good, excellent. The next MCQ number 4 answer is pure tone audiometry. Very good, very good, very good. Yes, can you tell me which question was there in the anatomy ENT integrated question, cadaveric image of nose? Autoacoustic emission is the screening procedure. BARA is always done in high risk baby, so it cannot be the right answer. One was pure tone audiometry, free field audiometry. If you remember in the lecture, even in my back to basic, we have cleared this point. Free field audiometry is a very favorite choice of your examiner. Pure tone audiometry, where we are using the microphone, while in free field audiometry we are giving the sound from the external source. So answer will be here, pure tone audiometry, PTA, pure tone audiometry. Any change in the choices, I will update you in my recall session. Is it clear? Okay, they have asked you which muscle is not involved in dysphagia. Okay, clear. So this concept is clear. So answer from audiometry will be PTA, pure tone audiometry. Any MCQ on ASOM, CSM segment? Did they ask you any complication part of infection of the ear? Any MCQ from otosclerosis, Meniere's, acoustic neuroma? Did they ask you to make a diagnosis of otosclerosis or Meniere's or acoustic neuroma? No. Then coming on the next MCQ, they have given you a audiometry finding of high frequency hearing, high frequencies gone, high frequencies damaged, low frequency were intact, low frequencies were not damaged. Which part of the cochlea involved? They ask you something like this. Which part of the cochlea is involved? Choices: outer hair cell, inner hair cell. Tectorial membrane, can you help me? Yes, one MCQ was from ENT with radiology, where they asked you to identify internal auditory meatus. Yes, I got this message, but I didn't get all the choices. Yes, Dr. Wajir, can you tell me all the choices of this MCQ? The fifth MCQ, noise-induced hearing loss, which part is damaged? Beta, pehle isko crack kar lete hain. Let's crack this one first. Outer hair cell, inner hair cell, base of the cochlea, high frequency. If the word base was mentioned, answer will be stria vascularis, or base. If stria is, okay, I got the point. Outer hair cell, inner hair cell. One was outer, one was inner, one was your stria vascularis. Stria vascularis is the lining of the scala media. So it will be at the base as well as apex. So answer should be base. Answer, high frequencies involved. Cochlea respond from 20 Hz to 20,000. So answer should be base of the cochlea. Base of the cochlea. So beta PYQ है ना बेटा, we have already discussed autotoxic drug, high frequency damage, the base of the cochlea, and if base of the cochlea is involved, it is here. Inner hair cell, outer hair cell. One student is giving different choices. Apex, no, apex cannot be the apex part of the tectorial membrane. Okay, no, it will be the base of the cochlea. Base with outer hair cell. If base with outer, Dr. Pramod, good, I got the outer hair cell of the base of the cochlea was mentioned, so it will be the better choice. Base with outer hair cell will be the best option. Base mentioned with the outer cell or with the outer inner are the part of organ of Corti everywhere. Na? So they were asking you at the base or at the apex. So answer should be at the base. Clear? So these were the 5 MCQs which I got till now. Any other question related with ENT? Yes, anyone? Any other point which you recollect? Please kindly update in the chat box. We'll discuss. Base or Dr. Vishal, yes, many students were saying a base with outer hair cell. So base with inner or outer hardly make a difference. Answer will be base with the inner hair cell damage. Base in the inner cell damage. Clear? One CT image was given. What was the options of that CT image? Internal auditory canal. Clear? So these were the important 5 MCQs. So now our other faculties will be joining. I will be coming with my ENT segment with a complete discussion. Yes, thanks a lot for listening to me and thanks a lot for helping me in all the important choices. Yes. Image with vestibular aqueduct, internal auditory canal. So let me work on this MCQ. I will be searching the image. I will be, when the 2 choices are confirmed, one was vestibular aqueduct, internal auditory canal. This, if I remember, this was the old MCQ where they have asked you the MCQ on acoustic neuroma and answer was internal auditory canal, but without other choices. I will be not be commenting anything. So thanks a lot for listening to me. Here we stop the ENT segment. Clear? I'll be coming tomorrow with a complete discussion of ENT.
Hi, good evening. Good evening. Great. How is micro? Easy or tough or moderate? Okay. I got some questions with you. These are all first hand information. I need more information from you people to get the full picture. Whatever you people are very tired because yesterday night many people they didn't slept, traveled, a lot of things are there. Even though you people helped me to make some questions, double digit level questions. Okay, good evening. Number 1, match the following. One question came. Larva currents. Everybody knows larva currents by Strongyloides stercoralis. Visceral larva migrants, especially Ankylostoma brasiliensis, Ankylostoma caninum, those kind of people, not Necator americanus and Ankylostoma duodenale. Great. And cutaneous larva migrants, Ankylostoma duodenale, visceral larva migrants, Toxocara canis. What is the other choice? Larva currents, Strongyloides, cutaneous larva migrants, Ankylostoma, visceral larva migrants, Toxocara canis. What about the other choice? Fourth choice? Ascaris also. Okay, a cyclist, Ankylostoma brasiliensis, very good. Ankylostoma brasiliensis. Another one is Ascaris. What are the skin condition they mentioned? Low flux pneumonia. Low flux pneumonia. Somebody said Ascaris not in, Ankylostoma not in option. Without Ankylostoma, we cannot make cutaneous larva migrants, my dear. Okay, right. We'll get the question. You just inbox me the correct question. Water-based itching, schistosoma. Water-based itching means schistosoma. Don't remember. Swimmer's itch. Very good. Swimmer's itch is schistosoma. Because these are the questions I got it from you people only. Okay, you modify. Schistosoma. Great, great, great. Swimmer's itch, schistosoma. Second one is, I will anyway, you just refine and send it to me. I will make a complete picture. Number 2, identify the egg. See carefully. Same picture given in the workbook also. Okay, and also in our DVT. Egg with 4 features, 5 parasite. Very good. Anyway, I will modify here the previous slide. And one is Ascaris and also schistosoma. And the fourth one is swimmer's itch. Or water-based itching. Okay, we'll make it. Second one is same picture. Egg with, see carefully, clear shell with the blastomeres. Exactly same picture came. Great. The same picture in DVT, same picture in workbook. Everywhere the same picture. What is it? It is hookworm egg. Easily people can make it hookworm egg. Perfect. Parasitology that much. That means you people more strong in parasitology. I know that. Parasitology and mycology people are more strong. Ankylostoma and Necator americanus. Either one. Both are hookworm. I don't know what option they give. I want the other option. So Necator was the option. Very good. Necator was the option. Great. Necator americanus. Great. And I want the other options also. Skin lattice was given with a DNA virus. I will come back to you, my dear Prakar Shingal. I'll come back to you after that. You will put all the questions I will write. Or best you in my Micromagic group, you message me, direct message me. I'll be so happy. Right. Ascaris was one option. Hymelepsis nana. Hymelepsis nana. Tinea solium. Very good, very good, very good. Super. I will make it a full slide, full presentation. Great, Rogini. Dr. Rogini said swimmer's itch in schistosoma. Ascaris tinea hachnana. Okay, good. We know the correct answer, Necator americanus. So people bagged. Next is which is not caused by thorn prick. Local inoculation, thorn prick. Thorn prick means always you remember sporothrix, even chromoblastomycosis, mycetoma, all due to local inoculation. Dermatophytes not due to thorn prick. Close contact. Dermatophytosis due to close contact. Great, great, great. Dr. Medisips, Sarath, great. Thank you. Dermatophytosis, simple question. Mode of transmission, all the subcutaneous is local inoculation, local injury or thorn prick, many things. Only thorn prick they asked which one is mainly by thorn prick is I can go for sporotrichosis. You know that. Dermatophytes. So mycology and parasitology you need to score 100%. Next is one question came as alpha hemolytic colonies, fever, cough, organism bile solubility positive. What is the organism? Alpha hemolytic, cough means pneumonia, bile solubility, inulin fermentation, optochin sensitivity. Always you think of streptococcus pneumoniae, but I don't know whether the image based question or not. Is it image based question or not? I want to know, is it image based or just a history? What about the other choices? Because some people send this question to me. Sir, alpha hemolytic, fever, cough, bile solubility present, sir. They asked for properties. Image was there. I put the image. Okay. And this organism is bile soluble, inulin fermentation. Optochin sensitive. And catalase negative. It is not catalase positive. That means what is not? Organism, not the feature. Not the feature. Sheep agar, yes, sheep blood agar, alpha hemolytic colony, fever, cough. Okay, picture they gave. That means streptococcus pneumoniae, gram positive cocci, streptococcus pneumoniae. It is bile solubility positive. Optochin sensitive, inulin fermentation positive, except it is catalase positive is the wrong answer. Because all streptococcus are catalase negative. Catalase positive was given in option. Vancomycin is drug of choice. Oh my God. Then if it is catalase positive, this organism is totally different. Catalase positive means we need to think of staphylococcus. Confusing. Be careful. Vancomycin is their option was catalase positive. Bile solubility. One option was catalase positive. Yes, everybody says catalase positive is there. Then it is the option. One option catalase positive. What about the picture? Is it gram positive or gram negative? Is it gram positive or gram negative? Bile solubility, catalase positive, vancomycin is the drug. Okay. Then this is not the option. I'll remove this. I want the exact thing from you. Catalase positive one option, bile solubility, vancomycin is the treatment. What about the picture? Gram positive or gram negative? Can anyone tell? What you seen in the picture? Which is correct, they asked. Okay. Which is correct? Alpha hemolytic. The correct is bile solubility. Then I can go for bile solubility because treatment is not, it is catalase negative. Vancomycin. Vaccine available? Vaccine available or not available? Vaccine not available. Great. No vaccine present. Very good. Then we made a question. Now I got the full picture. It is catalase negative, not catalase positive. Option ruled out. Vancomycin is the not the treatment. Ceftriaxone is the treatment. Option out. Vaccine available. Option out. It is bile soluble. Streptococcus pneumonia, gram positive cocci. Majority of your answer, I'll make it. A spectacle purple color, beautiful. Answer was bile solubility, yes. Kiran Thapa beautifully mentioned. Alpha hemolytic colonies, cough, fever, pinpoint colonies, and gram stain was given, which is correct. Bile solubility positive, Ancodoc. Okay, great. Right, great. Next is toxin acting on elongation factor 2 and inhibiting protein synthesis. Find the incorrect statement, and people said some picture came. I don't know the exact picture. You search in the Google. If you're able to find the Google picture, same picture, you just send it to me. I will add this picture. This is, I assumed elongation factor 2 means diphtheria toxin. So acting on elongation factor 2 is usually diphtheria toxin. Acting on elongation factor 2 usually diphtheria toxin. Gram positive cocaine, short chains. Okay. Great. Great. World view about India. Great. Last option, phage dependent. In case of Corynebacterium diphtheriae, it is exotoxin, yes. Myocarditis causes, yes. Phage dependent, yes. But it is not most harmful toxin on the earth. Most harmful toxin is botulinum toxin. Very good. Thanks, Vishal Singh. Then the question is completed. Thank you. I need this only. Because you people are lively, experienced and came. So it is not the most harmful toxin on the earth. The most harmful toxin on the earth is botulinum toxin. Make it botulinum toxin. Botulinum toxin. Good. Botox. Great. Pragar Shinkal. Great. Very good. It causes myocarditis. Yes. Man. Remember mnemonic man. Myocardium, adrenal hemorrhage. Myocarditis, adrenal hemorrhage. Palatal palsy. Nervous system. You remember in my notes. I used to write man. It affects 3 areas. Myocardium, adrenal and nerves. Palatal palsy. Great. Thank you. Next is needle stick injury to a healthcare worker who had taken 2-dose vaccine but non-responder on subsequent titers. That means he's not developed any antibody. That is called non-responder. What is the management? Sorry, spelling, fast typing, old age. Management is okay. See here. So if the patient is not at all exposed, not at all developed, vaccine is not useful, we need to give ready-made antibodies. As per government guideline, the ready-made antibodies, 2 doses of hepatitis B immunoglobulin, 1 immediately, after 1 month later 1 more, but 2 weeks also acceptable. First dose immediate exposure, second dose after 4 weeks, they given in the guideline, but 2 weeks also acceptable, they mentioned. No need for full course of vaccine because vaccine is not working on him. He already taken 2 doses of vaccine. It is not working. He is non-responder. So any non-responder, we need to deal with immunoglobulins. That's a concept. That is a concept. He need 2 doses of, if they mention the word non-responder, then as per guideline, we need to do like this. Okay. One dose HBIG mentioned. I didn't get the choice. I'll check. Full course of vaccine. I'll write. Then I will discuss. He has not taken third dose. He has not taken third dose, but non-responder, the word is there or not. That is important. If the person is non-responder, that management is totally different. If the person is not taking the third dose vaccine, the management is different. Little careful, my dears. Okay. Sir, 4 weeks given. Where the 4 weeks given? I got the answer like this. You please message me. If you know the full question and choice, please message me based on that. Majority of the people what is messaging, I will take that. Some people writing some question which is not at all asked. Like that. Okay, right. Nothing to worry. He has taken full course for 6 weeks. Okay, right. I'll check after your messages. BSL biosafety level for TB handling. I will ask one question. TB culture or TB PCR? Anything mentioned? If they mentioned TB culture, BSL 3, because many times they are asking TB culture only. So I assumed it is TB culture. I go for BSL 3. As the question is direct question or they made some history, some hemoptysis, patient had TB, like any question. After 2 series of vaccine, non-responder. Okay, good. I'll take Dr. Shobit Parmar. Full course and checked viral load. Oh my God. Nobody mentioned viral load. Nothing mentioned. No problem. TB BSL 3. Always remember TB BSL 3. Tuberculosis, always think of, because it's aerosol producing. Okay, BSL 3 is best for tuberculosis. Just handling, nothing mentioned. No problem. Lab handling needs BSL 3. That's ideal. Lab handling means culture. Because mere preparation, no need. Okay, open space many people are doing. But best is always BSL 3. Go for BSL 3. Working in lab with TB bacteria. Okay, handling sputum. BSL 3 is good. Next is some picture they mentioned. I don't know the same picture or some other picture. In the picture, bat is there, pig is there, human is there. Bat, pig and human. It is Nipah virus. Sir, in hepatitis B question mentioned that the patient had high viral load with hepatitis B surface antigen. I will write it that also. Surface antigen with high viral load means infection is more. That vaccine not at all controlled. So that time you can go for immunoglobulin. Good. Next is, what is this virus? Nipah virus. It is Nipah virus. Nipah virus is DNA virus. It's RNA virus. It causes encephalitis. I don't know other options. If we give the other options, I can make it this option more strong. Otherwise, 100% mortality. No, it is not 100% mortality. Good. It is around 60 to 70% mortality, not 100%. Human is not the reservoir. Fruit bat is the reservoir. Very good. Great. Human is the reservoir. Human is not the reservoir. No 100% mortality. It is RNA virus. Go for encephalitis. Great. Next is obligate intracellular parasite. Intracellular bacteria is, there is a mnemonic called cream, chlamydia. What about the other choice? Rickettsia, Ehrlichia, Anaplasma. These people are obligate intracellular. Okay. Chlamydia, Rickettsia, Ehrlichia, Anaplasma. These people are obligate intracellular. Direct question. Then vote for it. Ehrlichia chafensis. Cream is the person not taking what is called not taking gram stain. These 4 people are obligate intracellular. They won't take gram stain. M for mycoplasma, like that. So obligate intracellular. These 4 people always remember. Chlamydia, rickettsia, Ehrlichia, anaplasma. Okay. Campylobacter, granulomatis. Other option is Whipple, Whipple. Yes, very good, very good, very good, very good. That's all. If 4 choices came. Ehrlichia is the obligate intracellular. Sorry, Ehrlichia is obligate intracellular bacteria. Great. Next is Uchuria bancrofti, causative agent of lymphatic filariasis, most commonly found in which of the following site of the human body? Uchuria bancrofti, commonly found, the site is lungs. Most commonly found site is lung. Whipple was in option, sir. Great. Okay. Very good, very good. I will write it. Don't worry. I will write it, I will modify, and I will present. One more session is there. That session, now I got the information from you, and I may get more information from other people. Some people slept also, some people in traveling. Okay, aram se, after that you sit back, calmly you think whatever answer, feel free to message me. Okay, diurnal variation. During rest, because not at the time of rest, it will be present in the circulation. Capillary blood we can take. At the rest, we can get it from lungs. So periodicity, when they are not in blood, where the microflare? Lung. Very good question. It's a right question. If not in the blood, you can go for lung. Not in blood, present in where? I'll write it here. During rest, not in blood, present in where? I'll write. Don't worry. Now take down. Every word is important from ideas. Next is, choose the organism causing this infection shown in the image produces black granules. Sinus is there. See the image. I don't know the same image or not. If search in Google, it's a mycetoma. Adult gastroenteritis virus, Norwalk virus. I'll come back to you. Okay, I'll come back to this question. Please wait. Got it? See here. One is Majorella. After finishing the question, we'll ask. Lymphatic organ. It was a different image. Okay, Actinomadura, Nocardia. This produces white granules, yellow granules. Black discharge, yes. Black granules, black discharge. I can go for Majorella. If the Majorella is there, that is the answer. If the Majorella or Curvularia is the answer. Which lymphatic organ? Okay. Because it is lymphatic filariasis, which lymphatic organ? Okay, I will make it. Sometimes blacks. Majorella means Majorella is the one and only fellow producers. I am sitting in the same city where they found Majorella, Madurai. I used to tell in the class, remember, I am from Madurai. It is famous for Majorella mycetomat found in my place. If it is there, that is the thing. Intermittent discharge. Great. Now, extra questions. Now you people tell. Adult gastroenteritis. We have 4 choices. Somebody already mentioned. Okay, adult gastroenteritis virus. What is the virus? I'm missing this thing. Norwalk virus is, that is the answer. Majority of mycetodermitis. Norwalk, most common. One is Norwalk, Rota infant diarrhea, adeno infant diarrhea. Go for Norwalk virus is the correct answer. Another one is, what about Candida picture? Astro. Most common is Norwalk virus. Norovirus or Norwalk virus. Very good, very good, very good. Next is Candida picture. What is it? What is the question? Candida picture. Norovirus, you are right. Adult norovirus, children rotavirus is the common. Germ tube. Candida albicans. Candida albicans. Germ tube test, 37-degree growth is picture. Species of Candida. Candida albicans will form, Candida dublonensis will form. What is the answer? What is the answer? Albicans or dublonensis? Because both can produce this thing, germ tube. It is gram positive. Every point I'm writing. Species of Candida albicans was one option. Candida krusei, very good. Krusei. Dublonensis is not there. Leave it. Great, 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 great. If albicans is there, that is the answer. Other answers you just send it to me. Other answers you send it to me. Already 12 questions over. Now we found 2 more questions. 14. One more. Dublonensis is not there. Leave it. Then you are 100% aram se. Happily you put albicans. See my notes. Simply I gave the picture of the same germ tube picture is available in DVT. All pictures they given. Sir, another question, please. Henox choline purpura. Sequence of PCR. What is it? Aspergillus acute angled. Image. What about it? Paragonimus testimony, prasequantal. Paragonimus testimony, prasequantal. Apart from that, Paragonimus testimony, acute angle branching, denaturation, annealing, elongation. Very good. PCR sequencing. First denaturation, annealing, and third step is extension. Extension. After that, we can go for hybridization. Great. Lung imaging, crab picture correlation. Crab Paragonimus westermani. I want the choices also. Please, my dears, even the night, you please send it to me to make it 100%. Drug of choice is praziquantel. Drug of choice praziquantel. Separate hyphae acute angle branching. Aspergillus. Aspergillus. Yeah, fourth. After finishing this, you can go for hybridization. Praziquantel. Yes, Dr. AJ. Great. So almost we had 18 questions, 18 to 19 questions. Okay. I will make it in a perfect shape. I will present to you soon. Meantime, you please send the choices to me more authenticated. Don't make me forced to cook with some choices. I will not cook. I will take the choice. I'll put 3 choices, 2 choices. Okay. Whatever it may be. Anyway, this is an experience. Hope you all did well. Okay. Don't worry. Wait for the results. With this, yeah, crab image. Yes. You just send it to me, my dears. The questions, you please send it to me. Exact question, because 1 word, 2 word, it is confusing. The whole meaning will be changed. Okay, right. So I got the question, 1 question with the crab, sir. Then I can think Paragonimus westermani. The question is not Paragonimus westermani. The question is drug of choice for Paragonimus westermani. Like that. Hey, don't worry. We'll make it. Okay, right. Innate immunity question was there. What is the innate immunity question? Thank you, Dhanashri. Okay. Yeah. I'll get back you. Hybridization is a technique. Is that after PCR, we are going to go for hybridization. Okay. Thank you. Innate immunity is faster than acute because there is no lag period, because it is non-specific preformed. It is non-specific and preformed because of the reason innate is very faster than the adaptive immunity or acquired immunity. Yes. Advantage of innate is there is no memory, there is no specificity. Because of the reason, whatever antigen comes, they immediately react. But acquired or adaptive, for every antigen, it develops one type of immune response. It takes some time. For example, adaptive, it takes antigen processing, presentation, etc. Takes some time to prepare. That is the reason. Okay. That is the reason, right? Because it's have pattern recognition receptor, PRR, pattern recognition receptor. Okay, that molecular pattern recognition receptor. Because of the reason it acts fast. Okay, thank you. I am signing off now. All the best. See you with full version. Please help me. That's all. Thank you.
Hi guys, good evening all of you. Welcome to this INICET recall for the subject of PSM now. Okay, so I hope you can see me, you can hear me and everything looks fine. Yes, now first and foremost, let me tell you, these are the first line recalls as of now. Okay, so the questions will change definitely after I get a lot of input from your side. Okay. Now, basically, if you see, there were roughly around 15 questions PSM set. Okay. So, out of the 15, students were saying there were 6 to 7 questions from FP and statistics mix. Okay. Uske baad, we will have the other mixed bag questions. Okay. Done. Over. Now, pehla question. Study of asthma and pollution. P value less than 0.03. Okay. Shuru kare? Yes. Chalo. So, as you can see, this p-value is the significant one. So, clinically significant, yes, 3% chance of correlation. Now, please remember guys, p-value does not talk about correlation. It talks about association. So this cannot be the answer. Okay, this cannot be the answer. Now, if they would have given association, then this would have been true, because if with association, then this was the right statement. Okay. Other options, I am still waiting for a recall. Can you guys, Tanushri, Prakhar, Wazir, tell me the recall options for question number 1? Because I could get only 2 recall options. Yes. Question number 2, probably a general knowledge based question where they ask the Nobel Prize for the year 2025 for medicine or physiology was. Now this question typically shows that the exam paper is being set hardly 15 days back, because the Nobel Prize were announced just roughly 15 days back. Okay, done. Okay, Prakhar says 97% chance hypothesis is wrong. Okay, okay, yes, chance of alternate is 77, 97. Okay, got it. So again, this cannot be the answer. This cannot be the answer. Okay, because p-value talks about chance. So the chance is only 3%. It is not 97%. Yes, done. Okay, one more option coming up was 3% probability. Null hypothesis is correct. Again, if this was the statement, this cannot be the answer. Yes, because when we say it is 3%, they have to mention by chance. Okay, so 2 options again are wrong. If there is any other version, please feel free to let me know. Okay, because सब लोग अलग-अलग लिख रहे हैं. Just drop me a message after the session. So Nobel Peace Prize was given to Bruno, Ramsdell and Shimon Sakaguchi. They were basically given for looking into the immune system. Okay, done. Objective of NEET Aayog, except NEET Aayog, National Institution for Transforming India. For transforming India. Now this has replaced the Planning Commission. This has replaced the Planning Commission. Yes. So arranging state according to health status. Yes. NEET Aayog gives a sequence in which the states are ordered every year. Funding for private hospital. No, you can understand it's a government thing, so it would not fund the private. Assess the efficiency of government hospital. Yes, there are indices which helps to assess. Identify the aspirational districts. Yes, in India there is a 100 aspirational district aspirational district program. Okay. Okay, except not there, objective NEET Aayog index. Okay, now if they make this question NEET Aayog index, if they put it as NEET Aayog index with a single best answer would have been D. Now as they were saying, students are saying multiple correct. अरे ठीक है बेटा, अगर except हटा दो और multiple correct करो तो A, C, D. I hope I am clear with it. Okay, I have removed the except. It is A, C, D. It cannot be B. It cannot be B. I hope I am clear with it. Looks fine. No problem. Yes, 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 yes. Okay. Now, single best answer would have been D. Single best answer would have been D. Okay? Okay. 500 individuals followed for 2 years, 20 developed disease. They were given 950 person years. Calculate the incidence. So incidence is new cases divided by population at risk. Population at risk into 1000. Now again guys, as I have told you, single best answer for this question was D. So if it's a single best answer was D, 4. index for aspirational districts. Okay, done. Over. So look over here, new cases 20 divided by population at risk 950 person years in 2000. So the answer over here would be roughly coming as 21 per 1000. Okay, one more option was 4 per 1000. ठीक है, वो भी डाल दिया. I hope I am clear with it. I hope I am clear with it. Yes guys, looks fine, no problem. Yes, done. Yes, chronosphere, that's the reason I told you the NEET Aayog index single best answer is to identify aspirational district. Single best answer. It is not to arrange the states. It's not the single best answer. NEET Aayog runs a 100 aspirational district program. Okay. Now, a study was done between exercise and heart failure. It was found that those who are doing exercise have low risk of heart failure and they are also taking good quality of diet. So those who take diet, heart failure will be less. Yes, heart failure will be less, and the diet who are taking, they would not be related to your exercise. Yes, so this becomes more of an effect modifier. This becomes more of an effect modifier than a confounder. Okay, than a confounder. Okay, looks fine, no problem. Guys, please understand these are just first level recalls. I am yet to get recalls from you. Okay, and that's where I am putting these questions. So please feel free to drop me a message. That's the reason in the Telegram group I was putting every hour all the questions which were received to get inputs from you all guys. Okay, done. Over. Yes, see guys, if you can see over here, if this was not there in the option, if this was not there in option, then just change it. You have to look it per 100. So it would have been 2.1 per 100 person years. If option 4 was not there, then answer is A. Answer is A. Mathematical change they have done. Now why not confounder? Because diet is not related to exercise. Diet is not related to exercise. Yes, Sahil, I hope I am clear with it. Yes, Pramod, not. I hope I am clear with it. Done. Okay. According to NPCD screening, what is not done? So NPNCD, so it is the National Program for Prevention and Control for NCDs. VIA for cancer cervix, yes, it is done. Oral cavity cancer, oral examination done. Mammography for breast cancer. So I do not know what the option 4 was. What the option 4 was. Okay, so please tell me whatever is the option 4. Okay, okay, screening done over 30 years. Yes, okay, mammography at primary level. Okay, so if this was the question guys, then mammography at primary level is not done. Mammography is done minimum at the level of district hospital. District hospital. So option 4 is correct. We do screening after 30 years. That is correct. Yes. So it cannot be mammography at primary level. Okay. Case control study. What is wrong was asked. Multiple correct. Again, I was able to get 2 options. Matching cases with controls will prevent all confounding factor. No, it prevents only known confounding factors. It cannot remove the unknown ones. It cannot remove the unknown ones. So gone. Multiple controls for same case can increase the power. True. Why? We say for every one case we have up to 4 control. So this leads to increase in sample size. Increase sample size leads to power increase. Okay. Hospital based controls give better statistics. Okay. Hospital controls better results. Okay, better results. Now, selection bias more in hospitals. Yes, we do get more selection bias if it is a hospital based study. It is correct. Hospital controls yield better because this is easier to do. This is easier to do. Okay, done guys. Okay, which is included in family health education related responsibilities? Provide hygienic. When I'm choosing hospital based control, give selection bias. Control should be part of population. Okay, one more option coming up. Controls should be part of population. Yes. Okay, fine. Okay, looks fine guys. I would be putting these changes. Yes. Now, what is included in family health education related responsibilities? So provide hygienic environment, might be. Teach cultural beliefs about health. No, just not about culture. You have to teach the right things. Taking care in ill health. Yes. Sexual education. Closely monitor and observe the sexual preference and activities of children. Yes. Okay. Fine. Doll and Hill criteria for causality. All except. Answer was sensitivity. Answer was sensitivity. There is no sensitivity in this. We have specificity. Yes. Okay. Question was about not include behind sexual process emotional support in period of illness. Definitely emotional support for period of illness. Yes guys, this is definitely correct. Okay, multiple answer. ठीक है, option C and D. Option C and D. Now, causally triage a road traffic accident. Now, you are talking about whom should you treat first. 6-year-old child crying due to pain. ठीक है, crying, it's okay. 60-year conscious with pant full of blood might be the answer. 40-year unconscious female with labored breathing. This becomes more important because she is unconscious. Okay, so you would prefer for C. 20-year female agitating anxiety. No, because she is just having a anxiety or a panic attack. Yes, yes, no problem. So single best answer would have been C if unconscious was written. Okay. Particulate matter 2.5 micrometer. Why consider in air quality if inhaled? It mainly goes into the smallest alveoli. Yes, smallest alveoli. Okay. Qualification of ASHA. Unmarried is never ever employed. If you remember, even in the class repeatedly I say never ever employ an unmarried female. Widowed 5th class. No. Minimum standard is 10th class. If suitable candidate is not present, then 8th class pass. Yes. Okay. ASHA question on when not asked. ठीक है, ये भी ठीक है. Yes, done. Fine. So, guys, this is just a preliminary recall. If you find better options or any other questions, please drop me a WhatsApp message, because we will have a proper recall tomorrow. Tomorrow, a full recall. Okay, done? No problem guys, I am striking off this question, no problem. Okay, tomorrow we have a full recall. So tomorrow I would be putting up this. Overall, if you ask me, PSM 95% score is what you expect. Okay, because the questions were probably one or two options were tricky, others बाकी सब ठीक है done. This is all from my side. See you guys, bye bye. We catch up tomorrow with the full recall. ठीक है, चलो bye bye, take care, see you guys.
Yes, very good evening, doctors. Yes, welcome to INICET Recall Pharmacology session. My voice clear? Very audible, doctor? Okay, so let's go for recall. So first of all, how do you feel the question, doctor? Can you please answer? How do you feel the question? How was the pharmacology session? Easy or tough or very comfortable? What is the level of the question? Yes, yes, Prakash Singhal. How do you feel the question? The questions are very, very simple or moderate to tough or very tough. How do you rank the question? Pharma, yeah, your voices a little bit seems to be tough. Okay, okay, we'll make it. Actually, all the questions are mostly from direct. Some questions are indirect, I think so. Wait, see, we recall the session. Okay, the first question. Okay, which drug not useful in status epilepticus? This question was there. Okay, this question, I think, simple question. For this question, the right answer go for ethosuximide. Ethosuximide useful only for absensation, not for status. And can you please answer? Here they given option phosphorantine, ethosuximide, levetiracetam. What the one more option? Can you please answer? One option. Fourth option is valproate. Okay, valproate. Okay. So, okay, thank you. The answer is ethosuximide. Question 1. Actually, for status epilepticus, we discuss drug of choice IV lorazepam, followed by we go for phenytoin or phosphorantine or valproate. That's the second choice. If not, we go for a propofol midazolam. Okay. So, right. Yes. Okay. And then select SIPAC. Second question. Select specs given. I just want to know what was the exact question and what the option given. Somebody given in our DAMS Telegram channel, select specs on the question. Actually, we discussed select SIPAC, one of the newer drug useful for treatment of pulmonary hypertension. Here, Selexipag is the prostacyclin receptor. It's a prostacyclin receptor agonist. Okay. Anybody? What are the other options given, doctor? I just want to know what exact question. Yeah, regarding pulmonary hypertension, yes, good. What are the prostaglandin receptor? Yes, the prostacyclin receptor analog. So this was the question. Prostacyclin receptor agonist. Right answer. Go for select pack. And can you please answer what are the other options given? Others of prostacyclin agonist. That means ipoprostenol, treprostenil, beroperas, ilopras, all are prostaglandin analog. Whereas prostacyclin receptor agonist is selexipag. Okay. So this was the question. Answer is selexipag. Okay, so here the options are, I think one is selexipag, other things are prostacyclin analog, ipoprostenol, then alloprost, one more thing, bosentan. Yeah, Bosentan is a endothelin. So endothelin receptor blocker. We have ambrisentan, bosentan, massive dancer, endothelin blocker. Okay. So multiple answer. Multiple choice given. So multiple choice means prostocyclin receptor again only one answer. Suppose prostaglandin analog mean we can go for hypoprostinol, ilopros like that. Whereas bosentan is an endothelin receptor antagonist and ERB. What are useful in memory? So what are useful? Yeah, question was what are useful? What are useful in pulmonary hypertension? So here we have prostaglandin analog like this one, hypoprostinol, treprostinil, and prostacyclin. Multiple question. Okay, okay. Anyway, the drug useful regarding prostaglandin mean you have hypoprostinol, treprostinil, beropros, ilopros, PGI to mean go for Selexipag and ER mean Bosentan, Ambrisentan. ER mean Bosentan, Ambrisentan like that. So question somebody telling multiple, somebody say single answer mean prostacyclin receptor mean go for Selexipag. Okay. Includes mean go for this includes. I don't know exactly what is the question. Includes mean A, B, C like this. Only one mean go for this. Okay. Next question. Yeah. Along with, I think, which is the DPP4 inhibitor needs dose adjustment when given with the ketoconazole. Look here. Ketoconazole, one of the antifungal drug, it is the most important microsomal enzyme inhibitor. Now we have saxaglutine, elanglutine, sitaglutine, vildaglutine. Here saxaglutine purely undergo metabolism by CYP enzyme. So the right answer for the question go for saxaglutine. Among the glutine, the only one glutine undergoes metabolism by CYP enzyme. Go for saxaglutine. Answer saxaglutine. Okay. Yeah, answer saxaglutine. And it's also causing adverse effect of severe heart failure. So be careful. Like that we discussed in class. Okay. And other this saxaglutine causes heart failure. Other problem they cause upper respiratory. But in this in your exam they ask me which is the DPP4 blocker needs dose reduction. Mean go for saxaglutine. I think other options are the same option. Yeah. Yes. Next question. I think this question directly from our face to face class notes in our book, not a mechanism action of lafrotidine. See, lafrotidine, one of the H2 blocker useful for treatment of gastritis. Can I please answer? What are the options are given, doctor? Not a mechanism action. I think it's a multiple response question or single question. It's a H2 blocker. It has the action of increasing nitric oxide. Not it increases nitric oxide. It's a vasodilator. Improve the blood supply to the ulcer area. That will promoting ulcer healing. And so the single response mean go for this. It's not going to decrease NO. It's going to increases NO. NO means nitric oxide releasing property. It's a vasodilator, increasing blood supply to the ulcer area, that be promoting ulcer healing. Also, it has increased mucus production, that be covering the ulcer. Can you please answer what is the one more option given for this question? Regarding lafrotidine, all are true except what is the one more option given? The increase in blood flow and the H2 blocker. What is one more option? Can you please answer? One more option, whether they given increasing mucus secretion or they given increasing somatostatin. Anybody? What they given? Fourth option. Yeah, can I answer? What the fourth option they given? Anybody, doctor? single response question mean answer for question option A. But I just want to make what are the other option also. Lab food. See, in our class notes we're discussing H2 blocker mean concentrate on two main drug. One is cimetidine, one more drug lab food. They ask about lab food. Okay. Yeah, increase somatostatin. They ask about increasing somatostatin. Yeah, the same question we discussed in our workbook as well as in our class notes also. Same question. Okay. Now, regarding HIV pre-exposure prophylaxis, this question came somebody told, and here the right answer go for combination of tenofovir plus emtricitabine. Tenofovir with emtricitabine for a pre-exposure prophylaxis. Come on, all the options are right, doctor. Name the what are the options? The same options given. The right answer for a question go for tenofovir plus emtricitabine. That's the one. Okay. Now just confirming with you people whether the same option given. Yeah. Yes. Good. Varanish is good. Tenofovir plus emtricitabine. Go. Good. Good. And next question. Which one to be start first? I don't know what the complete question, but they asked about something about which one to start first. In case of TB with the HIV infection, which one I should start first to something asking about ATT or antiretroviral with the increased dose level. So I am not getting exact options, sir. So can you please post the options if you able to recollect? Just to post in our DAMS official Telegram channel so that I can make a complete question for you. But in general, what we teach TB and HIV, first always treat TB because when you treat first HIV, risk of iris, immune reconstitution, implemented syndrome. So first thing, always treat TB. And based on the WHO, based on fever count, if the count is less than 50, give 2 week gap. First start treatment at TB, give 2 week gap, and then start anti-retroviral treatment. If the CD4 count more than 50, give 8 week gap. If it is case of miliary, if it is the meningitis, irrespective of CD4 count, give 8 weeks gap. But here, what is the dose? Increase in dose. Yeah, ATT 2 weeks, TB, ART with yeah, yes. Anyway, ARV first and then is no. The right answer for question first go for ATT, give 2 weeks gap, and then go for antiretroviral therapy with increased dose of dolutegravir. That's the right answer. One option ATT before HIV, other option HIV 2 weeks. Yeah, yeah. The exact answer for the question first start giving treatment for ATT, give 2 week gap, and then start anti-retroviral treatment with the increased dose of dolutegravir. That's the best answer. If I able to kind of full options, I will give complete notes for you. ARV patient coming with the cough and fever. Okay, the hearing history. Okay, patient with the cough and fever like that. They will history based. Okay, okay, right. Then I think straight question in oncology they are not making difficult. They give very easy. So actually, what my most question is very simple. I don't know why you feel tough. I don't understand. Everything simple only from class notes. Anyway, come on. Monoclonal antibody acting against vascular growth factor receptor. Very simple. Vascular growth factor mean always remember CI circulation. Yeah, monoclonal antibody acting against circulation. Ramucirumab. Any drug name having spelling CI. For example, bevacizumab. Anything having CI means circulation. So drug name is Ramucirumab. Whereas other options are pembrolizumab, ipilimumab, dostarlimab. These are all immune checkpoint inhibitor. See, we have discussed in our GT paper, in our CBT paper, lot of questions based on immune checkpoint inhibitor. Sir, time management's problem. Yeah, Deepshika telling them that's what your talent, mom. Have to go fast, aggressive manner. Whatever question make it first instinct. If you feel difficult, then you have to time waste. For simple question, make sure that you have to run fast. Okay. So pharmacology, most questions are very simple only. But if you find difficulty in medicine surgery, then you may become depressed while coming to pharmacology. That's it. I think so. Okay. Anyway, ramucirumab, it's a VGE, vascular growth factor receptor antagonist. Pembrolizumab is a PD-1 blocker. Ipilimumab CTLE blocker. Dostarlimab PD-1 immune checkpoint blocker. First set was very lengthy. Yeah, that's a problem. First set was very lengthy. Okay, but if you're good in pharmacology, you can make time in the second pharmacology session. No, okay, right. Now, question 28. This was discussed. This one question, I think image-based question was there. They asked something about drug. I mean, which drug? They're asking log dose for carbohydrate alone with atropine something. I think I don't know exact question, but asking about drug potentially increases acetylcholine. The given graph. So one graph only acetylcholine, one graph acetylcholine with some other drug. Asking which one going to increases efficacy of acetylcholine. Which one is going to increases efficacy of acetylcholine? Can you please answer? Here the given action option methanacol, atropine, phystigmine. I don't know what the one more option. Well, answer. Here, the exact answer go for physostigmine because physostigmine is the choline esterase enzyme inhibitor. It's going to make more available acetylcholine, thereby increasing efficacy. Whereas if methanacol is a direct M3 agonist, it is not going to increase. Atropine is an anticholinergic. So right answer go for physostigmine. One more option was adrenaline. Yeah, thank you. One more option given adrenaline. So it's I think simple question. Answer is physostigmine, a choline esterase enzyme inhibitor. Okay, so far we did 8 questions. In the 8 questions, all are simple only. Nothing new question, nothing new drug, all simple. Somebody says select Sipax new drug. It's not new drug, it's a very old drug, useful for pulmonary hypertension. Okay, now ninth. I think it's a combination of medicine plus pharmacology. Patient with dengue fever with the platelet count of 50,000. What is the appropriate treatment? The options are packed RBC infusion, platelet transfusion, paracetamol shots. Okay. So here for treatment of dengue fever with the platelet count of 50,000. Here if they are not mentioning whether patient bleeding or not bleeding, then easy. Without bleeding, only for this much of platelet count, we can simply treat the fever by using paracetamol. Only paracetamol enough. Okay. Plate was 20,000. Okay, plate was 20,000. 20,000 mean, I think you have to go for platelet transfusion. Okay. Because multigrades. Okay. Multigrade mean better go for platelet transfusion and paracetamol. Steroid going to worsen. There's not good option. That's not a good option. Plate patient not bleeding. 20,000. Plate count is not bleeding. Not bleeding. When the count less than 50 mean better start platelet count. Platelet. I think my platelet and paracetamol is the best option. Hemoglobin 9. So no need for RBC. So best answer, single response to paracetamol, multi-bean go for BMC. Okay. All mention. Okay. Functions are jumbled. two different questions. Only paracetamol. Okay, two questions. I think somebody posted only this question for me only. Okay, I think in this question mean only one answer paracetamol. Okay, now whether this question came, it is from medicine paper, something with the pharmacology, purely medicine paper. A trial drug for neuroarthritis showed reduction of TNF alpha, reduction of IL-6, and reduction of B cell antibody formation. What is mechanism action? It's a typical mechanism of histone deacetylase inhibition. Okay, can you please give what are the other options given for this question? For this question, they mention option one is histodesylase, homothic DNA methylation inhibition. I don't know what are the other options. Can I please post what are the options? Whereas DNA methylation is going to improve antibody formation, is not going to decrease this. Condemns to chromatin. Anybody? What are other options given for this question? No idea. If you able to take live, please post. Single response question mean go for answer. Histone deacetylase inhibition. Okay. Now, I think this question was there, no? A patient on multi-drug resistant TB having anti-TB treatment developed tingling and numbness in the lower limb. Which of following drug most likely cause for this problem? This question was there. Same question with the same option. Can you please confirm, doctor? The same question with the same option. Patient with the option confused. Okay, no problem. Okay. I think answer was histone deacetylase. This was given. See, numbness and tingling is an adverse effect called peripheral. We have one drug called linezolid, a drug useful for MRSA, VRSA, also wonderful drug for MDR TB. It causes adverse effect of peripheral as well as optic neuropathy and causes cheese reaction because of MAO enzyme inhibitivity. So all are very simple question only. Clofazamine common problem, reddish black skin discoloration. Bedaquiline, a new drug for TB, it is mainly causing adverse effect of gastritis, joint pain, also causing QT prolongation. Quinolone causing gastric problem, also causing arthropathy, cartilage damage. Here the answer is for linezolid. Peripheral tingling and numbness, indication peripheral. Next. I think it's one question from antipsychotic patient on haloperidol. We given something about history related to malignant neurotic syndrome. Can you please tell me what is the exact question and what are the options were given? I think somebody posted. So it's a question on haloperidol, the history indicating symptoms of malignant neurotic syndrome. For this case, the best treatment choice means go for dandrolin. Dandrolin, one of the directly acting skeletal muscle action. Okay, and here along with we can supplement bromocriptine. Usually for malignant neurotic syndrome, we go for good hydration, good hydration, controlling temperature, also going for dandrolin. It is the best way. Adjuvantly, we can combine bromocriptine. So, question: they give history of high fever, history of high temperature, high heart rate, and respiratory rate. Okay, okay. The options are dandrolin plus steroid. Dandrolin. Yeah, and it's good. Do go for dandrolin and stop haloperidol. Stop haloperidol. That's the best answer. Stop haloperidol because that's a culprit. and stop haloperidol and go for haloperidol. The dandrolene. Dandrolene, one of the directly acting SMR, that's a very fantastic drug for this case. Okay, so one option they given one option they given bromocriptine plus dandrolene. One option, second option they given a stop haloperidol and go for dandrolene. Okay, and then third option only stop haloperidol. What the fourth option? Fourth option continue and security. Oh, one more thing, continue and security. Continue and security. Okay, doctor, I'll make a question. The right answer, go for stop haloperidol and give dandrolene. That's the best treatment. Now, I think it's one question from beta blocker role in cardiomyopathy. I just want to confirm whether they ask about hypertrophic obstetric cardiomyopathy or dilated cardiomyopathy. Can you please tell me, actor? Somebody posted this one thing, a question from beta blocker in case of myopathy. My question is whether they ask about HOCM or DCMP. Can you please answer? If the question hypertrophic obstetric cardiomyopathy mean first drug of choice will be go for propranolol among the beta blocker. If DCM mean go for a carvedilol. I don't know what the question was. Can you please answer? What was the question asked in the paper regarding beta blocker? One question was came. Anybody regarding it's a related to DCM? Okay, dilate cardiomyopathy for what the option given? Beta blockade DCMP. Yes, there's a definitely role for beta blockade DCMP. Better go for carvedilol or metoprolol or bisoprolol nebivolol. What a question. Dilated LV with dilated LV with heart failure, reduced ejection fraction, which is not true. Which is not true. What is not true? They ask about one option beta used mostly. Beta blocker used mostly. And next option, another one, anticoagulant never given. Anticoagulant never given. Drug used in reduction. Side, okay. I'll get the complete question and then post it, doctor. Okay. The exact question was not clear. Anyway, in DCMP, there is a role for beta blocker, but I have to correct other options also. Okay. Yeah. Next one. I think there's a question. Matching type of question. Very simple, straight question. They given drug name, and the antidote. I think so. Am I right? The same options are given. Can you confirm? Methanol mean antidote pomeprazole. Opioid mean option naloxone. Benzodiazepine flumazenil. Arsenic ball. What the question was? Question of pathology, heart, blood section, HOCM, and what is the okay pathology question? Okay, no problem. Now the same question given after. Can I please confirm? I think state question given drug name antidote. Very simple state question for alcohol, methamphetamine and fibrosol. Yeah, antidote, and for opioid naloxone. Yeah, all are correct option. Yeah, same. Okay, good, good. I think is easy match. Next, I think there's a question on dronabinol was asked. I don't know what is the question. What are the options? Dronabinol, one of the cannabinoid receptor inverse agonist. Cannabinoid agonist, useful for treatment of vomiting due to anti-cancer drug, and so wonderful drug useful to increase appetite also and causes adverse effect euphoria. My question, what was given regarding dronabinol? One question was there. Can I please post me? Please, doctor, after attending session in false regarding, yeah, false regarding Dronabinol. What a question. What's not true regarding also question. Okay, which is not true regarding what are the options? Anybody? Dronabinol, a cannabinoid agonist useful for treatment of vomiting due to anti-cancer drug, and it causes euphoria and increasing body weight also, but options are not able to get. So can you please tell me? Okay. Acts on act on cannabinoid. That's one right answer. And yes, undergo renal route of excretion. Then and many other options. Many other options. Weight gain causing weight gain. It not escape unchanged. It undergo metabolism in liver, become inactivated, and then only undergo excretion. It is not excreted unchanged. Yes, sorry. Excreted unchanged is wrong answer. Excreted unchanged in urine. Wrong answer. It undergo hepatic metabolism, become inactivated, and then only undergo excretion. So it is the answer, which is not true. Mean it is the answer. Okay. Useful in pain also, useful in pain. Okay. But it undergo hepatic metabolism and then only undergo excretion. Okay. So active cannabinoid, unchanged excretion, chronic pain. Okay, ma'am. So answer go for this one. Yeah. Next question. I think there's a question on reform basin. Is there? I think. I don't know what the question. Can I please answer? What is the question regarding basin? There's a question. I think resistant due to what? Resistant due to RPOB mutation. This was discussed in the classroom. But what was the question regarding reform basin? There's a question on resistant due to RPOB mutation. Something somebody posted. What exact question? Anybody? Regarding innovation? Yes, yeah, true about true about reform basin was question, but yes, mutation due to it and fatty meal increases absorption, and then which is wrong, which is true, which is wrong something. There is a question on Ravesan. Can you please post me? We have WhatsApp number also, please. Those attending session, kindly post this question. If you ever take a kindly post or post your question in our DAMS official Telegram channel, I will collect and make you answer. Okay. It's key different. It's a PGP inducer undergoes enterohepatic cycle like this somebody. Okay. So I think multi-response question. Undergoes end solution, which is wrong. Okay, I'll correct the question and make you answer that. Next, I think it's one question regarding newer drugs from migraine shelter, Remigiban. Somebody posted regarding Remigiban. One question was there. What the question? Can I please answer? They ask Remigiban. Remigiban, one of the calcitonin gene-related peptide antagonists, useful for both acute and chronic pain. Is there or not? Come on. Can you please answer? This question was there or not? which is not true about rabbits. So the question is there. Anyway, I'll verify and I'll make it answer. No problem. Now, this question is there regarding remage band. Any questions are there? Remage band, a orally given drug for acute as well as prevention of migraine. It causing vasoconstriction. One option, okay. Second option, it's a CGRP agonist. No. It's an antagonist. It's a CGRP antagonist. And option C and D. What option C and D? It's a CGRP antagonist. Why? Yeah, why so many questions from Mama? That's why Deep Prakash, Pharmacology core, you are a doctor, man, you are a doctor. At the end of the fact, MD or MS, whatever, at the end, after seeing the patient, after investigation and examination, you're going to give only drug only. So, our system is the most important system, doctor. That's why, if you see my workbook, lengthy workbook, see my class starting 8:30, evening 9:20 lengthy session, lengthy book, because a lot of points we are covering in the book, in the classroom. Okay, so pharmacology is most important for doctor. Okay, given some no, it's a oral drug. It's a oral drug, not squares. It's an oral drug. Okay, one more option I want to get from you. Please post me if you find. It's a CGRP antagonist and it's a vasoconstrictor useful for acute and chronic and going for useful orally. Okay. Yes. Next question. This one question. Next question. Yeah. I think it's one question regarding management of cryptococcal meningitis. 50% farmer November 2025. Yeah. Weightage. Good. Anyway, good. Yeah, I think one question regarding cryptococcal meningitis asked. I don't want a question, but there's somebody told there's a question on pharmacotherapy for cryptococcal meningitis. Actually, for cryptococcal meningitis, the best drug of choice mean go for intravenous amphotericin B with oral 5-flucytosine. But I want to know what is the exact question? What is the option? Can I please able to recollect? Okay, actually, for chronic meningitis, the best treatment is giving IV amphotericin B with the oral 5-flucytosine. But can you please answer what are the question? Whether asked only for induction or only for maintenance? What was the question? Yeah. If the induction phase mean the drug of choice will be IV amphotericin B with the oral 5-flucytosine. Maintenance therapy mean go for fluconazole. Maintenance mean with the fluconazole. Fluconazole. It is useful for maintenance. Okay. Amphotericin B, fluconazole, flucytosine. Yeah, one option was amphotericin B with the fluconazole. Second option, amphotericin B with the flucytosine. And third option will be, what is the third option? Only fluconazole. Only fluconazole. And fourth option, mm, fourth option, fluconazole, multi-option, amphotericin B, fourth option. So one is lipohydrogen B with the fluconazole. What is the fluconazole? So the best single response question for induction phase mean go for IV liposomal amphotericin B with the 5-flucytosine. It is oral drug. Induction mean go for fluconazole. Okay, right. So fourth option I should get it. Next question. Yeah, I think there's one question from based on Adverse reaction of beta to agonist based question. So very common question only. It's very common only. For example, I have a drug called salbutamol, a beta agonist. The most common area they causes high tremor, palpitation, hypokalemia, and hyperglycemia. Can you please answer what was the question and what are the options? So we told there's a question on beta agonist ADR. Beta agonist means the most common ADR tremor. Next comes palpitation, then comes hypokalemia, and then okay, yeah, that's good. Okay, all are true. All are true except okay. I think this one. Beta agonist can cause all of the following adverse effects except okay, which is least. Which is least. It causes only hypokalemia, not the hyperkalemia. It causes only hypokalemia, not the hyper. Because salbutamol useful for treatment of hyperkalemia. It causes only hypo, which is not the yeah, which is not the side effect of solbut or beta agonist. The answer is hyperkalemia because beta agonist causing only hypokalemia, useful for treatment of hyperkalemia. Okay, next. Come on. Options are same option or something, any other different option. Can you please check same option given or some other option regarding ADR? Whether option same option or extra different option. All are correct except was asked was alkalosis. Also alkalosis. Then what other options? Come on. Somesh, can I please answer? What are other option given? Same options. Okay, good. Next, I think this one question based on channel blocker. I think one question based on channel blocker. One option was pulmonary vaso. One option was pulmonary vaso. Yeah, beta agonist causing vasodilatation. Here alkalosis. One more thing, pulmonary vaso. Yeah, they will cause vasodilation. Yeah, yes, good. Good. Okay, next question. I think this is a question on cha- child blocker. What is the question at that? I think options were this, which one, which drug blocking channel, something they asked, I think so. Digoxin sodium, potassium, 8-phase pump blocker. It's not channel. I think calcium channel blocker. They given verapamil or diltiazem something. Potassium blocker or what they asked. Also, funny soy blocker, ivabradine. But what was the question? Can I please able tell? Sodium marked in image. Okay. Sodium, potassium, 8-base was marked in image. Which drug that acting? Yeah. Three channels were given. Sodium, potassium. Okay. Three channels like sodium, potassium, calcium, sodium, which is okay. So they given sodium, potassium channel, one channel. One more thing, calcium channel. One more thing, sodium channel, which is inhibiting sodium, potassium. Yeah, sodium, potassium mean go for digoxin. So sodium, potassium. Whereas evaporating, funny current, sodium blocker. Evaporating, funny current, sodium blocker. Okay. And calcium blocker, verapamil, diltiazem. About sodium, potassium. I think this one. So that means answer the image question. They give an image of sodium, potassium pump, one more thing, sodium, one more thing, calcium, which is inhibiting. Answer go for digoxin, sodium, potassium pump blocker. Yeah. Arrow was here. That means go for digoxin. Good. Next question. I think this one question based on helminthic infection. What is the question after? I think one question was helminthic infection. I think options are same option, but I don't know what the question was. What is the question? Whether about lung flu or something about any other infection. Some helminth infection was there in your question booklet. Somebody posted. prosequental, albendazo, ivermectin, niclosamide. What answer? Any idea? What was the help? I think the image one microbiology image based question. One helmet the organism image was given for this infection. What is the record choice? Something asked. Any idea? Paragomoniasis. Yeah. Lung plug. Paragomoniasis. Okay. For this choice will be prosequental. For most of the micros discuss. Okay. My friend, so yes, this already okay. Right. So for this question, answer prosequental, no problem. Yeah, good. It's a micro and pharmacology. Myself and so we are same college, so same like the micro and pharmacology is question, combined question. Yeah. Good, Prakash, good. Answer prosequental. Okay. And I think one more question regarding Phenerenin. Can you please answer? What a question? Yeah. One more question. What regarding brain? What a question? Last question. What is the question of Phenerin? It's a non-steroidal mineralocorticoid receptor antagonist useful for diabetic CKD patient with heart failure. What a question? Doctor? Can you please pose the question? So if we look at the recall question, we covered almost 20 to 23 questions. All the questions, all the options, all the important material is there in your workbook. That if you go and see the workbook, everything is there, nothing new. There's no new drug at all. But somebody telling something find difficulty. It's not pharmacology, everything covered. Only thing time management. So anyway, may God bless you. All very best. Expecting a very good result from your side. All the very best. I will collect all the question and I will make you full complete video. I will post it. Okay. Thank you. The options are it causes hyperkalemia, then spironolactone. One more thing, accumulating in liver, accumulated in kidney failure patients, less hyperkalemia. Okay, all these things. So I want to type the complete question with the option. So I don't want to waste time. So this one I don't understand. What is the full question? Phenerin, a non-steroidal mineralocorticoid antagonist, only great advantage, no risk of severe gynecomastia, very good drug for diabetes CKD patient, and reducing heart failure in case of diabetes CKD patients. I have taken complete absence and I post you. Okay. So meanwhile, I'm praying from the bottom of heart. You have to get very good rank. All the very best. Thank you for watching this recall session. Thank you. All the best. Thank you, Doctor.
Okay, Ji, good evening all of you and all the best to all of you. We are going to discuss some surgery question. First of all, जिसने भी अच्छा करा हो वेरी गुड, जिससे बुरा किया वेरी गुड, डोंट गेट डिसहार्टेड. अगर लग भी रहा कुछ सवाल गलत है, जस्ट रिलैक्स फॉर 2-3 days एंड जस्ट रिलैक्स. डोंट गेट डिसहार्टेड, डोंट गेट इलेटेड. पूरा रिलैक्स करो, एंजॉय करो 1-2 दिन के लिए. टेक इट. So I'm going to discuss surgery question. I couldn't get lot many surgery question. I could only see 7-8 questions. So yeah, so this is what I'm saying. Those who feel like ये खराब भी हो गया, it doesn't matter. You see, अभी INICET आना है, अगला NEET आना है. You just have 3-4 months, 3-4 पेपर और होंगे. So I'm sure all of you will pass with flying color. थोड़े महीने की बात है, इसका अच्छा हो गया, बहुत अच्छी बात है. So don't get disheartened. So anyway, I'm going to discuss surgery question. What I found, the surgery paper was basic, but very from certain topics only. Like no question from thyroid, no question from urology. I couldn't see any question from thyroid, no question from urology, and many other topic, major topic were left. Like GIT also was left. Voice not available. Okay, just let me check. Okay. ये वॉइस नहीं आ रही भाई जसप्रीत. नहीं बच्चे कह रहे हैं वॉइस नहीं आ रही. ऐसा so the staff is saying that it is audible. So I think there must be some problem at your end, because I just confirmed with IT team and they're saying it's audible. I think it's okay. So shall I continue? Yeah. So right. Fine. देखो ये सवाल तो बड़ा बेसिक सा सवाल है. This is stage T4D. So that's inflammatory breast cancer, and probably image was also there, family history was also there. So naturally, first you have to shrink the tumor. So you have to give chemotherapy neoadjuvant, no doubt. And breast conservation has no role here. Breast conservation only up to N1 and less than 5 centimeter. So definitely this is wrong. This is stage 3. This is wrong. This is wrong. This is the right answer. And we do give chemotherapy also adjuvant, but adjuvant radio is must. So best answer is 4. I guess this is not a difficult question to answer. भाई breast conservation तो आप early stage में करते हो ना, तो इसमें तो कोई issue ही नहीं है. So I don't think there's any confusion. I'm not confident about the options. So you can tell me the options, because I only got very few questions, that too random options. Most of the students, they only wrote the question or the option. So options may be erratic. If you have right option, just let me know. And if you have any question, I'll be happy if you share it with us. We can discuss it here only. This is another question where the patient has pain abdomen, amylase radio was an option here. Okay, no radio is fine. If it's neoadjuvant chemo and MRM, sorry, even this is fine. This is the right answer. But in practice, we always give adjuvant radio along with chemo. So if radio is not an option, it doesn't make a difference. The answer remains same. The concept is that you have to downstage the tumor, then you do MRM followed by adjuvant radio and chemo. So this part is missing. It does not make any difference. It could have made difference if other options. Okay. So the fourth option was cortical cyst. What do you see here? Why you went for cortical cyst? Where is the cyst here? See, okay, I will add the fourth option as choledochal cyst, but the point is choledochal cyst, but the point is, where is the cyst here? Like choledochal cyst means you should have a image like this. There is no cyst here. See, the pancreas develops from tuber. This I discussed 2 days back in marathon also. This is the ventral bud, this is the dorsal bud. Yeah, image could be different. I don't have the same image. But I'm sure what student told me, that there was two ducts, one here and one here. I'm sure image could be different. I'm not saying you'll have the same image, but the finding should be same. And don't write erratic questions here, like when I'm discussing question, either discuss this question or only write surgery question. So this is the ventral bud, this is the dorsal bud. The ventral bud is duct of Wilson, dorsal duct of Santoni. They don't become medially and fuse. When they fail to fuse and both the ducts are separate, this is called pancreas divisum, number one. Number two, the problem here is the proximal. This ampulla becomes stenotic, causing pancreatitis. And this is the duct of Santorini, ventral bud, duct of Wilson. So dorsal bud stenosis is the problem. And no, the image is not normal. If you look carefully, you will see that this duct is opening proximally, this duct is opening. Both are, there are two ducts here, two separate openings. It should have gone like this, but there is a separate duct here like this. This is called pancreas divisum. First listen what I am saying, then write anything. Don't, just first listen what I am saying. So this is pancreas divisum, which presents with pain, abdomen, pancreatitis, amylase and lipase high, means pancreatitis. What is annular pancreas? In annular pancreas, this is the pancreas divisum, two ducts. In annular pancreas, this duct here rotates. This is a problem of ventral bud malrotation, and it doesn't rotate properly, forming a ring around the pancreas, which is called annular pancreas here, which presents with duodenal obstruction. The third possibility, because I do not have the question, third possibility, those who have marked the cortical cyst could be if there is a cyst here. So a cyst in the wall of duodenum, that is type 3 choledochal cyst, that will present with pancreatitis, that will have amylase lipase high. So you have given the exam, you have seen the question. Now I will tell you what are the probability. Chronic pancreatitis is out of question. Annular pancreas could be there, but annular pancreas does not present with pancreatitis. It presents with duodenal obstruction, vomiting. So annular pancreas में vomiting जरूर होनी चाहिए. This is the annular pancreas causing obstruction of duodenum, number one. Number two, there could be double bubble sign in your paper, in your question. If these points are not there, like pain abdomen, vomiting and double bubble sign are not there, and there is no ring-like pancreas shown on MRI or CT, then this is not annular pancreas, unfortunately. There are only two probability. One is pancreas divisum, where you have two duct. If you see two duct in exam, and if there is a cortical cyst type 3, that also will have the same symptom. So you have to recollect the image. No, annular pancreas does not present with pancreatitis more often. It presents with duodenal obstruction. So I'll repeat, if the image was like this, a cystic dilatation here, then this is type 3 cortical cyst. If the image was like this, one pancreatic duct and one here, then this is pancreas divisum. These are the two probable answers. Most of you are saying there's a pouch, but when there's a pouch, then of course cortical cyst would be the answer. Okay, so that depends what image was there. But if the image was two separate ducts, because pain abdomen, amylase lipase high, with MRI image could be this, and the pancreas chronic I'll rule out, pancreas division of corticosteroids. That depends on the image. Although my gut feeling says they have already asked intramural CBD dilated, what type is this? That was type G, that was critical question. Yeah, pouch was there, then we'll go for, I mean, it all depends on the image you have. If you have image, will confirm, but I will not really go for annular pancreas. Annular pancreas does not present with lipase, amylase and pain abdomen. It presents with duodenal obstruction. The classical presentation is vomiting. Anyway, the next question was a hernia having appendix as a content. Image again would be different. I do not have the same image, and that was a M-Yarns hernia. M-Yarns hernia. So I told you the rare types of hernia in which Mickel's a content of hernia is called Litter's hernia, appendix a content of hernia is called M-Yarns hernia. I told you Dr. M-Yarns was the first surgeon who did an open appendicectomy in 1734, 290 years ago, in an 11-year-old boy. He was the first surgeon to perform open appendicectomy in an 11-year-old boy, and he was the first surgeon to report a case of hernia having appendix as a content. So this is called M-Yarns hernia. This, of course, we discuss in detail when we discuss hernia. And the second was Litter's hernia when Mickel's is a content. So I think this was the question. Image will be different. If there's any doubt, any point you can ask. Okay. Figaro classification is used for. Figaro, I was taking TND lecture on this Monday, 5 days back, on Monday in Calcutta, where I discussed a surgery for chronic pancreatitis, major operation. There I did ask Figaro classification used for what, and one student did answer for chronic pancreatitis, and that was a question they asked. That was not a question in TND, but I did discuss this particular point. Figaro, I guess you know, this is for chronic pancreatitis. International classification, where T stands for toxic and metabolite, I idiopathic, G genetic, A autoimmune, I recurrent acute, and O obstructive. So this, of course, we discuss in chronic pancreatitis discussion. So I don't think there's any doubt, any confusion here. Anything you want to ask here? Any particular issue? Now this I would like to know from you. They did ask a question where an image of bariatric surgery was given, and they asked what is the name of the surgery. In May this year, they gave this image. In INICET May 2025, this image, and asked the name of the surgery, and this is SARDI-S. So how to identify with Roux-en-Y the whole stomach intact is Roux-en-Y gastric bypass, with Roux-en-Y and distal gastrectomy, this is BPD, biliopancreatic diversion, Roux-en-Y and sleeve gastrectomy, this is duodenal switch. So Roux-en-Y gastric bypass, biliopancreatic diversion and duodenal switch, both are Roux-en-Y, but how do they differ? In Roux-en-Y gastric bypass, the whole stomach is preserved, nothing is removed, it's reversible. While here with Roux-en-Y, you do distal gastrectomy, BPD, and here with Roux-en-Y, you do sleeve gastrectomy. And if sleeve gastrectomy has been done without Roux-en-Y, then you call it SARDI-S. The difference in SARDI-S and sleeve gastrectomy and duodenal switches, both are sleeve gastrectomy. This is SARDI-S, but in one Roux-en-Y done, in one Roux-en-Y not done. So if this image is given, this is BPD, biliopancreatic diversion. So I guess these are the 4 images that they can discuss in malabsorptive surgery. This is the Roux-en-Y without distal gastrectomy. This is Roux-en-Y gastric bypass. This is without Roux-en-Y sleeve gastrectomy and bypass. This is SARDI-S. This is sleeve gastrectomy Roux-en-Y duodenal switch, and this is BPD. So this one is BPD and this one is duodenal switch. Yeah, if the middle image was given, this one, then this is BPD, biliopancreatic damage. I'll repeat. If Roux-en-Y you get, there are three options only: Roux-en-Y gastric bypass, BPD and dinner switch. How to differentiate? In Roux-en-Y gastric bypass, the whole stomach is preserved and bypass. In BPD, distal gastrectomy done, and in dinner switch, sleeve gastrectomy done. And in SARDS, no Roux-en-Y, only sleeve gastrectomy and bypass. So as you said, middle photo was given, so the answer is BPD. So do you, all of you, agree that middle photo was asked? So do you agree middle photo was asked, or there was something else? I mean Roux-en-Y and distal gastrectomy. Yeah, common channel 0.5 meter, not 0.5 centimeter. 50 centimeter, then 100% this is BPD. If common channel was 50 centimeter, Saurabh, then this was BPD. Only in BPD common channel is 50 centimeter. Here in dinner switch the common channel is 100 centimeter, and in SARDS the common channel is more than 250 centimeter. So if common channel was 50 centimeter, then this was definitely BPD. So Saurabh has written something that confirms the question that this is BPD. Okay. So all those are marked BPD, that's the right answer. Now this question also is very confusing. I do not know what the question was because I could not get image. Of course, forget about the image. You tell me what the question was. There was a cystic tumor of pancreas, age was probably 55, female, CEA high, and a cystic lesion in pancreas. What was this the question, or something else was there? And they asked the diagnosis. Forget the image. I'm sure image was different, but whether image was there or not, I'm not sure. But I think, was this a question that pancreatic tumor, 55-year-old female, CA high? Would you like to add anything here? Like, what are the options? What was the question? Yeah, on the rocks, if middle image was there, so it is BPD. उसमें कोई doubt नहीं है, वो BPD था. So, no image, that's okay. But question क्या था? What was the question? CEA high, amylose low. Good. इसी से diagnosis बन गई. CEA high, amylose low. Now the and mucin is there. This is mucinous cyst adenoma. Mucin is there. This is mucinous cyst adenoma. Why? Because first of all, serous is gone out of picture, because in serous you don't have mucinous content, no CA. Serous amylase can be high, CA is not high. Another option is IPMN, intraductal papillary mucinous neoplasm, where the CEA can be high, amylase is also high, CA 19-9 can be high, but IPMN you get after 60 years, slightly more common in male, and this is usually dilated duct and intramural nodule. So if CEA high, mucin present, amylase low, and a cystic tumor, this is mucinous cyst adenoma. These features, and age 55, relatively young age and female, all this is suggestive of mucinous cyst adenoma. So that's the right answer here. Yeah, lesser sac means coming to pancreas, coming from the pancreas. Lesser sac is just anterior to pancreas. So if it is protruding lesser sac, means either it's posterior wall of the stomach or anterior wall of the pancreas, it is pancreas. So this was mucinous cyst adenoma. Okay, I guess what you have written 3-4 lines, 55-year female, mucinous tumor, high CA, less amylase, this is definitely mucinous cyst adenoma. There is no confusion here. IPMN is usually in male after 60 years, and they will either write dilated duct or intramural nodule or fish mouth appearance of ampulla. These are the features. What feature you write is basically suggestive of mucinous cystadenoma. Like this, fish mouth appearance, dilated duct, this is IPMN. Sequence of steps of hernia surgery. Was this a question there? Did you have a question like this? Any question like this? Sequence of step in hernia surgery? Okay. So yes, this was a question. First you go for incision, then you repair the defect, ligate the sac at the deep ring, then you put the mesh over the fascia transversalis, and then you close the wound. So this is the right step, right sequence. So first incision, then repair the defect. This what you do here, ligate the sac and cut at inner ring. Then you place the mesh and then go for wound repair. So this is the step. I guess this is not very difficult. Most of you must have marked it correctly. Okay? Yeah. Repair the defect, that's option 2. So identify the sac. This is done by ligating the sac at the inner ring. So whether they say identify the sac or ligate the sac, they all are. So mucin low was not the option. Mucin must be high. Amylase is low, mucin high. Everyone is saying that's the option. Yeah. So dissect the sac, push the sac, ligate and cut at the deep ring. That's the second step. The third step would be mesh, and fourth is wound closure. So whether they say reduce the sac, ligate the sac, cut the sac, repair the defect, all these are second option. Okay, reduction of content also is option number 2. This you do in second step. So I guess here also, देखो, इसमें तो confusion है that incision with the first step. Then you separate the sac from the cord, open the sac, put the bowel back in the abdomen called reduction, reduce the content, ligate and cut the sac, and then you do the repair by mesh and then do the wound closure. So this is the step. So basically, maybe repair of the defect is not the option, ligating the sac is the option, reducing the content is the option. They all are step 2. Now, there was a question, not the same image, of course. Right. So on the rocks, the first will be incision, then push the content from the sac in the abdomen, then mesh placement, and finally wound closure. This is the step. Okay. So not the same wording and same image, but the question was someone having tingling and numbness in the right hand and problem in the vision, X-ray showing a mass in the upper part of lung. What is the next step? This was Horner syndrome seen in the apical tumor characterized by ptosis, meiosis, anhydrosis and anophthalmos, which I have discussed in GT. 2 or 3 questions were there last year in GT on Horner syndrome. And Pankos tumor you can say, of course it's Pankos tumor. The next step should be CT and biopsy to confirm that this is a tumor, usually squamous cell cancer. So the image may differ, the wording may differ, but the approach will remain same. You will not order ultrasound for thorax unless collection. Nerve conduction velocity has no role unless I am considering some nerve injury at the spine or in the superior. Yeah, no Pankos tumor. No, I don't get the point. No, was there no image or no Pankos? There was no tumor in the image. Or not a question like this. I think there was a question like this, where there was an image in the upper part of thorax, in the, lung, and then there was features. And why vision? Due to meiosis. So there was another surgery, hernia surgery with photo, that was an amnion hernia. We have discussed that already. Appendix, photo and a hernia. Okay. So, yeah, so that was one question. They did not mention Pancoast. They only showed the X-ray and the features they said. The brachial plexus are compressed, causing tingling numbness usually at the little finger side. See it even not this thumb side, not radial side, one of ulnar side. So presentation of ulnar nerve compression, little finger, and nerve conduction velocity that you do for neurogenic pain. Nerve conduction velocity. Okay. So this is C. I guess this is not a difficult question. Now another question somewhat like this. Again, I am not saying the same wording, not same image, but probably the image somewhat similar to this. History of trauma, unconscious patient, 2 episodes of vomiting, image given, image showing biconvex, lenticular, extradural. What is the next step? So I guess there was a question like this. Was it similar question or totally different question? Did you have a question like this? Yeah, it's extra EDH, of course. So is it similar or something different? Was the question like this only? And what did you mark? So what did you mark? What is the right answer here? Yeah. Chronosphere, Shweta, Saro Chauhan, the Wolf Logan, Prakhar. No, Wolf Logan, sorry, A is not the answer. Okay, there can be some confusion because I have written cranioectomy. Maybe in the option it was craniotomy. I am not sure. They could have given craniotomy as an option, not as a craniectomy as the option. If craniectomy was the option, then there is no doubt this is not the answer, this is the answer. Okay, that's the first point. If craniotomy was the option, not craniectomy, but craniotomy was the option, then okay, not the next step, appropriate. This is the question, right? So appropriate was the word. Was this craniectomy or craniotomy? Okay, so some people saying craniotomy, some saying craniectomy. Okay, now don't try, just listen what I am saying. Dekho, if craniectomy was the option, then there is no doubt the answer will be D. The difference in craniectomy and craniotomy is, in burr hole, we just make a hole here, which is emergency surgery, hardly takes half an hour, and you can evacuate the hematoma. It's only to drain the hematoma in emergency. By burr hole, I cannot do any removal of brain tumor or anything. Craniectomy means I remove a piece of the skull. In craniotomy, I don't remove. Burr hole is a hole. What is craniotomy? Make 4 burr hole, connect all burr hole, detach a piece, elevate it, do the surgery, put it back. So I am not removing it. And in craniectomy, you remove it. So in extradural, craniectomy is never ever done. Only confusion will be D and craniotomy. If craniotomy was the option, forget about answer D. When craniotomy was the option, now some of you will get confused that whether the answer should be burr hole or the craniotomy. Now there is a problem, and this is not at your level, it shouldn't be asked from you. Craniotomy should not be given. Normally in emergency for EDH, burr hole will suffice. You only have to, first of all, do we need surgery? Definitely we need surgery. there is very significant midline shift. You can see here, which is more than 0.5 millimeter. More than 0.5 millimeter is the indication for surgery. If craniotomy was the option, then the student may get confused whether we should do burr hole or we should do craniotomy. Ectomy is not the option. Now, out of these two, for EDH, in emergency, burr hole usually will suffice. Make a burr hole, evacuate the hematoma. Where should we do craniotomy? Craniotomy, where should I do a bigger opening? When I have to remove a big hematoma or a recurrent hematoma or EDH, subdural hematoma. For subdural, I do craniotomy. Craniotomy को तो हटा ही देते हैं. We never do craniotomy here. So let's remove the craniotomy option. Craniotomy we do in Dendy Walker, an area where we remove. So between craniotomy and burr hole, I'll repeat. For EDH, normally in emergency, burr hole is sufficient with evacuation of hematoma. But for subdural hematoma, for recurrent hematoma, for massive hematoma, we do craniotomy, where we remove a piece of the skull. And then put it back, of course. We are not remove it permanently, which is why autoimmune, not ectomy. So, unfortunately, those who have given answer A, if there is a ectomy, then there is no chance in this correct. If it is otomy, then again, I think that should not be the right answer. Had it been subdural, then it would have been the right, or recurrent hematoma, then I would have gone for craniotomy. Here in emergency for EDH, normally we do burr hole. Burr hole will suffice to evacuate the hematoma. So I guess the right answer should be D here. Now, probably, I am not sure, there was an image of pneumothorax and they asked what you do here. So, is this point clear? Is this particular question clear? I'll repeat it for you if you want me to repeat. I said a EDH surgery should be done when the midline shift is more than half millimeter. Of course, half centimeter. Of course, it's there, so it'll do. Number 2, all EDH are emergencies. They should be operated immediately. There's no chronic subdural. Number 3, confusion craniectomy ko to nikal do. That's not in the picture. Confusion between craniotomy and burr hole. For EDH in emergency, usually we do burr hole and evacuate the hematoma. But for subdural hematoma, recurrent hematoma, or for massive hematoma, then we do craniotomy. Now, image of pneumothorax, what is the treatment? Can anyone write the question and option? Because, okay, doesn't matter. Even if HRCT image was there, if it was pneumothorax, treatment will remain same. What was the question of pneumothorax of HRCT? So, what was the option of HRCT pneumothorax? I mean, if not trauma, then what was the question? If it's not trauma, it's not under surgery. I'm sure. Okay, forget about this image. What was the question on pneumothorax? Even HRCT was given. What is the option? What option was there? Did this develop after trauma? No, don't tell me what you have marked. You have marked needle decompression. I understood. One option was there. I am asking what was the question, what are the options? Because needle decompression is not the only treatment you have. Bilaterally, trauma not mentioned. It was a spontaneous pneumothorax due to emphysematous bully rupture. And bilateral lung margins were blocked. Sudden onset breathless. Good, very good. And cough. Absolutely fine. Good. So now I have understood the gist. It was not a question of trauma. It was a sudden shortness of breath. High resolution CT showing bilateral pneumothorax. Now tell me what was the grade? Was it very severe? And what were the options? Tachycardia, tachypnea, bilateral breath sound bilaterally. Good. What about any option of raised JVP or Very severe dyspnea, raise JVP. Any question like this? Why I am telling you this? Because it was a tension pneumothorax, then we'll go for needle decompression at 5th intercostal space. And it was a normal pneumothorax, then we go for ICD, intercostal drainage tube. And if the pneumothorax is less than 30%, like pneumothorax is only periphery, this is lung and this part is pneumothorax, then the answer could be conservative as well. So all three methods are there for pneumothorax. Tension pneumothorax managed by needle decompression. A pneumothorax without tension pneumothorax is managed, closed pneumothorax managed by ICD, and a minimal pneumothorax less than 20% managed conservatively. So what was the option? Only needle decompression, that's the right answer, Tanushree. Then I think if only needle decompression is option, then that's the right answer. What was the question? I have understood. What were the options? Can anyone write the option, please? One was needle decompression. What were the other options? And that is not a trauma, so that goes in medicine as well. What other options are there? Okay, anyway, let's go to, and I'll repeat. See, if it's a sudden development of pneumothorax and emphysema bully has ruptured, you can go for needle decompression temporarily. Finally, ICD is required. Permanent treatment ICD. But if the pneumothorax is very minimal, less than 20%, then you can even manage conservatively also. But I think the right answer here is needle decompression. What I can gather from the question, that needle decompression is the best answer here out of whatever you have written. Now, maximum tissue reaction is seen in, probably this was a question there. And can anyone write the fourth option? Meanwhile, can anyone recollect any question from thyroid, question from urology, question from head neck? So, was this an option there? Maximum tissue reaction is seen in? Yeah. What was the fourth option? Of course, out of these three, this is the best answer. Chromic catgut is absorbable natural suture. Polyglycaprone, okay, good. Polyglycaprone. Polygam. So, polygalactin is Vicryl, polydiaxone is PDS, and polyglycaprone is monocryl. What you need to know about monocryl? This is best for subcuticular suture. What you need to know about Vicryl? This is the best suture for GIT and urology and liver, hepat. So, chromic catgut natural coming from sheep gut submucosa takes about 60 to 90 days to get absorbed, absorbed by enzymatic degradation. Which is why phagocytosis, which is why it gives the maximum tissue reaction. Can anyone write thyroid question? What was the question? Yeah, whether it's catgut or chromic catgut doesn't matter. The answer will remain same. I will tell you why. The only difference, PDS is polydiaxone. Polydiaxone is PDS. Same. Because chromic has only one function in catgut, it increases the life of catgut. Catgut is light blue in color. Catgut is light blue in color and light yellow in color, and gets absorbed. The tensile strength is lost in hardly 3-4 days and get totally absorbed in 2 to 3 weeks. So, it's not good for GIT or any, except for fat. We don't use catgut anywhere. But chromic catgut has tensile strength which is higher, half-life is more and overall life is more. So chromic has only one function in catgut to increase the tensile strength and life. Tissue reaction whether catgut or chromic catgut remains high. Both have high tissue reaction. So answer remains catgut. There was a question like post laparoscopic ostectomy 200 ml fluid collection. Next step. Normally for this, if there's anything like peritonitis, then we go for exploration. If no peritonitis, then we go for wait and watch. Just drain, pigtail drain and wait and watch. This is what we do. So, for 200 ml collection, wait and watch is the best option. With a drain, you have to put a drain and observe. Unless there is a peritonitis feature, guarding, tenderness, pain and fever. No, not pain and fever. Guarding, tenderness, rebound, word like this. ERCP and stenting we don't do immediately. Only do percutaneous drainage. No, the best answer is not antibiotic, not ERCP. If it is early case in 200 ml collection, just do a drain and wait for some time. If the leak persists, yes, percutaneous drainage. This is what I am saying. Pigtail drainage means percutaneous. That's the best option you have. Go for percutaneous drainage, wait for some time. If the leak persists, then go for pigtail is placed percutaneously only. So percutaneous drainage means pigtail. Most likely, this is surgical abdomen, but you have to go for ERCP. Yeah, if there is a cystic stump leak, then the answer is ERCP and stenting. So if there are two questions as I could gather. One question says cystic stump leak. Then the answer is ERCP and stenting. One question says collection post-operatively. Then the answer is percutaneous drainage. And this is generally done by pigtail catheter. So if there are two questions, there are two answers. As someone said, cystic stump leak, I am not sure whether the question was cystic stump leak or not. If cystic stump leak was there, then the answer is ERCP and stenting, and only for collection around the gallbladder after gallbladder surgery, the answer is drainage. So if there are two questions, there are two different options, two different questions. So stump leak was a different question. As I said, first I'll repeat. For stump leak, this is Strasbourg type A, ERCP and stenting. And if there's a collection, for that the answer is percutaneous drainage. Is this thing clear? And meanwhile, if anyone could write parathyroid question or thyroid question, that will be helpful for me. So I guess you have understood this. Two different questions, two different answers. Okay. See, this goes in physiology and medicine, but it also comes in endocrine in surgery. We all know Conn syndrome means more of aldosterone, which has a job of sodium water absorption. So when it's more sodium, more water, less potassium, less hydrogen. Conn syndrome will have hypernatremia, water retention, hypertension, hypokalemia and alkalosis. But huge and hypertension as well. But water retention normally alkalosis due to hydrogen loss, sodium absorption causing hypernatremia. But there is aldosterone escape phenomena that leads to water loss. So water retention is not that severe. Alkalosis, of course, you'll find. Hypernatremia, you'll find. Hypokalemia, you'll find. Hypertension, you'll find. All this you'll get. I'm not sure what the options were. So, if you have any other question, any other doubt, any other which will help other students as well, I'll wait 2 minutes for you to write. But we'll not discuss. This goes in medicine and this goes in endocrinology and physiology. The aldosterone function is absorption of potassium and hydrogen. So, when it's not absorbed, this will lead to hyponatremia, hypokalemia. So, can anyone, any other question was there from surgery, especially the parathyroid one? I'm waiting for parathyroid question. Yeah, renal HCO3 compensation is there, aldosterone escape phenomena is there, all these features are there. Yeah, one question was about burn. Yes, Pixie, that's correct. Burn question was a image based question, if I gather correctly, and that was a superficial burn. So, that was a superficial burn. A blister was already ruptured. So, these were the options. Then alkalosis is the answer. Hypertension you do get, hypernatremia you do get, hypokalemia you do get, alkalosis. These were the options. So, then alkalosis is the best one. Yeah, degree of burn due to wet burn, hot milk, that was a stage 2 burn, grade 2 burn, partial thickness, superficial burn. That was the photo shown. Superficial, partial thickness burn. If superficial, yeah, pinkish skin with a angle between working instrument, that is a manipulation angle, 60 degree. So, this is the abdomen, one port is here, this is for scope, this is for camera, these are instrument. So, I am writing I and I for instrument and S for scope. So, angle between scope and instrument, this is called azimuth angle. Instrument and scope, azimuth angle should be ideally 30 degree. An angle between two working instruments is called manipulation angle. So, two instrument is manipulation angle and scope and instrument is azimuth angle. Two lap instrument is manipulation angle. If there are blisters, then it's always moist burn. Only moist heat can cause blisters, can cause vesicle, not dry heat, not chemical burn. Only if you are getting vesicles, then this is most likely superficial partial thickness burn, moist burn. What was the question on laparoscopic? Let's take me on the steps. Can anyone answer question or give options of laparoscopic ostectomy steps? And that's the last part. Then I'll stop the streaming. Another faculty will come. I'm waiting for two things. One is a parathyroid question number 1. No, moist burn. If vesicles are there, you go for moist burn. Chemical burn can cause vesicle, but there's a feature of moist burn. And mainly grade 2 burn. Moist burn, grade 2 burn will cause vesicle. Hirschsprung disease. What was the question of Hirschsprung? I had no idea that Hirschsprung has been. Crocodile skin you don't get in burn. Crocodile skin must be some different question. Crocodile skin you get after meshing of partial thickness graft. The sequence is create pneumoperitoneum, dissect calloid triangle, ligate the cystic artery first, then ligate the cystic duct, separate the gallbladder from the liver and take the gallbladder out. So, what is false about Hirschsprung? What were the options, Tanushree? Can anyone write the options of first? Yeah, first create pneumoperitoneum, dissect the calloid strangle, ligate the cystic artery, ligate the cystic duct, and then remove the gallbladder from the liver and take gallbladder out. This is the step. First is pneumoperitoneum creation. I'll write down. First is insufflate CO2 and pneumoperitoneum. Second, dissect calloid strangle. Third, ligate, or you can say clip. Clipping and ligating is same. Ligate the cystic artery, and ligate means cut, clip. Then ligate the cystic duct, then separate gallbladder from liver, leaving the cystic plate behind, and then take the gallbladder out. Asynchronous peristalsis, preganglionic segment collapse. No, preganglionic segments are dilated. They are dilated in Hirschsprung. The dilated part is the normal part, preganglionic. Proximal segment is not constricted. Phoenix, you are right. Phoenix proximal segment is dilated. You are absolutely correct. So, I think I'll stop now. I was waiting for the question of parathyroid, which I could not see. You see hot water, hot tea, hot milk with vesicles, red base, pinkish base. This is grade 2 burn. So, the proximal part dilated is not aganglionic. The distal collapse part is aganglionic. Right. So, I'm going to stop the streaming. Another faculty will come now. Meanwhile, if you are connected to Telegram, you can write the question of parathyroid on Telegram. Formation of pneumoperitoneum is step number 1. That's step number 1. That's it for today. All the best to all of you. Thank you.
Hello, I hope you all can hear me. Yes, shall we begin? Good evening, everyone. So there are only 5 questions of psychiatry, and I think I have uploaded them all on Instagram, Telegram, WhatsApp, wherever you can see them. But still customary to do a recall. So the PowerPoint presentation is open in front of you from which I am discussing. So if there's any change in the question language, kindly let me know because these questions will be finalized based on your inputs. Moreover, there are students who might not be attending this live, might be seeing it as a recorded video. So if you are seeing a recorded and you see that the question language needs to be edited, you can inbox me later. For all those who are attending live, Tanushri Mukhopadhyay, Prakhar Shingal, Pawan, Sandesh, Phoenix, is my voice clear? Shall I begin? Am I audible to you all? Just one of you can confirm so that I can go on. Yes, thank you, Vishal Sharma. First question, a 7-year-old child. Can somebody confirm me the age? 7 year? Perfect. Yes. History of anger outburst episodes many times in a week. Many times, not once, which are out of proportion to his age or developmental level. Was the word outburst mentioned or was the word episode mentioned? Was it outburst or was it episode? Okay, age is confirmed. Was this word mentioned out of proportion? Because this is a very important part of diagnosis. Was out of proportion mentioned? Was the word out of proportion mentioned? Multiple episodes? Because if the episodes are out of proportion to age or development level, is the question okay now? I have removed out of proportion. IED was not an option. Option was ADHD. Okay. Some students said IED was in the option. Was this mentioned irritable episode for most of the time for the last 1 year? This is a case of disruptive mood dysregulation disorder, DMDD, disruptive mood dysregulation disorder, in which the person has anger outburst more than 3 times per week, plus irritable mode for most of the times in between the episodes also, DMDD. Could you mark this question correct? Avanish is saying out of proportion was there. Avanish, out of proportion to age or developmental level, because it's a part of diagnostic criteria of DMDD. Done? Can we go ahead to the next question? Question 2. Was only this much information mentioned? Question 2. Question number 2. Only this much information? A person derives sexual pleasure with non-living thing. A person derives sexual pleasure with non-living things. Any other statement that I have missed? Out of proportional to duration. Is the question okay? Everybody answered this correctly in the exam. Fetishism, inanimate objects. Could all of you answer this correctly? Can you see that I am editing the questions as per your recall? Purpose of the recall is to tell you what was asked, you answer this correctly. Psychiatry questions are all completely recalled with full statements. We will not keep anything incomplete today. Okay, next question. Is it similar to a PYQ? Do you remember not concerned with the blindness? Was it mentioned? Vishal, I have already authored a Q bank. Is this question correct? Sudden loss of vision, sudden onset sensory motor loss after an accident, all examination normal. So it is a case of conversion disorder. Could you all answer this correctly in the exam? It is similar to a PYQ. I discussed this question day before yesterday in marathon as well. I discussed this question in main class. C&D class. I hope you people who have been taught by me, they are aware about this concept. Sudden onset blindness after stress factor, sensory motor neurological loss of function after a stress factor. Let's go ahead with 4. I suppose I have told you EPS is an important topic. Extra pyramidal side effects. Could you recall this question? Any other thing mentioned in the question that I have missed? I think this question has been discussed by pharmacology faculty also. Thiru sir had discussed this question. Any other word that I have missed? Could you figure out that this is a case of neuroleptic malignant syndrome? Was raised CPK mentioned? Was raised CPK given in the question? Raised CPK was mentioned. Could all of you answer this? I think psychiatry was not difficult at all this time. Maybe other subjects troubled you more. Like the fifth one is definitions. I have already correctly matched. Was it like permutation combination 1A, 2B, 3C, something like that? Was it some permutation combination given? Could you answer grandiosity, rich, nihilism, I am nothing, thoughts are in control, influence, somebody is planning to the. Now tell me, how was your in psychiatry? How many could you score? Any doubts? Any other question related to psychiatry? Narcissistic is not a uh, narcissistic is not a delusion. It is a personality. Narcissistic is not a delusion. I think you missed it. Any question where you need some discussion or understanding? I think everything is clear. Okay. Wish you all the best for exam results. Thank you. Bye bye.
Hi guys, Wish you all a very, very good evening. Just give me a thumbs up if everything is fine. No, I won't take, I know, much time of yours. Patho still arrived, right? Prakash, so please tell me, how was pathology? Good evening, Tanushri. I could collect not much, very unexpected for me to see pathology, just 9-10 questions. Prakash, Tanushri, I think we got 9-10 questions only I could arrange. Please help me out with the options and the questions without wasting much time on what I've got. Would definitely need active participation of you guys. I know it's very hard to do. Just try a level best. Please change the question for whatever sources I could arrange. I have arranged the pathology questions. So guys, first question: a patient presents with fever with the mass over the mitral valve. Histopathology: GMS stain positive. GMS stain is a fungal infection. So there was an image-based question, right? And if I remember, the image was, this was the image given. So we know septate है, aseptate है, patla sa hai. You have gone through my back to basics wali videos. You know this. The condition is aspergillus. Was this the image? हमने पढ़ा था aseptate है, patla sa. Aspergillus is thick, 45 degree, thin, sorry, and mote wala thick is acute branching, 45 degree पे. Aseptate wala, it has to be aspergillus. Acute branching है, apps है, acute angle branching है, so it has to be aspergillus, right? So great. So this is the question. Great. Acute branching hai, you will go with aspergillus. Great. You've gone through best videos. We know this question. Anything that you need to add on, just add on, guys. Next is which of the following are correct regarding rheumatic heart disease? हमने पढ़ा था A for aspergillus के A for apps है, यानी septa है, and M for mucor is mota, thick fibers. Now, which of the following are correct regarding rheumatic heart disease? As far as I know, we got two questions on RHD, right? One was on this histopathology and one was on the revised Jones criteria, right? That obviously medicine people will discuss. But which of the following are correct regarding RHD? Any inputs, please. I really appreciate that. Rheumatic heart disease shows Ashoff bodies, yes. Okay, acute rheumatic fever. Okay, Baba. Thank you. Rheumatic fever, okay. So, group B Streptococcus involved? No, it is group A. Only myocarditis? No, it is pancarditis. So, rheumatic fever was for the Jones criteria, right? And options are pretty much same, Baba, or different, totally different. Okay. So, there was one question on RHD card, Jones criteria, and there was one question on rheumatic fever. That's what you're telling me, guys. And any option that you could recall, Baba? Divya, Shweta, Prakhar, Karan, Tanushri. Two weeks after Streptococcus infection. Thank you. 2 weeks after Streptococcus infection. Okay, one option. Almost same option. Third option, only myocarditis, no endocarditis. Okay, done. So then obviously answer is D. Answer is A, sorry. Associated with aortic valve rupture? No, it is associated with mitral valve rupture. Either group A hai. Great. So answer is A. Straightforward. So systematic pathology, you know this. We have know this. Acute RHD. A for have Ashoff bodies. Will have A for NH cells. Done. Thank you so much, guys. Thank you. No image in this question, right? Any image of Ashoff nodules given in this question? Acute valve rupture. Prakhar, acute valve rupture, RH, rheumatic fever, it doesn't make sense, Baba. Cockroach, then occur. No image. Chalo, next question. Again, multiple sources to make this question. Which of the following are right regarding the stains? They mention the stains, unusual thing, then the color, and then the thing that it stains. First Prussian blue stain give blue color, iron. Right? Yes. Alizarin red for calcium, black. No. It gives red color. Von Giessen elastin blue. No. Von Giessen give black color. Okay, Baba, got it. And Jimsa Sen masked and purple. So Pearl Prussian blue was blue and for iron, right? So two options, right? Multiple answers were there. Okay, so it was not Pearl. Okay, so that is the wrong option. Okay, so if it's Pearl Prussian red color, then obviously it is a wrong answer. So then we have got only one answer, that is Jimsa mast cells purple color. So I think easy question. I'm sure all of you would appreciated this. Iron is blue, calcium is black, alizarin red is red, von Giessen is black. So answer is D, right? So only thing that matches is the Jimsa stain. But Tanushri, Divya, we have got only one correct match, right? Anything that we need to add on? Only one correct answer, right? There was no confusion with other options, no? Okay, chalo. Thank you so much, guys. Which of the following is true regarding HPV virus? Now again, two possibilities. One, they said it's a straight away HPV virus was given in the question. And then they said there was some image. So if image was given, was it the gross image? The lesion was given? Or was it, can you please tell me the image that I could arrange? Sir, कुछ image आई थी. Okay, multiple correct option. It was a multiple correct option, but then we have only one correct answer. बताओ मेरे को. True regarding HPV virus. So can you give me a hint? No image given. So it was straight away Phoenix. So it was straight question tha. It was only on HPV virus. They mentioned it HPV virus. Am I right? No gross, no microscopic image, no proliferation wala face, nothing, no image. The following is correct regarding HPV virus. If that is the case, Phoenix, then no vaccine available. That is a false statement. Oncogen is absolutely right. Image of skin. One side normal physiology of the skin, other side. Okay, Pushpa. Diagrammatic image, one side skin layers. Okay, got it. So they added an image of replication of virus. Okay, so they took an image from Robbins and they are telling. So they didn't mention HPV virus. It was not in the name. And they gave an image of physiology of involving the skin of image of replication in epidermis. Great. So any coilocyte, something was given. They mentioned coilocyte. Okay, thank you, Prakhar. Image was there. So was it an image that was difficult to appreciate that it was HIV virus? HPV virus? There are some people who are telling, sir, only history was given of HPV virus. And there are some people who are telling there was image of skin layers. One side normal, one side skin lesion. So I'll go with the skin lesion because majority of people are telling me this. Okay. So we had a normal physiology of the skin. Normal skin physiology. And we have HPV ki physiology. Thank you so much, guys. Easy image was given. So, and now what about the options? I got you. Thank you so much for the inputs. Really appreciate that. Painful lesion? No. It is not an RNA virus. It is a DNA virus. What about the option? We had to mark the incorrect option. Okay. So Shweta is telling us we had to mark the incorrect and not the correct answer. Shweta, can you help me with the options, because you're giving me that, you're the only one giving me that input. Can you correct me with the options, please? Can you help me with the options? अगर ट्रू नहीं था, इनकरेक्ट था, तो then the options will be totally different, right? इनकरेक्ट तो 3 है. वैक्सीन अवेलेबल इनकरेक्ट ऑप्शन है. पेनफुल लीजन इनकरेक्ट ऑप्शन है. इट इज नॉट RNA वायरस, इट्स DNA वायरस. Anybody, if you want to help me with the options, kindly make it. And at least if not options, can you please tell me कि incorrect था या correct था, so that if I can arrange best option possible. Mohinder Preet, correct option, I guess, sir. Your question was correct. Question was correct. Okay. So mostly people are selling, sir. HP specifically is not mentioned, only image was given. And what about option, Tanushri? Correct ही पूछा था. चलो, I'll remove this. I'll remove the incorrect वाला option. I'll go with the people that are saying that options almost यही थे and they asked the correct option. चलो, done. Thank you so much. Next पे आते हैं. Patient with microcytic hypochromic anemia and normal और increased RBC count था और target cell दिख रहे थे. Target cell थे. So did they mention microcytic hypochromic anemia with target cells? And then they ask the investigation of choice. Is that the case? Because that's make it thoda sa simple. I won't say exactly simple. That makes the case thalassemia. That makes the case thalassemia. And thalassemia, the investigation of choice is hemoglobin electrophoresis. सोचना ही नहीं था. जीन सिक्वेंसिंग ऑप्शन में नहीं था, तो बात ही खत्म है. हमने डिस्कस किया था. Okay, they mentioned MCV 72. Thank you, Tanushri. Really appreciate that. Hemoglobin 9 tha. What about the age group? Okay. Menzer index 11. Thank you. Menzer index 11. And what about the options? We have discussed this. Gene sequencing is the best investigation. जीन सिक्वेंसिंग ऑप्शन में नहीं था तो HPLC होना चाहिए. HPLC भी ऑप्शन में नहीं था, तो देन वी हैव टू गो विद हीमोग्लोबिन इलेक्ट्रोफोरेसिस. मैं जब क्लास में पढ़ाता था, बस टेलिंग, इफ यू गो ऑन थ्रू माय बैक टू बेसिक्स वीडियो, इवन दो जीन सिक्वेंसिंग HPLC इज द बेटर टेस्ट, दे विल कीप ऑन आस्किंग अबाउट इलेक्ट्रोफोरेसिस. ओके, सो ऑन द रॉक्स इज टेलिंग मी, सर ये अलग क्वेश्चन था, दिस वाज अ डिफरेंट क्वेश्चन. In that different question, they asked in different question where they asked the diagnosis. Is that the case? Chalo, done. So 2 question on, can I say there were 2 question on thalassemia? Can I say that? एक में Menzer index देके and MCV का value देके they asked the diagnosis, and other question they gave this clinical case and they ask the investigation of choice. So can I go with that? 2 question on thalassemia, 2 question on rheumatic heart disease, rheumatic fever. Menzer in this one only. Menzer in this one. So Menzer index in this one only. So some people are telling me एक ही question था, some are telling me there are 2 question. Okay. Thank you so much. यही था sir. Abhinav is saying 2 questions थे. चलो, thank you so much. Let's move to the next question. Which of the following is about retinoblastoma is false? Now again 2 inputs. Sir, false पूछा था, true पूछा था. False पूछा था या true पूछा था, प्लीज इसमें बता दो. ओके श्वेता, थैंक यू, गॉट इट. 2 क्वेश्चन थे. रेटिनोब्लास्टोमा पे false है, true था. Always unilateral, not at all. Gone through my back to basics video, अच्छे से पढ़ा. 2 टाइप के होते हैं, familial होता है और sporadic होते हैं. Familial वाला सर bilateral, sporadic वाला is unilateral. So it is not always unilateral. The familial one is all bilateral, the sporadic one is unilateral. The gene is RB gene, so true पूछा था. Mohinder Preet is telling me sir कि true पूछा था sir. It is not known as the guardian of genome because guardian of genome is P53. मैंने क्लास में पढ़ा था रेटिनोब्लास्टोमा रब है, और जो रब होता है एक तो वो गवर्नर होता है, द रब इज गॉड इज द रियल गवर्नर, एंड द रब इज ऑन एंड ऑफ स्विच. ऑन एंड ऑफ स्विच, कभी तुम्हारी दुआ कबूल करेगा, कभी नहीं करेगा. गॉड नोस व्हेन टू गिव यू एंड व्हाट टू गिव यू. सो गवर्नर ऑन एंड ऑफ स्विच इज यूज्ड फॉर. नो क्वेश्चन ऑन आरबी. Okay, so you are telling me retinoblastoma option mention was not there. They gave a 3-year-old child. Retinoblastoma not written. 3-year-old child, retroorbital mass. Okay, thank you so much. Perse was not mentioned, retroorbital or something like that. Okay. So what about the, so they mentioned, they framed a clinical case. Ye hai INI, you know, this is INI. RB retinoblastoma was not written. Now guys, can you tell me about the options? God sir. How many right rosettes was mentioned? Shweta is telling इस क्वेश्चन में how many right rosettes थे. Is that true? क्योंकि impossible नहीं है, unlikely है, but जनरली अगर वो रेटिनोब्लास्टोमा बना रहे हैं फ्लेक्सनम इंटरस्टिनल देंगे. यस यू कैन हैव होमेराइट रोसेट्स आल्सो कैन बी सीन रेटिनोब्लास्टोमा, बट वेरी अनलाइकली. आई डोंट थिंक दे विल डू दैट मच टू यू. फ्लेक्सनर इंटरस्टिनल होगा बाबा, very unlikely. Retinoblastoma, the homerite they'll write. Flexner, thank you so much. Okay, so flexner interstitial was mentioned. Okay, retinoblastoma sort out हो गया, clinical case done. Now what about the options guys? True पूछा था, false पूछा था. False है तो पहले दो ऑप्शन तो false हो गए. RBG is inactive hypertrophy, right statement. Loss of function, yes. और D ऑप्शन शायद कुछ कह रहे नहीं था. Osteosarcoma was not there. अब इतना प्लीज मुझे बता दो false हो या true था. Would really appreciate that. Right, then please also option में था. Now, which of the following are marker of mantle cell lymphoma? Mantle cell lymphoma. Is it translocation नहीं पूछी थी, ISC marker था, right? हमने पढ़ा था. ये तो मेरा favorite है when I teach there. True पूछा था. Okay, which of the following is true? False नहीं, true था. So when they ask true, then they say, चलो, thank you so much guys. Mantle cell lymphoma, CD10, CD200. I told you right, mantle cell lymphoma. एक लड़का जो mental हो गया था, CD5, किससे शादी करके? Because it got married to CD23, right? So it is 523. And specific मैंने बोला था, इतना mental हो गया कि socks पहन के साइकिल पे भाग गया था. If I've gone through my back to basics video, you know the trick. CD5, okay. Translocation was given. Okay, mantle cell not there. And they wrote 11, 14 translocation was given. Thank you so much. But option is correct, right? SOX 11. So I'll talk it as SOX 11. Right, done. Thank you so much. Next question पे आते हैं. 25-year-old athlete collapses. Favorite systemic path question. While playing basketball, brought to the emergency department. And they said gross mention was given. Gross था क्या? Gross था क्या? Typical gross image. As they've been asking from years. Was the gross image given? Yes or no? Banana shaped cavity है. All hypertrophy muscles हैं. This is has to be HOCM वाला question. Multiple choice. Cyclin D was also there. Okay, cyclin D was also there. Both cyclin D and is given. Okay, okay. So I'll make it CD cyclin D. So option हो गया A and D, B and D, right? So B and D is correct. Thank you so much. Thank you so much. Okay. Instead of CD200, CD23, they write cyclin D. Thank you so much. HOM similar image was given. Thank you, done Baba. Then to no wasting time on this. It has to be HOCM. Thank you so much. Next पे आते हैं. Then this question. Karyotype was given. Yes or no? 45-year, developmental delay, obesity, hypotonia, hypogonadism, body mass index increase, ghrelin hormone. Answer Prader-Willi syndrome. Any inputs, guys? they mention ghrelin, did they mention increased ghrelin hormone? Did they mention increased body mass index? Yes or no? मुझसे पढ़ा है तो यू नो प्रेडर विलाई के बारे में मैंने आपको कहा था, भूखा बच्चा है, बहुत सारा खाता है, बहुत सारा पीता है. They eat a lot, they drink a lot. They don't drink H2O, they drink H3O. They drink H3O. Hypotonia, hypogonadism, hyperphagia. Ghrelin was mentioned, hyperphagia and obesity. Yes, now again, some people are telling me, sir, yes, it was mentioned. Some are telling me it was mentioned. Any inputs, guys? Ghrelin hormone था तो sort out हो गया, क्योंकि ghrelin के hormone, I need more data because just karyotype is not enough for diagnosis. Hair on forehead was given. Guys, are you mixing two questions? What is most important for me to know is ghrelin hormone or body mass index was given or not? Can you please help me out with that, because that will totally change the diagnosis. I think you guys are mixing two questions. Okay, level for options. Options को भूल भी जाएं तो other. What about the other thing? Question is clinical case. Were you all sure it was on fragile Prader-Willi syndrome? Is there any doubt about that? Did you find any doubt कि ये fragile X syndrome तो नहीं है कहीं? इसमें तो कोई doubt नहीं था ना? चलो, and now before to end of the story, was there question on onion skin fibrosis? Say yes or no. But how was given on fragile X? Okay, think about option. क्या answer was in favor of Prader-Willi? Because now you're telling me there was no ghrelin hormone increase. Okay, so was it the question on Prader-Willi or there was some confusion? Angelman पे था. If Angelman पे था, can you give me some history? Angelman वाला developmental delay होगा. साथ में there will be smiling faces, happy puppets, ataxia होगा. The question was on Prader-Willi, that is for sure. No image, no karyotype was given. Only on the basis of clinical feature you had to diagnose Prader-Willi. Am I clear? Am I right? So chromosome 15 tha. Okay. So to sum up the story, chromosome 15 was mentioned. Clinical feature was mentioned. And then there was developmental delay that was definitely there. Chalo, done. Thank you so much. Now, before I leave, everybody, onion skin fibrosis was the question given. Onion skin fibrosis was the question given. BMI was increased. Okay. So what you're telling me, sir, ghrelin hormone nahi tha, but body mass index was. Now, thank you so much. That will help me. That will help me. Thank you so much. And karyotype was given. Guys, all of you agree with that? Pushpak is telling Prader-Willi tha. Karyotype was given. 46XY was written. Okay. Karyotype was given in that question. Chalo, done hai. Onion skin fibrosis. Onion skin fibrosis was given. Yes, thank you so much. That is PSC. Blood vessel का था या bile duct का था? Bile duct का था, right? Onion skin fibrosis, bile duct का था. Thank you so much. And one last question. Any question that you can add on is? There was some image-based question on neuroendocrine tumor. Any input, guys? Neuroendocrine tumor पे भी एक question था. Chromosome 15 था और 11, 13 था. Okay, then तो clear हो गया ना? फिर तो clear ही हो गया Prader-Willi. चलो, okay, done. ये तो था. It was there. Okay, I'll add on. Guys, anything about neuroendocrine tumor before I sign off? Neuroendocrine tumor पे any question? Or any question on pathology that you want to add, guys? आसान नहीं था पैथो, that is for sure. It was very clinical, very clinical. आसान नहीं था, I know that, but want से कुछ बाहर से था. 4 slide images were given in one question. Okay. Question on red gene and MAP kinase. Divyadashri, there is a question on red gene and MAP kinase. Can you little bit, can you tell me the language of the question? क्या था? Did they ask the disease involved? 4 slide images were given in question 4, and which of the following is not a neuroendocrine tumor? Out of these, those was asked. 4 histopathological images were given in same question. Retinoblastoma I got, बच्चों. Oncogene activation question was there. Okay, बच्चों. There was fair amount of pathology. I was very surprised to know that only 9-10 questions. Pathology 9-10 questions not possible here. चलो oncogene activation. Guys, Abhinav, oncogene activation पे guys, if you could help me with the language, I'll wait. Tanushri, recurrent gastric ulcer with a small nodule, middle wall of second duodenum. What was the option, guys? हाँ, पीजे सिंड्रोम पे भी तो क्वेश्चन था गाइस. आई रिमेंबर. हाँ, पीजे सिंड्रोम पे देयर वाज वन क्वेश्चन. All of the following is correct about Peutz-Jeghers syndrome, and as far as I remember, they asked autosomal recessive. All of the following is incorrect except, so autosomal recessive was incorrect option, right? Or it's an autosomal dominant. I kept on telling the class. So PJK syndrome, did they talk about false option or the correct option? पीजे सिंड्रोम पे क्वेश्चन था, न्यूरोएंडोक्राइन ट्यूमर में 4 इमेजेस थी, which was correct was asked. पीजे सिंड्रोम पे Peutz-Jeghers red gene map activity with degree 7. Okay guys, thank you. Chalo, thank you so much. I'm signing off here. Thank you so much for the times. We'll come up with the new frame language that was tried to replicate as it was asked in the exam. But thank you so much. Incorrect was, which of the following is incorrect, right? Anu, just last question guys. PJ syndrome multiple option. Correct option पूछा गया था. Which of the following is correct? And you are telling me STK11 was asked. Somebody are telling me correct, somebody telling me incorrect. So STK11 gene था. Do not have endocrine function. Islets, ovaries, other than, okay. Vanshika, 4 pathology slides. 4 pathology slides were there. Question was which do not have endocrine function. One was islet oils. Okay, guys, I'll come with that. Thank you so much. Thank you so much, guys. We'll wish the best for you guys. We'll wish the best for you guys. Thank you so much. जो last का 30 minute का भी systemic passage discuss किया था. We could see HOCM. We could see PJ syndrome का question from that, right? Thank you so much, guys. God bless you. Manifesting the best for you guys. Fingers.
Yes, so very good evening, everyone. And so myself, Dr. Kamal Jindal, and along with me is Dr. Prem Balaguru, my colleague, and we both will be discussing the questions of physiology now. Hello. ठीक कर दिया. So these are, remember, the recall based questions which we both have gathered with your help as well. So in case you feel like giving your suggestions, you are more than welcome. Do let us know the choices which we can correct, and then the proper recall will be done tomorrow, right? So the first question is, sodium absorption is least in stomach, duodenum, ileum, or salivary secretion. So remember, generally we say that the sodium absorption is maximum in jejunum, right? Or in the small intestine, particularly in jejunum. But here they are asking you least. Least is in stomach because there are multiple reasons for it. First of all, stomach does not have brush border lining like the small intestine. Secondly, it does not also have the various transporter mechanisms. Thirdly, the epithelium is having tight junctions, right? So commonly does not allow much of the ions and water movement across it. So the answer was stomach, right? So moving to question number 2, the following kind of graph is seen with. Remember, if you recall, this is a tall and a narrow loop. So we have been doing it indirectly in aortic stenosis where there is more afterload, right? So here there is only one option which is showing me increase total peripheral resistance or increase afterload, giving me the loop as tall and narrow where the stroke volume has reduced,
but the left ventricular pressure is increased, right? So left ventricular pressure is increased, but stroke volume is reduced. So answer was option C. Remember, increased ventricular contractility would be giving me a different kind of loop. Suppose this is the normal one, then the increased ventricular contractility would be like this. So here I will have increased contractility resulting in more stroke volume. So in this one would give me more stroke volume with less end systolic volume, right? So basically that can't be the answer. And if my ventricular compliance increases, then naturally the loop will shift towards the right, and there would be a corresponding decrease in pressure, the reason being the ventricle is able to stretch more, right? So this would probably be the increased ventricular compliance, right? So this can be my loop for increased ventricular compliance. Fine. So here the answer was increased peripheral vascular resistance, and I'm sure all of you have got it correct, right? Because this was an easy one, I would say. Again, a straightforward question. Identify the agent blocking this transporter. Let me zoom the figure for you all. This is the one which is blocking the sodium potassium pump. Sodium potassium ATPase pump. Yes, so what should be the answer? The only correct answer here would be, which is the blocker of the sodium potassium ATPase pump, digoxin, right? So digitalis or digoxin is the blocker of the pump. If you could recall, there are subunits alpha and beta. So digoxin binds to the extracellular side on the alpha subunit, right? Then we had question number 4. Here you can help me with the choices if you are thinking that there were any other choice here. A transport protein uses ATP to push the substrate out of the cell. So remember, direct breakdown of the ATP is happening. That means this is primary active, right? This is primary active. So answer cannot be SGLT1. This will be secondary active. GLUT2 would be facilitated diffusion. Organic anion transporter protein, if they are mentioning again secondary active or an ion exchange, so P glycoprotein is the answer, and this belongs to a family of ATP, or we say the ATP is utilized directly, which belong to ABC, ATP binding cascade family of proteins. ABC family of proteins, right? So even if you had a less clue about P glycoprotein, you could have done by elimination the option number A, because SGLT1 is secondary active, GLUT2 is facilitated, organic anion transporter protein, again an ion exchanger, secondary active. So with elimination, you could have done ATP, P glycoprotein, direct utilization of the ATP. These are known as ATP binding cascade family of proteins, ABC. Then there was a question which is done indirectly in renal system. Serum magnesium is mainly maintained by. Serum magnesium is mainly maintained by. So yes. So I hope all of you got it correct. Serum magnesium is mainly maintained by. Remember, the answer is kidneys or the renal reabsorption. In the kidneys, what is happening is we have a ROM-K channel, due to which, if you could recap, this is the thick ascending limb of loop of Henle. This is another one. Now what happens is that via the ROM-K, potassium is going out. If the potassium is moving out via the ROM-K, then this luminal potential will become highly positive, and this repels calcium and magnesium into the blood vessel. This is occurring in thick ascending limb of loop of Henle, where maximum magnesium is reabsorbed around 60 to 70% or 65%. So answer was renal reabsorption, right? Then I will be asking Dr. Prem to discuss the remaining few questions, right?
Yeah.
So Prem will take over now.
Good evening, sir. Sir, let the slide be there itself, sir. I'll just
Yes,
tell them
sure,
the
sure,
answer.
sure,
Yes.
sure, no issues.
Good evening, friends. I hope you had a wonderful exam session. I could able to see you guys were suggesting the correct options, and of course, since it's a recall, we couldn't able to bring all the exact question and options precisely. But anyway, we'll be doing that once again. Sir will be getting a video with all the perfect questions and explanations, and at that time, every single these small things will be perfected. And anyway, guys, let's move on to the question. So this is something you guys must be very familiar with. Tall P wave in JVP is seen, and the choices are mitral stenosis, mitral regurgitation, tricuspid stenosis, tricuspid and aortic stenosis. One small mistake. This is a tall A wave. I'm sorry for this one error. It's tall A wave, guys. And of course, you know the answer. It's going to be tricuspid stenosis. So that's tricuspid stenosis. Yeah, C is the right answer for the question. Very good, guys. Very good, people. Good. Let's move on to the next question. Osho Music's P pulmonale. Anyway, yeah, that's good. Perfect. And the next one is cortex responsible for scanning of visual field. This is something, it speaks about the frontal eye field. All right. If I have to see my visual field, if I have to scan through my visual field, I need to move my eyeballs. It's more of a saccadic movement, and the cortex that controls the saccadic movement of eyeball or any sort of eyeball movement is all about frontal eye field. So frontal lobe is the right answer for this one question, doctors. So yeah, it's going to be frontal lobe. And let's take up the next question. We have a patient here with severe acidity. The image shows small nodule on medial side of second part of duodenum. And what will you check for further in this patient? It's obvious. It's a duodenal tumor. And when it comes to a duodenal tumor that could able to cause this amount of acidity, it must be Zolling-Ellison syndrome. So typically there is going to be hypergastrinoma. So gastrin is going to be the right answer for this question. This is clearly Zolling-Ellison syndrome, guys.
Yes.
So yeah, perfect. Dr. Prakar, tall P wave in ECG. Oh, perfect, perfect. So anyway, the option is still the same. Thank you,
Yeah.
Dr. Prakar. We'll incorporate in that the change in the final version. And let's move on to the next question. So FEV1 by FEC, guys, if you could able to help us out, we'll be utmost grateful. Of course, we all could able to bring out this one parameter. FEV1 by FEC, the value was given less than 0.7 and it was correlated with the diagnosis. So obviously any parameter FEV1 by FEC, when it goes less than 0.8 and specifically less than 0.7, obviously it is going to be a classical case of obstructive lung disease. So yeah, we have the choice here, obstructive lung disease, but if you could able to be gracious enough to tell us the other choices,
Yes.
will be really helpful for us as well as your juniors as well. So we expect you guys to come up with the choices. If you could able to know, please let us know. Okay, 50%, 30%, 40% were three options. All right, Dr. Prakar, 50%, 30%, 40% were three options. Oh, read index. Oh, perfect. Okay, read index. Not necessarily a typical obstructive lung disease. Any sort of pathophysiology where the mucosal gland becomes enlarged. Of course, there is going to be an increase in read index, but anyway, that's a classical finding in COPD, and we can connect that with obstructive lung disease. Perfect. Good. So 80 to 50%, 40 to 30%. Perfect. There was another question on gold as well. Total two questions. Oh, very good, Dr. Prakar. If you could able to send us the choices through Telegram or YouTube, it will be grateful. So thank you very much. Anyway, so let's keep the session moving. And it was other question read index. So thank you, doctor. Thank you.
Yes, as Dr. Prem has rightly mentioned, read is basically mucosal hypertrophy or excessive secretion of the mucus by the glands, Dr. Prakhar. But yes, we would be highly grateful, both of us, if you could share the remaining choices with either myself or Dr. Prem. And hopefully, we will improvise over these choices and give you a better recall in a day or two, right? So thank you so much, and wishing all the best of luck for the results from both of us to you all. And God bless all of you, right? And just keep the fingers crossed, and now the exam is done and dusted, so relax today, and right, have the faith on Almighty, right? That is what I would say. You have given your best, right?
Thank you,
So
doctor.
thank you so much. Thank you.
Thank you. Thank you, sir.
Thank you, Dr. Prem. Thank you.
Thank you, sir. Thank you, sir.
Hello. Yes. Good evening, everybody. Thank you, Dr. Tanushri. I think you have helped maximum. Yes. Okay. Critical grade of. Okay. Chal. So let us see that Dr. Bharat sir will be discussing the respiratory questions for you. So hypoxemia related questions, ECG related question, Dr. Arvind sir is going to join. He'll help you with that. And then, of course, I'm going to discuss nephro and rheumatology for you. So you have to help me with this completing the recall. So a patient presented with proteinuria and hypoalbuminemia, that is a clear case of nephrotic syndrome. So definitely option B is not there, but all these other are remaining possible. So what was that in the MCQ that made all of you or majority of you choose FSGS? So here there are few students who say that it was mentioned that histopathological examination showed segmental sclerosis. Now, if segmental sclerosis is there, then FSGS is like a very straightforward answer. But I'm doubting if that is what it was given to you. Okay. So what was given? Okay, it was a child. If it is a child with more than 3.5 gram proteinuria per day, that is nephrotic syndrome, sclerosis was mentioned. So child, any age was it mentioned? Child, was any age mentioned? Was there a mention of, was the age group mentioned? Yes. What was it? Okay. Sclerosis was mentioned. Great. और क्या चाहिए फिर? छोड़ दो. So answer was very clear that it is a case of the sclerosis. But child, was there any age mentioned? Okay. Not responding to steroid. Okay. Steroid resistant FSGS. Okay. So 5-year-old was there, okay, but was having the symptom and not responding to steroids. Okay, got it. Not responding to steroid. This was a case of FSGS, right? That is no doubt about that. So that is correct. This is a case of steroid resistant FSGS. So 3 year hai, koi ye hai. Okay, fine, done. So this is cool. The single response answer was there. Another question, which was the criteria for nephrotic syndrome. So the criteria, it was a multiple correct answer one. Multiple correct answer one for nephrotic syndrome. So nephrotic syndrome, definitely hyperlipidemia, hypoalbuminemia is definitely correct. Okay. So as we have discussed, proteinuria 0 to 30 is trace, 30 to 100 is 1 plus, 100 to 300 is 2 plus, and 300 to 1000 milligram is going to be the 3 plus proteinuria. Okay. So was it dipstick 3 plus proteinuria? If you can just help me with that, was it dipstick 3 plus proteinuria was given? तो 3 प्लस और ग्रॉस ही होना चाहिए. तो करेक्ट है। ओके, सो डी प्रोटीन्यूरिया वाज गिवन। ओके, तो ए ऑप्शन क्या था? ए ऑप्शन क्या है फिर? प्रोटीन्यूरिया मोर देन 3.5 ग्राम पर डे, ठीक है। ओके, ओके ठीक है, ये ओके, तो ये गलत है। ये तो इसके बदले क्या ऑप्शन था? हाइपरलिपिडीमिया, हाइपोअल्बुमिनीमिया, प्रोटीनीमिया। ओके, प्रोटीन्यूरिया। और क्या करेक्ट ऑप्शन था? और या ए और बी ऑप्शन क्या था? आप बताएंगे डॉक्टर आर्य, क्रिएटिनिन था? Was there creatinine part of the thing? Creatinine कितना था? So elevated creatinine बस इतना ही था। ओके, क्रिएटिनिन, हाइपरटेंशन, क्रिएटिनिन का कोई वैल्यू दिया हुआ था? क्रिएटिनिन मोर देन 2.20, तो दिस इज नॉट पार्ट ऑफ द क्राइटेरिया। ओके, रेस्ड क्राइटेरिया। ओके, सीरम क्रिएटिनिन था, ठीक है। ओके, हाइपरटेंशन था क्या? ओके, सो क्राइटेरिया डायग्नोसिस ऑफ नेफ्रोटिक सिंड्रोम के लिए क्रिएटिनिन की जरूरत हमें है नहीं। ओके, डन। सो ये दिस इज नॉट पार्ट ऑफ द क्राइटेरिया फॉर नेफ्रोटिक सिंड्रोम। Nephrotic syndrome can have relatively preserved GFR. Creatinine may be normal also. Okay. Only creatinine possible है, किसी को 2.0, 2.2 या कोई कह रहा है only creatinine था, that is fair enough. ठीक है, no hypertension. Great. So correct answer is B, C and D are the correct answers in this question. All three are going to be correct answer in this question. Done. Okay. What about rheumatology? Can you help me with the options here for Sicca syndrome? A patient presented with dryness of mouth with enlarged salivary gland and grittiness of the eyes. What is the best step to diagnose this disease? So if you can help me with the other options. ANA अगर है तो करेक्ट है। ओके, टोटल 5 ऑप्शन थे बट करेक्टली नहीं रिकॉल कर पा रहे, कोई बात नहीं, उसको साइड में रख देते। अब हम वापस आ जाते हैं टू दिस क्वेश्चन कि व्हाट इज द करेक्ट आंसर हियर। हाँ, जोग्रेंस तो करेक्ट है, देयर इज नो डाउट अबाउट दिस। दिस इज डेफिनेटली अ केस ऑफ जोग्रेंस और इट यू कैन कॉल इट सिक्का सिंड्रोम, देयर इज नो डाउट अबाउट द डायग्नोसिस। बट ऑप्शंस क्या थे इन द स्टेप टू डायग्नोस? तो send antibody. So were there skimmers test and antibody? Yes, correct. So very good. So first step is to do skimmers test to confirm gland involvement is there and then send the antibody. Ye perfect hai. So that is what we have learnt in class, that we have to first step number 1 is to confirm gland involvement is present. We also did one step, exclude infective cause of gland involvement and send auto antibodies was given. What was the other options? What were the other options that were there? This is the correct answer. सबका आंसर तो करेक्ट है, उसमें कोई डाउट ही नहीं है। So what were the other options? कि कई बार होता है ना, आई ऑलवेज टेल कि आपको जो इजी क्वेश्चंस हैं उसके ऑप्शंस याद ही नहीं होते, क्योंकि वो करेक्ट आंसर इतना ऑब्वियस था कि आपने मार्क कर दिया और आपको दूसरे ऑप्शंस पता नहीं है। बट नथिंग टू वरी, ठीक ही है, ये आंसर तो करेक्ट है। स्किमर्स एंड सेंट एंटीबॉडी, ओके, नो हाइपरटेंशन पे है। और क्या ऑप्शंस क्या थे? और एक दो भी याद आ रहा है आपको कि इसके अलावा क्या करना पड़ सकता है? सलेवरी ग्लैंड बायोप्सी दिया हुआ है क्या? सिर्फ एएनए टेस्टिंग दिया हुआ है? इंस्टेड ऑफ पैरोटिड, ओके, सलाइवरी सिंटीग्राफी। ओके चलो, सलाइवरी सिंटीग्राफी। ओके, चलो वेरी गुड। चलो ये तो हमने पढ़ा ही है, आयनटोफोरोसिस करवाना, ये सब करवाना हम नहीं करते, ये सब ऑब्सोलीट टेस्ट है, नो लॉन्गर डन, because they can only bring you till gland involvement. They cannot help you confirm diagnosis of the Sjogren syndrome itself. Cannot be confirmed. Chest X-ray with ACE inhibitor, Dr. Srihari will come. Dr. Bharat sir is going to discuss respiratory after this. So वो X-ray will be discussed there. Don't worry. Okay. Chal, fine. तो इतना ही ऑप्शन यार. I think this everybody marked Bottonier's deformity in the patient with rheumatoid arthritis. So that is where there is hyperextension of the DIP involvement. Okay. There was hyperextension of DIP. Okay. ACTH वाला question में आ रहा हूँ. So patient of SLE on steroids develops Cushing syndrome. इसमें please, what was the fourth option? So serum cortisol and ACTH साथ में है. A patient of SLE on steroids develops Cushing's feature. Okay. पियानो फाइंडिंग ऑप्शन था. ओके, चलो इसको क्लोज कर देते हैं. पियानो फाइंडिंग. ओके. ओके, सो लास्ट क्वेश्चन, ये मुझे हेल्प करिए. पेशेंट विथ स्टीरॉइड, patient of SLE on steroid develops Cushing's feature. Serum cortisol, ACTH, low dose dexamethasone, high dose dexamethasone, followed by high dose dexamethasone. Okay. Low dose followed by high dose dexamethasone. Okay. There was serum cortisol, ACTH option, वो तो आ गया. Number A. ACTH and high dose dexamethasone टेस्ट करना चाहिए. ओके. और क्या था? फिफ्थ ऑप्शन क्या है? लो डोज फॉलोड बाय हाई डोज. ओके. ओके. ACTH followed by dexamethasone suppression test. Okay. So ideally when the patient, it is an exogenous drug induced cause, then there is no question of checking the points. But to confirm the diagnosis of Cushing syndrome, when it is not responding to low dose dexamethasone test, would be the correct answer. Options had multiple tests. Okay, fine. So tell me what multiple test was there, or only cortisol? ऐसा ही हाई लो दिखा रहा था. अच्छा. ओके. सो आप लोगों ने क्या चूज करके आए? आप ऑन स्टेरॉइड विद कुशिंग्स है तो आप लोग क्या मार्क करके आए हो? लो फॉलोड बाय हाई मार्क करके आए हो, या सीरम कॉर्टिसोल मार्क करके आए हो? क्या किया आपने? इनमें ही बता दो. मैंने कहा ना, आइडियली तो ड्रग इंड्यूस्ड है. आइडियली ड्रग इंड्यूस्ड कॉज है तो वो तो डायरेक्ट डायग्नोसिस है. ड्रग इंड्यूस्ड ये उसका कॉज है. हम लो डोज डेक्सामेथासोन कर सकते हैं टू कंफर्म डायग्नोसिस ऑफ कुशिंग सिंड्रोम. Cushing syndrome is defined as elevated cortisol level, which is not going to be responsive to low dose dexamethasone test. That is necessary to diagnose Cushing syndrome. Cushing syndrome can be iatrogenic also, can be pituitary adenoma also, or it can be ectopic ACTH also. Okay. I left the question. Wow. कमाल कर दिया. हाँ. So serum cortisol, ACTH is not recommended only here. because already the cause is very clear in front of you. So just for the diagnosis, I think जितना available है उसमें बेस्ट चॉइस हम मार्क करेंगे लो डोज डेक्सामेथासोन सप्रेशन टेस्ट. ओके, याद आ रहा है आपको नेफ्रो एंड रूमेटोलॉजी से एक्टोपिक एसीटीएच ऑप्शन था. बताइए एनी अदर क्वेश्चन फ्रॉम नेफ्रोलॉजी में कोई क्वेश्चन नहीं था. दूसरा हिमैचूरिया से related to GFR, related to AKI, related to CKD, related to dialysis. No question. कोई भी क्वेश्चन नहीं था. और इसके अलावा रूमेटॉइड आर्थराइटिस न्यू ट्रीटमेंट, डीमार्ट्स, वेस्कुलाइटिस सिंड्रोम, कुछ नहीं. बहुत नाइंसाफी है आपके साथ. ओके, चल. सो लेट मी नॉट इनिशियल इन्वेस्टिगेशन लो डोज डेक्सामेथासोन करना है तो करेक्ट हो गया. आपको चॉइस चूज करना है. चलिए डन डन डन. आरए पे था डॉक्टर बोमराज, वो डन हो गया. पोटेनियस डिफॉर्मिटी था. ओके चल. सो मैं और टाइम वेस्ट नहीं करता हूं आपका. आप दूसरे सब्जेक्ट के फैकल्टी भी वेट कर रहे हैं. तो मेरे ख्याल से नेफ्रो रूमैट में टोटल 5 क्वेश्चन थे. उसमें से मेजॉरिटी आपके लिए सिंपल थे. आपने आंसर किया. ये एसएलई और लो डोज वाला ये रुका हुआ है. ये आगे हम वापस से वेरीफाई करते हैं. चल अभी एंजॉय करो, ज्यादा स्ट्रेस मत लो. थोड़ा बहुत जो है वो एक बार याद कर लेते. आफ्टर दैट एंजॉय करो. मिलते हैं हमारे ब्रेक के बाद, मतलब आपके रिजल्ट के बाद. चल ऑल द बेस्ट, एंजॉय, बाय बाय.
Hi everybody, good evening. Good evening everybody. So am I audible? Am I visible? So if you when you'll just tell me about audible, visible, we'll start talking about pediatrics, INICET November recall. So all of you, let me first talk about the exam analysis of pediatrics. So देखो, there is no doubt कि previous year topics हमेशा पूछे जाते हैं, and all the questions which came in pediatrics we already knew that these topics will definitely come, and I'll show you that these questions were already discussed in your classes, though they were not exact questions from previous year, but the same topic was asked. And of course remember, देखो, all you have to do is your notes, your back to basics, and the previous year topics and whatever we discuss in your GTs and CBTs. I'll show you, यही सब हम पूछते हैं आपसे हर एग्जाम में. So this was a question which many students told me, that there was a term newborn with tachypnea, and on X-ray there was fluid in the horizontal fissure, and the tachypnea resolved in 48 hours. So all of you, do you agree with me about tachypnea, term gestation, fluid in the fissure, resolving in 48 hours, and these were the options? So I've discussed with multiple students, and most of them told me that these were the options. Let's see, what do you tell me? Okay, one of the student is saying this was a 3-year-old baby. Okay, we'll add this 3-year-old baby, and gets resolved in 6 hours. Okay, so whatever it is, remember, and we already discussed, this is a snapshot of mine from your back to basics, where I was showing an X-ray of a prominent horizontal fissure in transient tachypnea. And we already discussed in a workbook also that in transient tachypnea, it is a self-limited benign condition which resolves in 48 to 72 hours. So of course, there is no doubt this was a benign condition of transient tachypnea of the newborn. So I'm sure all of you agree with me. So when we talk about pediatrics this year, There were almost more than 12 questions, and I'll show you most of the questions, and you also help me if I am wrong regarding the options or the questions. So let's take you to the next question. So can you tell me about this question about the age of the child or any other thing which was mentioned? What was the fourth option? A child with recurrent infections and a continuous murmur infraclavicular. What is your diagnosis? So all of you, do you agree with the question? Was the age mentioned, gestation mentioned, any other clinical features mentioned? And do you remember the last option? So let us look at the chat box. So age 1 month 3, okay, thank you. So I'll add here a 1 month old child with recurrent infections. Sir, fourth option, someone is saying AR, aortic regurgitation. Okay. So of course, there is no doubt this is definitely PDA, and we discuss in multiple classes of yours, and I always have been talking about PDA, and I in all of my notes I talk about PDA having wide pulse pressure, and I told you in your classes wide pulse pressure important hai, bounding pulse is important hai, and left upper second intercostal space there is a continuous murmur. Okay, there was bounding pulses were also present, excellent, and no cyanosis, excellent. So of course they have, and I've been telling you this since ages now, that bounding pulses के बारे में जरूर पूछते हैं. And remember, wide pulse pressure also is asked in these patients. Okay, very good. So bounding pulses, all of you agree with me that bounding pulses is seen in PDA. Okay, bounding pulses, wide pulse pressure, machinery murmur, left upper intercostal space. Very good, all of you. There was no doubt this is a case of PDA. Excellent. So I think most of you did pediatrics very well. Now this was a very important question, and I want your inputs on this. There was a 3-month-old child with jaundice and clay colored stools. His growth was normal. And I told you, in fact, yesterday also in the AIIMS marathon, I told you that breast milk jaundice, cholestatic jaundice is very important. Okay. So what do you think, guys? Were all of these 4 options right? First option, definitely there was a question. They said whether it's breast milk jaundice or not. Now, many students told me that, okay, dark yellow urine. Yes, of course, dark yellow urine also suggests it was a cholestatic direct jaundice. So there was a dark yellow urine. Okay. Okay. So guys, we discuss in our back to basics lectures exclusively breastfed. Okay, we'll add that. And I told you that whenever we are thinking about biliary atresia, of course, in HIDA scan there is no excretion, but liver biopsy will be the best test. Okay, weight was normal, feeding well, exclusive breastfed. I'll add those things. Growth was normal, exclusively breastfed. Cholestasis was, I know one of the option was cholestasis, where they were asking about a genetic defect question or no bile flow. So that was in HIDA scan. So guys, remember, agar HIDA mentioned tha, liver biopsy is a better option. If liver biopsy was not there, I'll think about HIDA scan. Remember, here we are thinking about biliary atresia. See, jaundice with clay colored stools. Your first option, start thinking about biliary atresia. Remember, this is a favorite question of NEETPG, favorite topic of INICET, of biliary atresia. So remember, this is not breast milk jaundice. Breast milk jaundice is unconjugated. It does not have, yeah. So formula feeding we will not give, Ashish, because it is not breast milk jaundice. And moreover, remember, We never stop breast milk. I told you in all of my classes. So if were both of these options given, see, liver biopsy is a better option. I told you in all your classes that liver biopsy will be the best test to diagnose biliary atresia. But if this was not there, then I will go for non-excretory HIDA. See, I told you in my classes, HIDA is not a very reliable test. But in biliary atresia, there is no excretion. Okay? But remember, liver biopsy will be a better option if it was there as an option. बताइए. अच्छा, both given थे तो liver biopsy better है. देखो, I told you in all of my classes that liver biopsy you don't have to wait. Don't waste time to diagnose biliary atresia. Otherwise, liver will be gone. Okay, so liver biopsy is a better option. Of course, guys, first week of October, Nobel Prize is distributed, and we had put this on the Telegram channel, on my Twitter, on Facebook, that you need to know about this year's Nobel Prize, which was for peripheral immune tolerance. So this happens and guys, remember, NEETPG के लिए भी बहुत important है to know about peripheral immune tolerance, okay, which is also used in organ transplantation. Okay, let's go further. Now, milestones. There was a question on match the following. This question was match the following, and this is all according to OP Ghai textbook. Guys, do you agree with me about these milestones and the ages? Remember, tower of 2 is at 15 months. Hand to hand transfer is at 6 months. Points in one direction at 15 months. Pincer grasp is mature at 1 year of life. So what do you think, guys? Okay, so it was not match the following. Okay, so pincer grasp, which is correctly matched. Okay, so it was not match the following. It was which is correctly matched. Thank you. Okay, which is correctly matched. So what I have done is I have given you all the correct ages here, and you can follow it. Okay, pincer grasp was 9 months, but remember we told you in all of your classes mature is at 1 year. So I've written all of the normal age groups here, and you can take your pick. Okay, so you need to know about these milestones. Now there was a question on a boy with developmental delay, progressive obesity, hypotonia, hypogonadism, and the karyotype was deletion of 15q11 to 13. Am I right? And these were the 4 options, guys. Yeah, of course, this was Prader-Willi syndrome. This is a snapshot of our workbook, and I'm very happy to share with you that this time the workbook of Back to Basics is excellent with all the images, all the PYQs, and I discuss already in your workbook about Prader-Willi syndrome with obesity, hypogonadism. Yes, forehead hair, and this was a typical case of Prader-Willi syndrome. Exact question. Thank you, Pushpak. So most of the students told me that hypogonadism was already there, also there. Even if it was not there, remember obesity with this deletion, you think about Prader-Willi syndrome. And we also told you that in similar deletion is also seen in Angelman syndrome. Okay. Now, every NEETPG, every INICET has a question on disproportionate short stature. So can anyone tell me what was the age of this child and what was the ratio of upper segment to lower segment? Okay, so most of the students were saying hypogonadism was there in the previous question. Now there was a question on short stature and disproportionate short stature. Diet, head circumference, BMI, systemic examination was normal. So let's see, what do you guys feel about this? upper segment to lower segment ratio was 1.4. Age तो बताओ 1:4. Okay, Pushpak is saying 1:4 था. 1:4. Everybody is agreeing with 1:4. 7 years old. Okay, 7 years old. Most of you are saying 7 years old child, and the upper segment. So basically, guys, you need to know that we have already discussed about disproportionate short stature in the endocrine system, and I told you because 7 years old, his ratio should be almost like 1 point, at 6 years it's 1.1:1. So at 10 years it's 1:1, so it should be like 1.2:1. So if the ratio is more like 1.4 जिसने बोला, तब आंसर achondroplasia है. Okay, 1.4 Shweta, 1.4 achondroplasia. But if the answer was 1:4, and this I told you last year ये NEETPG में भी this question came, spondyloepiphyseal dysplasia may this ratio will be reduced. So I'm marking here 1:4, but remember if the ratio is more, then your answer will be achondroplasia. Okay, someone is saying one option was hypothyroidism. But remember, so just look at the hypothyroidism also has an increased upper segment lower segment ratio, but they are not so dwarf. This is a complete dwarf child. Okay, so 1:4 hai, to answer is spondyloepiphyseal dysplasia. Okay, so basically you need to know about disproportionate short stature. Okay, I agree with you, Divya. Okay, now there were two questions on dengue syndrome, dengue and dengue with warning signs, severe dengue. So this was a febrile child. Anyone please let me know if age was mentioned, you don't agree with the question. A febrile child with dengue NS1 positive, day 5 of fever, he's stable, but platelets are 20,000. What to do? What did you mark, guys? And do you agree with the options? Do you agree with the question? Multiple choice question, okay. Multiple option correct, okay. So whatever today I'll tell you, it's from our notes and also from the standard textbooks, okay. So guys, remember this, if the platelets are 20,000, okay. See, dengue with warning signs, even if he's stable, but if the platelets are rapidly falling, it comes in dengue with warning signs. Okay, it comes with dengue with warning signs. Okay, so even if he is not having pain abdomen, fluid accumulation, this comes in dengue with warning signs. Now remember, blood transfusion is routinely not given. Only if this child is in, this is according to the OP Ghai latest edition, 10th edition, blood is only given if child is in shock and PCV is falling. Platelets, there is little evidence to give platelets unless he has a very severe bleed. In a massive bleed only, we give platelets. So of course, most of you are right. We will just give paracetamol. Paxels, I told you, it is only given in severe dengue with a falling PCV. Steroids only in refractory shock. Platelets, if very severe. All of you are right. You will only give paracetamol. Now there was one more question on dengue. And guys, tell me, can you tell me the age of the child or any other thing you want to share with me about this question? A febrile child with dengue NS1 with warning signs, hematocrit was high, platelets were less than 50,000. So do you all agree with the question and the options? Do you all agree with the questions and the options? Okay, ringer lactate कैसे देना है? A and B were RL, C was okay, RL RL. See, first fluid will be, of course, to start with RL. Normal saline, someone is saying normal saline, or whatever it is, guys. Remember, the first thing is you have to give crystalloids. And remember, OP Ghai and all of our pediatric guidelines say, listen to me carefully, all children of dengue with warning signs, okay, you will start RL or normal saline at 7 ml per kg for the first hour. You're right. So Dr. Bishnoi in the chat box and Dr. Hinosh Holland Papura in the chat box 7 ml per kg per hour से शुरू करेंगे. देखो एल्गोरिथम में भी ऐसा ही है. Dengue with risk factors. So this child which you saw just now, this child had low platelets, high PCV. So even the algorithm in OP textbook says you will start with RL or normal saline at 7 ml per kg per hour. So remember, we start with 7 ml. Only if he's in shock, we give 10 ml per kg per hour. Okay? Okay? All of you agree with me? So he was not in shock. So you will start with 7 ml per kg per hour. Look, OP Ghai ka sentence hai. Without hypotension, start with RL or normal saline at 7 ml per kg per hour. OP Ghai and guidelines of WHO का algorithm है. Straight away start with 7 ml per kg per hour. Okay. RL or normal saline, they are the same. The funda is colloid use नहीं करना. You have to start with crystalloid. RL or normal saline. So see Dr. Tanushri in the chat box. OP Ghai में क्या लिखा है and guidelines में भी and real life में भी, guys, we start with RL here in dengue somehow. In dengue, because of the plasma leakage, RL is more like plasma. So we start with RL first in dengue because of the peripheral leakage. We will come to DK. Don't go anywhere, Dr. COVID-19. Though I don't like your name. So, okay. So the next question is for you, DK. And 10-year-old child with pain abdomen, vomiting, with severe DK, bicarb of 4, pH of 7, random blood glucose of 340, sodium, potassium was given. Now, do you agree with the options? And then I'll tell you. Dr. Sen Gupta, 7 ml was the answer. Okay. And I'm sure option में RL और normal saline के differences नहीं होंगे. The key was 7 ml per kg per hour. Okay. Algorithm में भी RL और normal saline ही कहते हैं. Okay. So do you agree with the options? Potassium was 4.8. Okay. 4.5, 4.8. Blood glucose was 450. Okay. I will correct that. Whatever it is, चाहे 340 हो, 450 हो, these things will not change the management at all. Now, guys, I want to tell you that diabetic ketoacidosis is a very, very, very important topic for NEETPG, for INICET. So, in your back to basics, what I've done is, and you all know, in all of your new back to basics, which is workbook based, and I hope you like the content, we have also added a folder of Beyond Workbook. And I specially added a 30-minute video on diabetic ketoacidosis. I will tell you, don't go anywhere. Okay, COVID-19, change your name. Okay, so first of all, I want to tell you guys that in every grand test of yours, every CBT of yours, I added a question on DK because this is the latest trend of last year INICET, last year NEETPG. So I even know question में लिखा था ISPAD, and I told you guys ISPAD आएगा question. So let me write here ISPAD, management as per International Society of Pediatric and Adolescent Diabetes. Okay, so management as per International Society of Pediatric and Adolescent Diabetes. So guys, we told you in your lectures what is DK. Of course, this patient had a pH less than 7.3, and this is the workbook where I also added in the notes कि देखो अगर pH is less than 7 or 7.1, it is severe DK. तो severe DK में 10% dehydration सोचना है. Otherwise, this is a direct question in our notes. 7% dehydration every DK has. Number one, 7%, but in severe 10%. Now, this I always, whenever I write this in the class, I write star, star, star. Normally, the first fluid to use for the first hour is normal saline, 10 to 20 ml per kg over 20 to 30 minutes. Use crystalloids. तो सबसे पहले क्या देना है? Bolus. Okay, सबसे पहले देना है bolus in the first hour. Okay, Dr. Sharma, after that we'll go to n by 2. Okay, after that we'll go to n by 2. Funda समझ लो. Okay, first give bolus. Now there was also option of potassium देना है या नहीं देना है. देखो, this is all actually a very nice question which takes you through the whole guideline. See, DK में all patients are in potassium deficit. So every DK we give potassium replacement of 40 millimole per liter. Option में लिखा था 40 millimole per liter. मुझे मालूम है, many students told me. So K you have to give 40. Insulin, see, please go to our back to basics guys, and ये आधे घंटे का वीडियो सबको देखना है before your next exam. Bolus should never be given of insulin. You start with insulin infusion 1 hour after the fluid resuscitation. Okay, bicarb is never given prakhar. Never. Bicarb is usually never given in cases of diabetic ketoacidosis. By giving fluid replacement over 20 to 30 minutes, सब ठीक हो जाता है. Insulin after 1 hour of resuscitation. Okay, 0.05 to 0.1. So guys, I don't know the exact options. Okay, I don't know the exact options. Okay, but I want you to know that we will give 20 ml per kg of normal saline. Okay, because this is a severe DK over 20 to 30 minutes. See, pH was 7, so I will give him 10% deficit correction. Insulin bolus नहीं देना, insulin infusion देना है. और एक बात और, everybody, after the first hour give him n by 2 and give potassium supplementation to all diabetic ketoacidosis, and the fluid should have 40 milliclins per liter. Yes, you're right. Yes. So even if you don't agree with me, I'm telling you this is the kind of question they asked, because I've discussed with multiple students and they've told me they asked funda tha bolus, don't give insulin bolus. After 1 hour start insulin infusion and make it n by 2. Okay, bicarbonate is not needed because these patients are very critical. They may get cerebral edema. Remember, the most common cause of death in DK is cerebral edema. I'll not take a lot of time here because we have a lot of things to discuss in the next faculty also. Now, this was our tricky question. In autosomal recessive mitochondrial disorders. Now, do you agree with me? This was a bouncer, okay? So don't worry about this question. In autosomal recessive mitochondrial disorders, which systems are involved? Do you agree with me? Even if you did not correct this, it was not an easy question. Let me wait for a minute. See, autosomal recessive mitochondrial disorders are because of nuclear DNA. Okay, they are not because of mitochondrial DNA, and in most of them they have skeletal system and muscle involvement. Okay, so remember, most of them have skeletal, muscle, followed by GIT involvement. So remember, the answer of this question will be the second option, skeletal and the muscle involvement, followed by, अगर muscle नहीं लिखा था तो skeletal and GIT. Okay, many of you left this question. Of course, it was a difficult question. Okay, it was not a question at your level. Okay, so कुछ questions ऐसे bouncer आते हैं. Now, Gauchers is a very common question, so we'll not take much time on it. What is not true about Gauchers? Then they had 1, 2, 1, 2, 3, 1, 2, 3, 4. So, of course, we discuss in all of your classes. This is a snapshot from my genetics lecture. मैंने star लगाया था यहाँ पे. I told you, Gauchers is beta glucocerebrosidase deficiency. There are crumpled tissue paper appearance, Gaucher cells. A straight question. So, of course, it is not related to ceramidase. Bone pains are there. It is beta glucocerebrosidase. Crumpled tissue paper appearance. Okay. Cardiac तो बिल्कुल नहीं था भोमराज. Okay. Let's go further. Now, I think there were 2 questions on rheumatic fever. So please help me if I am wrong. This was the first question. Okay, swingomyelinase एक था. Okay. Rheumatic fever में what is not seen? So of course it occurs 2 weeks after a sore throat. Remember, Aschoff bodies are seen, infection by group A beta hemolytic streptococci. But remember, it is always a pancreatitis. And I told you in your lecture of rheumatic fever that it is always a pancreatitis. So there is valvulitis, endocarditis, pericarditis. Okay? Okay? Yes, Prakhar, even if the Gaucher's question was multiple options, तो उसमें ceramidase वाला नहीं था option, rest was there. Okay? And foam cells are also not there. So remember, rheumatic fever is always a pancreatitis. So this option is wrong. Okay? It is caused by group A beta hemolytic streptococci. So अगर group B लिखा था तो वो भी गलत होगा. Group A beta hemolytic streptococci. Okay? Okay. Now there was a question on drug not used in status epilepticus in a child. And these were the 4 options. Am I right? Okay. So since you are persistently saying, so of course it was, someone is saying it was group B streptococci. So ये भी गलत होगा. Okay, I'll just correct this. ये भी गलत है. Okay. Okay, happy now, Dr. Pushpak? So both of these options are wrong. A and C are right. So all of you agree with me, and there's just a 15-minute lecture on seizures, and I told you, in fact, yesterday in the INICET marathon, that febrile seizures, status epilepticus आता है, and this is the way we treat status epilepticus: first phase, second phase, and third phase, and ethosuximide is not used. Cool. Let's go further. Now I want to ask you about criteria for nephrotic syndrome. उसमें child लिखा था या नहीं लिखा था? Did they ask you about a child or not? I was attending Dr. Srinath's lecture just now, but my question to you is, did they ask about criteria of nephrotic syndrome in a child? Or this word of child was not there? 10-year-old child. अगर देखो, why am I saying this is because in pediatric nephrology, the criteria of nephrotic syndrome have changed. बच्चों में hyperlipidemia is not a criteria. Okay. So if they ask, I'm just telling you this because in children, I'm a pediatric nephrologist. In 2021, our society changed the guidelines of nephrotic syndrome. So hyperlipidemia is not a part of nephrotic syndrome definition in children. Okay, adults में होगा, पर बच्चों में we know hyperlipidemia is associated, but it is not a part of the diagnosis of nephrotic syndrome. Okay, so just let's and of course I know this question Dr. Srinath just discussed with you, and I told you in my lecture also that if you have a steroid resistant nephrotic syndrome, we do a biopsy to look for FSGS. So they had already given you segmental sclerosis in the question, so this was FSGS. So do you agree with me? Both questions of nephrotic syndrome were children, or in one there was an age of 31 years. See, question में they gave a biopsy showing segmental sclerosis. So of course it's FSGS. There is no doubt about this. Okay, in a child, most common cause of steroid resistant nephrotic syndrome is FSGS. So was there a question on Jones criteria? So do let me know, guys. Let me know on Telegram. This is my channel on Telegram, or email me or put me on Twitter. Okay. So if you know about the question on, I think maybe one question on Jones criteria we are missing. Otherwise, there were more than, like I showed you, there were almost 12-13 questions from pediatrics, and most of them were easy questions. हमने सब डिस्कस किया था in our GTs, CBTs, back to basics. So guys, फंडा वही रहेगा. Okay, please do your CBTs. Do look at the lectures. Do look at the video solutions. Okay. Okay, so someone is saying yes, there was a question on Jones criteria. Major or minor, what are included? Okay, so that's a simple question we have already discussed in our classes. So not a very difficult question on Jones criteria. So one question on Jones was also there. So let me know in your on any of the social media platform. Okay. Okay. Thank you and all the best. I'll see you on the other side when you will be a PG. Just आज का दिन relax करो. Okay. And we'll see you soon with more of pediatrics. Thank you.
Hello everyone. So let us discuss these recall questions, and the language can be a little bit changed or options also, because these are all recall basis, and depending upon that answer may be different also. So this is basically to discuss what I have got from the students till now. Okay, based on that information, these questions I'm going to discuss with you. So there was this question based on the now supplying the muscles of mastication passes through which of the following marked foramen. So muscle supplying the mastication is nothing but the mandibular nerve is there, and the mandibular nerve is going to pass from the foramen ovale, and that is this C foramen. All right. And there was this question based on muscle of mastication, the only muscle of mastication which depresses the mandible. So we know the mouth opener is the lateral pterygoid muscle. The lateral pterygoid is the only muscle of mastication which does the mouth opening or the depression of the mandible. All other three muscles, total we have four muscles of mastication. All other three are involved in the elevation or closing of the mouth. Now regarding the lateral pterygoid, which statement is incorrect? It is supplied by the mandible. Yes, that is true. It is attached to the neck of the mandible and further in continuity with the, articular disc. That is also correct. But it is attached to the medial pterygoid plate is wrong. C will be the answer. It helps in protrusion. Yes, that is the major action, right? This bony landmark was given, है ना? That occipital condyles were there. So they are going to definitely articulate with the occipital bone, and the joint will be atlanto-occipital type. This joint is like ellipsoidal type and you use for the noding. It is called as yes joint. And this is the site where we have dens of the C2. Okay, here we have the dens of C2 will be there. So there will be kind of a atlantoaxial joint will be there. Atlantoaxial joint is no type joint. All right. Now this question was there, which of the following does extension at the hip and the extension at the knee? Which one have you marked? Like how this question was given, the names were given or some markings were given? What exactly, what you have to mark as an answer? Was the option as muscles as such? We have gluteus maximus muscle, that should be the answer. Why? Because gluteus maximus is the chief extensor at the hip, but via iliotibial tract it can work on the knee joint as well. So far as hamstrings are concerned, there is the hip extensor but knee flexor. And tensor fascia lata is the abductor and medial rotator. It is not doing the extension as such, and this will be the adductor. That was image based question. And what exactly attached to the temporomandibular disc was there? If disc it is attached, lateral pterygoid is attached to the temporomandibular disc, beta. No muscles were given, image based question, so you have to identify the area where it is attached. मतलब बोन दी हुई थी, हमें उसमें मसल्स का अटैचमेंट बताना था कि यहाँ पे अटैचमेंट वाली मसल ऐसा एक्ट कराएगी. दैट वाज द क्वेश्चन. So basically we have to see the attachment points for the gluteus maximus. Those are the points, है ना? Answer will be gluteus maximus over here. Now this question that student have recalled ki ischial spine was marked, and they're asking ki ischial spine, like which is not related here. So we know the pin structure are definitely related here, and apart from the pin, whatever is the fourth choice will not be related, or you can say most appropriate answer. Sometimes we don't have a correct answer and we have to mark the most appropriate answer, because otherwise tendon of obturator internus will be below it. It is related, relation to hai na, it is not winding around, hai na. But yes, if we have to choose these among these given option, then answer will be D, tendon of obturator internus. ओके, मार्किंग था और अटैचमेंट पे पूछा था, ठीक है, पेल्विस बोन देके. ऑल राइट. इश्यू कॉक्सीजियस भी तो अटैचमेंट रहता है ना. एक ये क्वेश्चन था, इसमें मैच द फॉलोइंग, मैचिंग करना था या रॉन्ग और करेक्ट हमें बताना था. बेसिकली व्हाट आई हैव रिकलेक्टेड फ्रॉम द स्टूडेंट्स की ये 4 मार्कर्स थे. एक तो इंफीरियर कॉलिकुलस था, ए इज द इंफीरियर कॉलिकुलस विच इज करेक्ट. व्हाट इज दिस वन इज द सुपीरियर सेरिबेलर पेडंकल, this one is the middle cerebellar peduncle, and this one is the inferior cerebellar peduncle. So D जो है inferior cerebellar peduncle correct है ना. B जो है वो middle cerebellar peduncle होना चाहिए था, that is wrong. C superior cerebellar peduncle correct है. इसको मैच करना था. ओके, मैच द फॉलोइंग था. ऑल राइट. तो फिर हमें लाइक इजी है ना. inferior colliculus, this one is inferior colliculus, superior cerebellar peduncle, middle cerebellar peduncle, and inferior cerebellar peduncle, right? We can match this way. Now 4 slides were given, and which one of the following does not have the endocrine function, ये बताना था, ठीक है. जैसा स्टूडेंट्स ने बताया कि एक थायराइड था, this is the thyroid, we can see the thyroid follicle is there, this will be the parafollicular C cells are there. This is the glomerulosa fasciculata reticularis, that is adrenal gland is there. This one is the pancreas, where we have the islet of the Langerhans are there. But this one is the spleen, so this should be the answer. नीचे का व्यू था, ओके, व्यू नीचे का था और मैच द फॉलोइंग ही था, ऑलराइट। इनमें 4 स्लाइड्स ये सेम है या आप इसमें कुछ बता सकते हो कि चेंजेस हैं? क्वेश्चन था विच वन इज नॉट हैविंग एंडोक्राइन फंक्शन, एड्रीनल, थायराइड, पेनक्रियाज, they all have endocrine function, but spleen or the other whatever the fourth option was there, it does not have any endocrine function. ये वाले ऑप्शन ठीक थे? Now this is also match the following type, where we have been given pharyngeal arch arteries, and I always tell in the class that first arch artery, if we can recall that first is the maximum, it will make the maxillary artery. Second starts with letter S, so it's like stapedial and hyoid artery. Third artery and third alphabet is C, C for carotid system. And the fourth will make the right subclavian artery on the right side, but on the left side it is going to make the arch of aorta. And after that we have sixth arch artery. Proximal part will make pulmonary artery, and distal part only on the left side will make ductus arteriosus. ओके, स्पेसिमेन यही थे, पिक्चर्स डिफरेंट टाइप के थे, बट थे वो हिस्टोलॉजिकली पिक्चर्स होंगे, है ना? दिस वाज इनकरेक्ट बता रहा था हमें, इनकरेक्ट मैच करना था। ओके ओके ओके, इनकरेक्ट पेयर बोलना था, और इनकरेक्ट पेयर में क्या बोलना था? 6 आर्च वाला ऑप्शन था। ओके, 6 आर्च के साथ आर्च ऑफ आयोटा को मैच किया हुआ था। ओके, सो दिस बिकम्स द आंसर, राइट? इसको चेंज करेंगे लैंग्वेज को। नाउ दिस क्वेश्चन स्टूडेंट्स आर सेइंग कि एक ऐसा क्वेश्चन था इसमें लाइक मसल्स ये वाले थे। आई थिंक ये तो आई केम टू नो कि दिस वाज इमेज बेस्ड क्वेश्चन, जिसमें कि कैडेवरिक इमेज है। आई विल फाइंड आउट द कैडेवरिक इमेज फॉर दिस, बट मसल्स ये वाले ही थे, पैलेटोफेरेंजियस, स्टाइलोफेरेंजियस, pharyngeal constrictor and the tensor valley palatini. Circular gland and the secretion within most likely should be thyroid beta. Thyroid is the endocrine gland जिसका secretion follicle में रहता है ना। ओके, सो अगेन अगर यूला भी था तो वो पैलेट का ही मसल है। ऑलराइट, तो आप कह रहे हो कि एक मसल उनमें से यूला था। Which part will lead to dysphagia and dysarthria? Okay, is not नहीं था, which will be leading to the dysphagia and dysarthria. तो फेरिंग्स में से कुछ एक होना चाहिए था। आप कह रहे हो यूवला था, टंग था, और क्या था मार्किंग्स? जीनियोग्लोसस। ओके, टंग का जीनियोग्लोसस मार्किंग था, एक यूवला था। डिस्फेजिया डिसआर्थरिया के लिए फेरिंजियस मसल्स में भी तो कोई एक मार्किंग होना चाहिए था। देयर शुड बी वन फेरिंजियल मसल आल्सो। पोस्टीरियर फेरिंजियल वॉल था। नोट यूवला बट अबव यूवला कंफ्यूज कर रहे हो थोड़ा सा आप लोग चलो एक बार आप मेरे को ये वाले ऑप्शंस सही से बता दो अमंग दीज ऑप्शन जो यहाँ पे है फेरेंजियल मसल्स तो दे विल बी इन्वॉल्व इन द डिस्फेजिया डेफिनेटली ये जो मसल है ये पैलेट का मसल है तो इसका डिस्फेजिया में डायरेक्ट इन्वॉल्वमेंट रिलेटिवली नहीं होना चाहिए है ना इट्स लाइक इन्वॉल्वमेंट इन द डिग्लूटेशन प्रोसेस में मसल सुपीरियर टू यूवला यूवला कंस्ट्रिक्टर एंड जीनोग्लोसस फेरेंजियल कंस्ट्रिक्टर तो है ही है ठीक है at the level of nasopharynx was there okay so I try to find that image for this question and this particular question ki bones were given and cranial nerve was marked now कौन कौन से बोन थे जो मेरे को रिकॉल हुआ एक है टेम्पोरल बोन था एक मैक्सिला था ठीक है और एक स्फिनॉइड बोन था ठीक which one was the fourth bone so secondly some students have told that it was related to CNS the cranial nerve related to CNS now cranial nerve which is directly related to CNS should be optic nerve because optic nerve we only call it as nerve right it is the extension of the CNS if CNS is there then we can see that we have the lesser wing and just medial to the lesser wing in the sphenoid bone that we can think of nerve of CNS most likely CNS nerve if they are saying then we may think of 2 if not 2 then we can also think of 1 it is related to forebrain part cribriform plate was there if cribriform plate is also there one was from base of skull temporal bone petrous part yes temporal bone का petrous part है ठीक है fourth bone was cribriform plate which one was the fourth bone cribriform facial nerve तो temporal bone petrous part में आएगा ना yes correct what was the question cranial nerve तो इनसे पास होगा फिर सब multiple answer हो जाएगा it was multiple answer type what was the language of the question like multiple choice था single best था what was the language see temporal bone you are saying that can be answered cribriform plate that can be answered because cribriform plate will allow cranial nerve 1 to pass if it is a multiple type then we can consider all this option not multiple you are saying not multiple means it has to be chosen single best answer if you are saying which bone is related to cranial nerves my dear friends तो पेट्रस पार्ट भी तो रिलेटेड है ना यहाँ से तो 7th नर्व एंड 8th नर्व नहीं पास करेंगे इंटरनल कास्टिक मीटस से राइट रिलेटेड तो ये भी है मैक्सिला का पार्ट यहाँ पे फोरामेन होता है दैट मैक्सिलरी नर्व विल कंटिन्यू हियर it contains the word was it contains nerve related to CNS only so CNS तो फिर most likely CNS first with respect to CNS direct extension of the CNS is the optic nerve that should be the best answer best possible but अगर नहीं है then we can choose this also but optic canal तो था वहां पे ना alright if CNS word was specifically given then I'll say my answer will be extension of the CNS is the cranial nerve 2 okay And if it is not there, like better answer than 1. Okay, otherwise 1 is also related to forebrain, even though it's not extension of the CNS as such. Okay, वो है तो पेरिफेरल का ही भाग ना, CNS का नहीं है. तो CNS का अगर क्वेश्चन स्पेसिफिकली पूछा था तो cranial nerve 2 should be the answer. ठीक है, if they are generalized cranial nerves they are asking, then all can be answered ना. If there somehow CNS word was given, as you are telling, some other students have also told me in the messages कि part of CNS लिखा है तो 100% वो 2 ही है, cranial nerve 2. cranial nerve 1 4 brain से related है, but वो CNS नहीं है. Okay, 2 is definite better answer. यहाँ पे 2 के respect में चलेंगे. तो one image was remaining. Okay, this was the basic recall which I have got, and certain changes are there which I will be looking into it, and after that final recall will make. Okay, chalo, till that time now chill and relax little bit, and then again start. Don't take too much lamba break. Okay, and God bless you all. Thank you.
Okay. Hello friends, welcome to this session where we will be quickly talking about the biochemistry questions which have been asked in the INICET exam, and this is based on the recall sent by you guys only. So let's quickly take a look at the questions which have been presented in the exam. One question for which the first question for which I did not get the options is the anion gap metabolic acidosis, but this is an important and very repeatedly asked question, so I thought I'll just tell you about this. When you talk about metabolic acidosis, you can have the high anion gap metabolic acidosis and the normal anion gap metabolic acidosis. For normal anion gap metabolic acidosis, you have the two very important conditions. One is the diarrhea, and second is the renal tubular acidosis. Most of the other metabolic acidosis will have the high anion gap, and for this you commonly use the mnemonic mud piles. So I'm not sure what were the options here. So which of the following is true? Very good. Starvation, decay. Okay, so very quickly I'll tell you about this. This is the methanol toxicity. Then you have uremia. About uremia, you have to keep in mind whether it is acute or the chronic kidney disease. Any of them is going to have the okay. Regarding vomiting, please note, one of you have said that one of the options was vomiting. Regarding vomiting, please note, you are going to have alkalosis here. In vomiting, you are going to have alkalosis. All right. Then DKA stands for diabetic ketoacidosis and ketosis of other causes, which include the starvation and alcohol intoxication. These are the three causes for ketoacidosis: diabetes, diabetic ketoacidosis, the starvation, and alcohol intoxication. These will cause the ketoacidosis to happen. P stands for paracetamol and paraldehyde. I stands for isoniazid and iron. And you can also add here inborn errors of metabolism. In inborn errors of metabolism, the anions are being produced, so there also you'll have the high anion gap metabolic acidosis. Okay, and L is for lactic acidosis, E is for ethanol toxicity, S is for salicylates, aspirin, etc. All right, so these are the important high anion gap metabolic acidosis. Like you have said in the question, the first two, the starvation and DKA should be our correct answers. Starvation and DKA should be our correct answers. So the question as per the feedback should be, which of the following result in the high anion gap metabolic acidosis? You had option 1, 2 and 3, or which of the following is not causing the high anion gap metabolic acidosis? And options were vomiting, diarrhea, vomiting, starvation, and decay. Starvation and decay will cause the vomiting, will cause the alkalosis. Okay,
Then you had a question where they had shown two images, hydroxyquinone getting converted to xanthuronic acid. So image was showing the conversion of hydroxyquinone to xanthuronic acid, which is coming in the urine, and it is due to which vitamin deficiency. So in this case, you have to remember in B6 pyridoxal phosphate deficiency, you have the three characteristic urinary findings which you must remember. One is the xanthuronic aciduria, second is the oxaluria, third is the homocystinuria. Along with this, you are also going to have the sideroblastic anemia and peripheral neuropathy. These are the characteristic features of vitamin B6 deficiency. Most commonly it is iatrogenic due to drugs. Classically it used to be due to isoniazid, but a lot of other drugs are also involved in the metabolism of vitamin B6. Alright. So normally what happens in the quinine pathway, this B6 is required for the conversion of hydroxyquinone to the B3 in the form of NAD. Alright, so when B6 is not there, this step gets blocked. The alternate metabolite which is produced is the xanthuronic acid. The alternate metabolite is the xanthuronic acid, which will appear in the urine. Okay, very good. Pramod has mentioned the same thing. If at any point you have some additional points to add regarding the question that I'm showing you, please let us know so that I can tell all of you whether about those points, and we can also put it in the final question that we'll put on the website. All right. So there was a question talking about a female where the anemia picture was given: low hemoglobin, easy fatigability, some peripheral neuropathy matching the upper motor neuron symptoms. And the question says that she was treated with folate supplementation, anemia improved, but neurological symptoms worsened. Which of the following is most probable reason for her condition? Now, please remember, this is a very, very important repeat question. However, in the previous time when this question was asked, they had mentioned the details that folate therapy causes the use of B12 stores, which aggravates the neurological symptoms. This time, as per your feedback, this point was not mentioned. What was mentioned was the folate trap. The term which was written in the question was the folate trap. Is this correct? Is this point correct? The detail about folate therapy causing the aggravation of symptoms was not mentioned, but rather the term folate trap was used in the option. So this is the correct option. Folate will get absorbed. Unmasking pyridoxine deficiency is not related, and deficiency of folate reductase this is not associated with the CNS problem. So folate trap was in the option, because of which what is happening, that whatever B12 is there, it is getting used towards the recycling of B9, and it cannot be utilized for the neurological purposes where the myelin protein requires the B12. Okay, so because of which the neurological features will get aggravated. So remember, in B12 deficiency you will have features of B9 deficiency. What are the features of B9 deficiency? That is megaloblastic anemia plus increased homocystinemia and homocystinuria. Along with the features of B9 deficiency, you will have neurological features present as SACD or SCD. SACD means subacute combined degeneration of the cord, and along with this you have the methyl malonic aciduria. So all features of B9 deficiency along with the additional features of SSCD and methylmalonic aciduria will indicate B12 deficiency. In B9 you will have megaloblastic anemia with homocystinemia and homocystinuria, but the other features will not be there. Neurological features will not be there. Methylmalonic acid levels will be normal. Okay, great. Then the next question that we had was, which of the enzyme defect will lead to increasing 2,3-BPG and low glucose in vitro? Your options were as per feedback: pyruvate kinase, phosphoglycerate kinase, the G6PD, and the hexokinase. These were the options. Now the main problem here is between the first two options. Pyruvate kinase will also cause increased 2,3-BPG. Phosphoglycerate kinase deficiency will also cause the increase in the 2,3-BPG. but there is a small problem when the phosphoglycerate kinase is deficient. All right, when the phosphoglycerate kinase is deficient, in that case the gluconeogenesis will get affected, because the phosphoglycerate kinase is the reversible, it is catalyzing the reversible reaction, which is also a part of gluconeogenesis, right? So when the phosphoglycerate kinase is deficient, in that case gluconeogenesis will get affected, blood glucose levels will tend to be normal, whereas in both pyruvate kinase and phosphoglycerate kinase the 2,3 bpg levels will be higher. There's a block in glycolysis, so some of it at the level of the 1,3 bpg will be diverted towards the Rappaport Lubering shunt. So normally you have 1,3 bpg, from here you get the 3 phosphoglycerate, and downwards in the pathway you get the pyruvate, where the before in the preceding reaction pyruvate kinase is acting. So if there is block here, or if there is a block here, in both the cases the 1,3 bpg will build up, and 1,3 bpg will get diverted towards the synthesis of 2,3 bpg. So in both the cases the 2,3 pg will be elevated, but the 3-phosphoglycerate kinase is catalyzing the reversible reaction, which is part of gluconeogenesis. All right, so here your answer should be phosphoglycerate kinase, not pyruvate kinase. Pyruvate kinase is catalyzing the irreversible reaction. Only one option choose karna tha, sir. Very good. The answer is phosphoglycerate kinase. That's what I'm telling you. Answer is the phosphoglycerate kinase. Pyruvate kinase is catalyzing the irreversible reaction, so it will not cause blockage, will not cause the decrease in glucose levels. All right, so here answer is phosphoglycerate kinase. Okay, I think graph of this type was shown. Probably it was hand-drawn graph. I'm not sure. If you can give me some feedback regarding the graph, what type of graph was there? Okay, what type of graph was there? I think what I could get from the feedback, something similar to this was there. And this is the classical graph for oral glucose tolerance test. Nowadays we don't use this expanded OGT. We normally do the mini OGTT, where you take only 2 samples, fasting and the 2-hour sample after the oral intake of 75 gram of anhydrous glucose, right? But the original OGTT includes 7 samples at every half hour till 3 hours. So you get 7 samples, 0, half, 1, 2, it was 1, 1.5, 2, 2.5, 3, total 7 samples. You take both blood sample as well as urine sample over a gap. Okay, multiple graphs to be chosen for DM. Very good. So you can see 2 things to keep in mind. First is the cutoff at fasting, and here the value should be less than 126. 126 is the diagnostic cutoff for diabetes mellitus at fasting blood glucose. So anything which is above 126 will be diabetes mellitus. Second parameter should be at 2 hours. At 2 hours, anything which is more than 200 milligram percent. Wonderful. Exact picture but hand drawn. Very good. Okay, so you have to look at 2 parameters. One is parameter is at 0 hour, that is fasting sample. Second parameter you have to look at 2 hour after the intake of 75 gram of anhydrous glucose. At 0 hour value it should be less than 126. Anything above 126 is diabetes. Similarly at 2 hour, anything above 200 will be diabetes. So in the given options, only the top 2 graphs are indicating diabetes mellitus. Okay, the others have a lot of other variations, initial stages, some other complications, those things are there, but they are not related to diabetes mellitus. If you look at the red one at the bottom, this is the normal graph, and in some cases if there is some initial pre-kidney condition, in that case you can get the renal glucosuria even at normal values. We know that the renal threshold is 180 milligram percent. Normally it should, the glucose in urine should not come when the values are less than 180 milligram percent, but in the initial stages of renal disorder you can have the renal glucosuria. Okay, then in some individuals there is a transient shoot up in the half an hour value and 1 hour value beyond the renal threshold. So this is you can think about it as a pre-diabetes state. In pre-diabetes state where there is some level of insulin resistance or defect in the insulin release, so that the spike values at half hour, 1 hour in the fed state is crossing the renal threshold, which is 180 milligram percent. In normal individual, 180 milligram percent threshold will not be crossed. Insulin will make sure that the renal threshold is not breached. So if you see a peak at half hour or 1 hour which is crossing 180 milligram percent, then it is the pre-diabetes. So these individuals are likely to develop diabetes. Okay. All right. So these are the factors when you look at the OGTT graph you have to keep in mind. All right. So last and second last, the top two graphs are indicating the diabetes mellitus. Thank you. Okay, then we had a question indicating the features of von Gerke disease. In von Gerke disease, the points you have to keep in mind is severe hypoglycemia, right? First thing is severe hypoglycemia, and very commonly you will have the fainting episodes. Very commonly you will have the fainting episodes. So all right, it's very commonly you'll have fainting episodes. These patients may also present with increased uric acid, hyperuricemia is there, and the organomegaly in in this case is entirely different from other conditions. Here you have liver and kidney enlargement. Normally, what you expect, liver and muscle enlargement in glycogen storage disorder, but in this case you have the liver and kidney enlargement. All right, so a very different presentation in terms of organomegaly. And one characteristic feature which you might find mentioned in the question is doll-like fishes. What do you mean by doll-like fishes? This is very interesting. See, if you look at older style dolls, the face is very round. From there we get the term doll-like fishes. In a normal individual, a normal child, you can see some bony provenance. But in a chubby patient, in a chubby child where there is a lot of fat around the face, it will appear round. They're so chubby, they you just feel like pulling their cheeks apart, right? But in this case, in what happens in von Gerke's disease, the child becomes irritable in between the meals or becomes lethargic. So the parents have learned to feed the child frequently. The fallout is when the child is feeding frequently, there is a lot of buildup of the lipid stores in the body getting deposited all over the body. So the whole face looks like a round structure. So we call it the doll-like fishes. So in von Gerke, there is excess formation of lipids if the child is being fed frequently. So they will have the doll-like fishes. So this is a combination. This is a combination question with clinical scenario. Okay, okay. All right. So these are all from your feedback only. These questions we've got from you and your friends only in our different groups, and that is how we have been able to collect this. All right. So in this case, the clinical feature of von Gerke's is given, and the most common symptom is the hypoglycemia. Most common symptom is the hypoglycemia. About von Gerke's disease, what you have to remember, the enzyme deficiency is the glucose 6 phosphatase. Glucose 6 phosphatase is used in two different pathways. One is the glycogenolysis, and second is the gluconeogenesis. One is the gluconeogenesis. So because both the pathways which are responsible for maintaining the blood glucose level, both the pathways are getting depressed, and therefore blood glucose levels will fall. The most common feature will be the hypoglycemia. So I think there was some tussle between the friends that whether it was most common or most specific. Okay, but ultimately the friends, a lot of people agreed that yes, it was most common. So when it is most common, it will be the hypoglycemia. Okay, if it says most specific, then we will go with the kidney enlargement. Kidney enlargement is typical for von Gerke's in the different GSDs along with the hyperuricemia. All right. Okay, Shali. So I'm happy that you are able to identify these questions as they had appeared in the exam. Okay. So moving on to, okay, in this question, your answer should be the fasting hypoglycemia as the most common feature. Most common feature. Okay. glycogen is increased, ketosis may or may not be there. Ketosis is a common feature of all the glycogen storage disorders, but it is a fallout of hypoglycemia. And hypercholesterolemia is again a non-specific feature. It is again a fallout of the hypoglycemia. Okay, then there was another question where they had described the presentation that a person from a train or some region is there, some disease is there, and then he's having features hemolysis, and it was mentioned that G6PD deficiency is suspected. G6PD deficiency is suspected, and then the question was which are the features of HMP shunt which is related to the G6PD deficiency. There was okay. The lab indicated all symptoms von Gerke's child was given the question. Yeah, that's what I told you, that it was describing the clinical features of a von Gerke's patient. Okay, then the next question is where they were describing a clinical scenario. A person having the specific inheritance due to some illness is taking some treatment and now is having hemolytic episode where the G6PD deficiency is suspected. Okay, please correct me if there is any mistake. All right, and then the features of HMP shunt were mentioned. You have to identify which one is which combination is the correct feature of the HMP shunt. All right. Okay, so as you know, the HMP shunt is one of the pathways where there is no ATP synthesis or utilization. This is one of the only pathways which is ATP neutral. It doesn't touch ATP at all. So no ATP production is correct. It produces ribose 5-phosphate as an intermediate, but it produces the NADPH and it utilizes the oxygen. So NADPH is produced, not NAD. O2 is not produced, it is utilized. So only one part is correct. So this option is not correct. Transketolase, which is present in one of the reactions, requires thymine in the form of thymine pyrophosphate. This is correct. Non-oxidative phase is reversible. This is also correct. We have two phases in the HMP shunt: the oxidative phase and the non-oxidative phase. Oxidative phase is irreversible. This is where you are going to get the NADPH, and non-oxidative phase is reversible. This is where you get the ribose 5-phosphate. Okay, so 1, 3 and 4 are correct. 1, 3 and 4 are correct. All right. So as per the given question and given options, no ATP production in HMP shunt correct. Transketolase in the reaction requires thymine is correct. Non-oxidative phase is reversible is also correct. All right. Thank you. Okay, very happy to know that it was the same question in the exam. All right, so for this question, I'm not very sure about the statement. Even the students who gave the question were not very sure. But the summary of the question was they're asking about TCA cycle and which intermediate serves as the main substrate of the fatty acid synthesis. Please let me know if there was some other point mentioned in this question. All right, so what you have to remember, the main immediate, which intermediate serves as the main substrate for fatty acid synthesis. The TCA cycle is in mitochondria. The fatty acid synthesis is in the cytoplasm. So something has to go. Something. Okay, succinate was there. So should I replace oxaloacetate with succinate? Okay. Okay, succinate was there. Okay, succinate was there. So please note, something has to go from mitochondria to cytoplasm so that the fatty acid synthesis can take place, because fatty acid synthesis is taking place in the cytoplasm. Now there are two important, rather three transporters. One transporter is for malate. One transporter is for oxaloacetate, but as I can see that oxaloacetate was not there in the option, so let's forget it. Then one option, one of you is saying is fumarate. So fumarate generally doesn't travel. So malate can travel and citrate can travel. For citrate, we have a dedicated transporter. Fumarate instead of citrate. Citrate was not there in the option. Citrate should be there because citrate is the option answer, because citrate is the one which goes outside. Dr. Prasanna, we cannot have no citrate in the option because citrate is the answer. The citrate is the intermediate from the from the TCA cycle, which is going outside from mitochondria through the dedicated tricarboxylic acid transporter, also commonly known as a citrate transporter. Okay, once it reaches the cytoplasm, in the cytoplasm it is acted upon by citrate lyase. Okay, it is very much possible that oxaloacetate or alpha ketoglutarate were not there. I know that, but malate and citrate, these were two where most of the students agreed that these two were there in the option, because these are the two which will travel through the shuttle. So you have to choose between the two which will participate. And now I'm telling you, citrate is acted upon by citrate lyase, broken down into oxaloacetate plus acetyl coenzyme A. This oxaloacetate goes back to the mitochondria. Yes, yes. So oxaloacetate will go back in the mitochondria, and this acetyl coenzyme is more commonly used for fatty acid synthesis. Depending on requirement of the tissue, it may also be used for cholesterol synthesis. Please remember, cholesterol synthesis also occurs in the cytoplasm. Okay, so this is how the carbohydrates are channeled first to the mitochondria. Depending on how much of the carbohydrate is getting metabolized, if the excess is there, then only this transport happens, because the tricarboxylic acid transporter has a very low affinity for citrate. So until unless the concentration of citrate in the mitochondria is very very high, it will not go through the TCA transporter. So if you have lots of carbohydrate, means glucose getting metabolized, resulting in lots of citrate being formed in the mitochondria, only then this fatty acid synthesis is going to take place. Malate is not the correct answer. Citrate will be the correct answer. Citrate goes out and it splits into oxaloacetate and acetyl coenzyme. Acetyl coenzyme is then used for fatty acid synthesis in the cytoplasm. Oxaloacetate comes back to the mitochondria and it can re-participate in the Krebs cycle. All right. All right, so in this case, our answer is citrate. Our answer for this question is citrate. Don't worry if you made one mistake, doesn't matter. But broadly, you should be having a good return on your answers. Okay, now next question is Gauchers. Next question is Gauchers. Gauchers is one of the very commonly repeated questions, so I'm sure you would not have much problem here. Sometimes it comes with the image where they give you the crumpled or wrinkled tissue per appearance, the H&E stain showing that particular image is there very commonly. Sometimes they can give you the clinical picture and then ask you about the diagnosis. In clinical picture, you should remember presentation with abdominal pain and bone pain, also known as the bone crisis. Abdominal pain or bone pain, also known as the bone crisis, is there. And the hepatosplenomegaly is one of the important features, and uh, and inability to good development is not there, anemia etc can be there, those features can be mentioned. And then they'll mention bone marrow biopsy shows the presence of crumpled or wrinkled tissue per appearance, or the following image is seen on bone marrow biopsy. Okay, so crumpled paper appearance for the Gaucher cell, crumpled paper appearance for Gaucher cell, and glucocerebrosidase deficiency is the genetic defect. Okay, remember Gaucher's is the most common lysosomal storage disorder, and this is the first condition for which enzyme replacement therapy was made available. Enzyme replacement therapy was made available, the first condition for which enzyme replacement therapy was made available. So among the given options, foam cell sphingomyelinase defect, these are related to the Niemann-Pick disease. Presence of foam cell and sphingomyelinase defect is related to the Niemann-Pick disease. In Niemann-Pick disease, what you are having is the accumulation of sphingomyelin. In all other sphingolipidosis, you have accumulation of the glycolipid. Only in the Niemann-Pick disease, you have the accumulation of the sphingophospholipid. In all others, you have the accumulation of the sphingoglycolipid. So here option A and C, crumpled paper appearance and glucocerebrosidase deficiency. All right, so this should be your option which you should have corrected, option A and C. The order of the options may be different obviously in your question. I am not saying specifically A and C, but crumpled paper appearance and glucocerebrosidase deficiency should be the ones you should have selected. Okay. Then there was one complicated question about oxidation, beta oxidation of fatty acids. Here would need a little bit of help from you because the statements were pretty long as told by a lot of your friends. So if there are additional comments for any of the options, I would love to hear from you. So if anyone can tell me any specific changes in the options before I answer this question. So the crux was you have to mark the incorrect statement for beta oxidation of fatty acids or something of that order, and you had 4 lengthy statements. Any comments on the options? Any comments on the options for this particular question related to the beta oxidation of fatty acids? Okay, so option 1 is CPT1. CPT1 is the carnitine palmitoyl transferase, also known as the carnitine acyl transferase. 2 isoenzymes are there, isoenzyme 1 and 2. The isoenzyme 1 is present in the outer mitochondrial membrane, isoenzyme 2 is present in the inner mitochondrial membrane. Okay, ATP is hydrolyzed in the process, coenzyme A, HCPT1 and present different sites of mitochondrial membrane. Okay, in different mitochondrial membrane, like I told you, outer mitochondrial membrane, inner mitochondrial membrane. Still this statement is correct. CoA SH was there in the option. Okay, see, ATP is hydrolyzed in the process or coenzyme A is added. This is part of activation part. This is not part of the beta oxidation per se. This is not part of beta oxidation per se, but hydrolysis and the addition of coenzyme A happens with fatty acid, whereby fatty acid is converted into acyl coenzyme A, and the ATP is also used up. 2 ATP converted into ATP converted into AMP. Okay, ATP converted to AMP, so you count it as 2 ATP equivalent, and the reaction is catalyzed by acyl coenzyme A synthetase. Acyl coenzyme synthetase will catalyze this reaction. Okay, so acyl coenzyme A is getting incorporated, ATP is also used up, 2 ATP equivalent are used up here, and but this is not part of the beta oxidation. This is part of activation which occurs in all the oxidations, whether it is alpha oxidation or beta oxidation or omega oxidation. This activation is common to all of them. The transport part for beta oxidation is very specific, where you use the acyl carnitine, and it is not seen in alpha and omega oxidation. So the transport part where CPT1 and 2 are involved is common. CO is released in cytosol during formation of acyl carnitine. This is this should be this is correct, because when you are releasing the acyl coenzyme and converting into acyl carnitine, this is, I would say, plus minus, because it is happening in the intermembranous space, so it is slightly ambiguous. See, I've written this CoA-SH. It is commonly written as CoA-SH, indicating that sulfur is there at the end. Carnitine is released on the matrix side. This is also correct. So if you have to choose the best possible answer which is incorrect, I would go for the ATP is hydrolyzed in the process, because it is a part of the activation. It is part of activation. It is not involved in transport or the actual reactions of the beta oxidation. So slightly tricky question, but this is what we could get as per the statements. Maybe there was some more clear cut statement, but I have not been able to get that. If you can help me with some specific mentions. Dr. Divya's comment I have taken, and I've already elaborated that the mitochondrial membrane has 2 layers. One is the outer mitochondrial membrane and second is the inner mitochondrial membrane. Outer one will have CPT1, the inner one will have the CPT2. So option 1 is still correct. Okay, I think I've given you all the information related to the beta oxidation and transport, so that should suffice. And the given options, the ATP is hydrolyzed would be preferably the best possible answer. If there are some other options, then the answer might change. We had this question, something similar to this last year also in the INICET exam, where they're given you 4 amino acids and 4 products coming from amino acids, and then you have to choose the specific matching, and that you had to do from where the special products of amino acid are coming. So this is one thing which we spend a lot of time in class talking about, the special products of amino acid. Okay, so for tyrosine, you have to remember it should be the thyroxine hormones T3 and T4. Along with this, you get the catecholamines. Catecholamines means dopamine, norepinephrine, epinephrine, and you get the melanin from tyrosine. These are what you get. For tryptophan, you get melatonin, serotonin, and B3, that is niacin. For glycine, you get creatine. Glycine is also involved in formation of heme. It is also involved in formation of the purine ring. It is also involved in the xenobiotic metabolism. It is used to convert the insoluble substances into the water soluble conjugates. Option was CPT1 and 2 are in same mitochondrial membrane. Okay, if Dr. Manush Raval has said that option 1 was CPT1 and 2 are in the same mitochondrial membrane, in that case it will become the wrong option. CPT1 is present in outer mitochondrial membrane and CPT2 is present in the inner mitochondrial membrane. If one of the options was that CPT1 and 2 are present in the same mitochondrial membrane, then that will be the wrong answer. That will be the wrong answer. Please keep in mind, I told you CPT1 part of it is present in the outer mitochondrial membrane, whereas CPT2 is present in the inner mitochondrial membrane. Okay, please keep that in mind. Thank you, Dr. Manush. Thank you very much for your feedback, so that we have been able to rectify our question. Coming back to this question, cysteine is used in taurine. Okay, glycine is also used in the formation of glutathione. Glutathione is having glutamate, cysteine, and glycine. So cysteine in taurine as well as glutathione. There are some other products where the sulfur containing amino acid may be present, so cysteine will be involved there also. So fortunately, I've written the options in front of each of them. So as per the given presentation, your option A should be correct. Tyrosine will give rise to the thyroxine hormones. Tryptophan will give rise to melatonin. Glycine will participate in the synthesis of creatine, and cysteine will participate in the formation of a taurine. All right. If there are any other options or any other changes in these options, please let me know so that we can make corrections here. Okay, so I go to next question. Here again, there was a little bit of clinical presentation in the question. See, I've told you both the points, Dr. Samta. I've told you both the points. Depending on what is given the option, one of the membranes will contain the CPT1, the other one will contain the CPT2. So depending on what is mentioned in the question, if question says within the same membrane, then it is wrong. If it is saying that in different mitochondrial membrane, then it is a correct statement. Okay, so we had a clinical case where they mentioned the arthritis patient synovial tissue is showing increased expression. So there is no need to focus on what is being expressed, but mainly we have to focus on there is increased expression. So increased expression can be due to epigenetic changes. Two very important epigenetic changes which can cause increased expression. One is methylation of the DNA, and second is acetylation of histones. These will have categorical result as increase in expression. For the other covalent changes of histone, the results are variable, but acetylation of histone is going to have a definite increase in the expression, along with the methylation of DNA is going to result in decrease in expression. So these are two results which are very categorical. Acetylation will cause increase and methylation of DNA will cause decrease in the expression. So if you do the opposite of methylation, that is in this case inhibition of DNA methylation, activation of DNA methylation will cause down expression. Activation of histone deacetylation will also cause down expression. Inhibition of histone acetylation will also cause down regulation. So up regulation, increased expression will only be there when you inhibit the DNA methylation, because DNA methylation is going to cause the down regulation of expression. Okay, so among the given options, if these were the correct options which are there, then the best answer will be inhibition of DNA methylation. Please remember the concept: methylation of DNA, decreased expression; acetylation of histone, increased expression. And these are done by the DNA methylase, and then you have the histone acetylase and the histone deacetylase enzymes are there. Okay, thank you, Dr. Somta. So in that case, option B should be the correct answer: inhibition of the DNA methylation. I understand that it is confusing because they've written the options like that, but the take home message should be here: methylation of DNA, decrease expression; acetylation of histone will have increased expression. These are the two take home messages. So you have to see in which of them increased expression will be enabled. Okay, methylation of DNA will cause decrease in expression, acetylation of histone will cause increase in expression. So if you prevent methylation, then down regulation will not happen, so there will be increased expression. All right. Okay, okay, I understand. Now, again, in this question, I have a lot of trouble in getting the correct statement. So, if anybody has some feedback for this question, I would be very, very happy to take your inputs. The cancer cell shows increased length of a specific RNA transcript or fragment. I'm not happy with this statement when compared to normal cells. The most likely reason for this, I can give the best possible answer for what I got, but I just want to know that whether this was the statement or there was something else, because not I'm not very happy with the statement that increase in length of RNA transcript or fragment. So if anybody is able to give me some feedback on this part, I would be very, very happy to take that comment on record. um, any comment. See, in all these cases, what is happening, there is gene amplification, there is increase in gene silencing, there is decrease in the expression of gene. Polyadenylation means there is the poly A tail which is getting enhanced. Okay, so in none of these the RNA transcript or fragment is getting increased. Only way in which it can get increased among the given options is alternative RNA splicing. Okay, so if you are happy with the question, I'll go with it. So in the given options, the only way by which the RNA transcript in comparison to normal cells will be showing increase in length is the alternative splicing. So if you know a little bit about the splicing, what happens is you have the hnRNA like this. This is the structure of hnRNA, where you have both exon and the intron. These thin lines are the introns, the boxes are the exons. So what happens? There is splicing. In splicing, we remove the introns and join together the exons. But after splicing, it is not necessary that all the exons will come together. Yes, I'll come to that. Alternative sequence of RNA fragment. There was a question, there was a word alternative sequence instead of RNA fragment. Splicing decreases the length. Okay, okay, I'll tell you. So see what happens. So what happens is the gene amplification cannot change the size, gene silencing cannot change the size. Only way by which the changes can happen is alternative RNA splicing or the polyadenylation. Now about splicing, what you have to understand, that although you can see exons 1 2 3 4 in this image, it is not necessary that after splicing all the exons will come together. This is not necessary. It is possible that the normal transcript only has three of them. It is possible, very much possible, that the normal transcript, that the normal messenger RNA which is being formed has only three of them. And in cancer cells, the splicing gets modified that now all the four exons are getting incorporated. That is one possibility. Second possibility is the adenylation site. Okay, but I'm not sure that they had mentioned adenylation site. There can be change in adenylation site during the process of post transcriptional modification. Okay, okay, alternate sequence. Okay, so in that case, an alternate sequence instead of RNA fragment. See, when it's saying alternate sequence, okay, so alternate sequence is very much possible due to alternative splicing. If it says sequence, then we are very sure that answer should be alternative RNA splicing, because when you say alternative sequence, then maybe the normal combination is 1 to 4, and now the combination in the cancer cell becomes 134 or the 234. So in that case, the result of the translation will be entirely different. The transcript sequence will also be different. Okay, so alternative splicing is one of the common sources of variation. If you remember, the Human Genome Project gives us 20,500 genes. From these 20,500 genes, you are supposed to derive more than 1 million proteins. The biggest source for this increase in variation is the variation in post transcriptional modification via the splicing. So if the question mentions that alternate sequence of RNA is achieved in the cancer cell, then definitely it is alternative RNA splicing. Okay, thank you very much for your feedback. So that helps to simplify our selection of the answer. Thank you very much. Okay, so this is not a pure biochemistry question. There's an overlap with microbiology to some extent. Please correct me if there is some difference in the question on your screen. So the question mentioned an elongation factor 2 toxin. Is that right? Elongation factor 2 toxin. Now, so you have to know that elongation factor 2 toxin is the diphtheria toxin. It is the diphtheria toxin. Okay, so in diphtheria toxin, the points you have to remember is it is an exotoxin produced by Corynebacterium which selection. Okay, it was image based. Okay, image based. Okay, so if it is showing the elongation factor 2, Pramod, which selection are you talking about? Your selection will happen, don't worry. One or two questions here and there will not make much effort, because the ones where tricky question is there, a large number of students are likely to make mistakes, so don't worry about that. Problem will be there when you make mistakes in the simple questions. Making mistake in tricky question is okay, because majority of the students will stumble there. But when you make mistakes at the simple normal questions, that is when you fall behind the race. So your aim has to be mark the answers correctly, carefully in the simple straightforward questions. Some things are out of your control, you can't do much about it, so tricky questions are one of those. But wherever you can, in the simple questions, you have to make your best effort and get the correct answers. That is the way for the selection. Okay, so exotoxin produced by Corynebacterium diphtheriae. What you have to understand here, that the gene for the diphtheria toxin, that is the tox gene, is not present on the genome of Corynebacterium diphtheria. It is coming from the phage, bacteriophage. When it infects the bacteria, that is when this gene is getting expressed. So the lysogenic phage must be present before the toxin can be produced. Please remember, the lysogenic phage must be present before the toxin can be produced. And what is the action of this toxin? This toxin, what does it do? It targets the elongation factor 2. It causes the ADP ribosylation at the amino acid diphtamide. It causes the ADP ribosylation at amino acid diphtamide. So these statements, these points, ADP ribosylation of elongation factor 2 at diphtamide, have been asked separately in the previous years. Okay, so in this case, the most lethal toxin is not the correct option for diphtheria toxin. There are more lethal toxins than diphtheria toxin. It is toxic, it is lethal, but it is not the most lethal toxin. It is not the most lethal toxin. Okay, we have maybe one or two more questions. M13 bacteriophage vector was mentioned in one of the questions. And it was mentioned that is used in microbiology for various specific functions which was described in the question. And one part was written that it works through expression of the inserted gene fragment. It works through expression of the inserted gene fragment. Okay, so if you have read the lac operon model and how it is modified for use in genetic engineering, we regularly discuss this in our class. So there we have seen how the lac operon model is undergoing the transformation. It is undergoing the transformation, and whereby the product can be generated. However, here the better term which is used in the literature is the phage display or the phage expression. Phage display or phage expression is the better term which is used, although the phenomena which is seen is the transformation. And if you recall, we identify the transformation with the help of the blue white screen. Blue white screen using colonies is used to identify the transformation in the lac operon model, where we use it for genetic engineering using the M13 vector model itself. The blue white screen and the lac operon model is a primitive model to do the genetic engineering for production of the gene related products in an artificial system. So in this given question, the best possible answer would be phage display, but please don't get disheartened if you did not mark this question wrong. This is a first time so much in detail, in depth, the question about the genetic engineering has been asked regarding the M13 bacteriophage, although it is a common model, but we don't expect them to ask this question from you in the PG entrance exam. This would be a good question for the super specialty exam, not for the PG entrance. So I'm not very happy with this question coming up in your PG entrance exam. This is definitely not on the level of the PG entrance. So please don't worry if you have marked this answer wrong. This is one of those 5-6 questions which you're not expected to answer. This is just to make sure that nobody scores 100% marks in the exam. So absolutely okay, not going to have any impact on your ranking if you have marked this question wrong. Please don't worry about this question at all. Okay, steps of PCR. This is one question. If you make a mistake, then you should catch hold of your ears and do 10 times sit-ups and sit down. Okay, because this is something where you cannot make a mistake. PCR is the very basic technique which you must be knowing. The three steps of PCR: the denaturation, annealing, and the extension. These are the 3 steps which you must be knowing in sequence. First, you separate the 2 strands of DNA, then you allow the primer to attach, that is anneal, and then you elongate or extend the primer. These are the 3 steps of one cycle of PCR. Before this, you have step 0, and after this you have step 4. Step 0 is the synthesis after the designing of the primer. So you first design the primer and then you synthesize the primer. That's step 0. Without that, PCR cannot be done. And once you have done, this is step 1, 2 and 3 makes up one cycle. Once you do 30 to 40 such cycles, then you go to step 4, which is the final elongation step. Step 1, 2 and 3 will have a time duration of 15 to 45 seconds. The final elongation step has a time duration of 5 to 10 minutes. All right. So this is about the polymerase chain reaction. Step 1, denaturation. Separate the 2 strands of DNA. Then you allow the primer to attach, and then you do the elongation. Okay, so that is all from my side for biochemistry. Thank you very much for listening, and I hope this discussion has helped you. Option was present. COVID-19 protein expression. Yes, COVID-19 protein expression term can very well be mentioned here, because this through expression of inserted gene, this term, this was used for the COVID-19 protein expression for the development of the antibody based kits and the vaccine as well. Protein COVID-19 mention is perfectly fine in that particular question. One, the cosmid formation can be there because the phage can be used. Phage from the phage plasmid can be used in the bacteriophage, and it will result in formation of cosmid. So take care, and very shortly the next session will start. And please, at this point, don't worry about what has happened in the exam. At this point, you can just listen to the different experts and get an idea about where you stand, how well you've performed, or whether you need to girdle up again. But this is not the time to worry. This is the time to just sit back, relax, and see how many questions you have been able to mark correctly, and then we'll see the result. See, this recall is very, very important, because we still have the NEET PG exam to go, and the question bank for both of them is same. So whatever mistakes you catch here, you have to make sure that you don't make those mistakes in the NEET PG exams. All right. So even if there is some decrease in performance here, it can help you to boost your preparation for the NEET PG exam. So very, very important to listen to other experts as well, and see what possible mistakes you would have made, or what are the pitfalls that other students might have made, and which you can avoid in the next exam. So take care and best of luck. Thank you very much.